Hello everyone. A very good evening to all of you. Am I clearly visible, audible to you guys? Is everything is smooth? If everything is good, can you give me a thumbs up in the chat box? If I'm clearly visible, audible, everything is good. So Sangeeta, Nitish, Osama, Arvind, any one of you? Got it, got it. Thank you, Arvind. Thank you, everyone. So I think we must start. Everything is good, right? So I welcome you all for today's session. A very good evening to all of you. I am Dr. Priyanka Sachdev here, and today we all are gathered here to continue the remarkable rapid revision on this beautiful platform. So we are going to continue the remarkable rapid revision of pathology. We have started pathology in the morning. In the morning, we have already covered most of the important topics of general pathology. Currently, I am going to start with hematology. So in rapidly, just in 1 hour or 1 hour 15 minutes, I am going to cover entire hematology in a fast manner. I'm going to give you the crisp topics on which there are high chances that you will get questions in your exam. And after that, immediately we will move on the systemic pathology. In systemic pathology, I'm going to cover all major systems and important topics in them. So I'm going to cover 9 to 10 systems, right? So, okay, without wasting any further time, let me start with hematology. In hematology, first I will be discussing anemias, and then I will be coming on the WBC disorders, that is leukemias and lymphomas. So, you know what is hematopoiesis? In the blood, human blood, how many types of cells we are having? We are having RBCs, we are having platelets, and we are having WBCs. WBCs are of two types, granulocytes and agranulocytes. Granulocytes are the WBCs which have granules in their cytoplasm. They are further of three types. Neutrophils having pink and purple granules. Basophils having black granules, dark blue or black. And eosinophils having red color granules. The brick red color granules. Agranulocytes don't have any granules. So there are two types of agranulocytes, monocytes and lymphocytes. So basically, I mean to say there are 5 types of WBCs, right? We will be coming on that. So you can see RBC, platelet and 5 type of WBC. Where all these are formed? It is present in the human blood, but where they are formed? They all formed inside in adult human, in me, you, all adults. It is forming in the bone marrow. So bone marrow. So formation of blood cells is known as hematopoiesis. The word hemato means blood cells and poiesis means its formation. So can you tell me the organ? Yeah, in adults I agree it's bone marrow. But in, in a fetus up to 10 week of gestation. So blood start forming in a fetus inside the uterus of the mother. In the fetus, from 2nd to 10th week of gestation, it is formed in the yolk sac. In the yolk sac. So yolk sac is the first organ inside which RBC, WBC and platelets are formed inside a fetus up to 10 weeks of gestation inside the uterus of the mother. It's very important MCQ. You have to learn, right? From 10th week till 24th week of gestation means 8 months. 8 months baby, right? Still it's intragestational I'm talking. I'm not talking about the live baby. Intragestational age I'm talking. So it takes place in the liver. Basically in the liver, and after that it takes place in the bone marrow. After that it takes place. So learn the 3 organs. First it's yolk sac, followed by liver, and followed by bone marrow. Followed by bone marrow. So inside the bone marrow, let me draw bone marrow. This is the bone marrow. The first cell which give rise to all the blood cell is hematopoietic stem cell. So this cell is hematopoietic stem cell. It gives rise to RBC, it gives rise to platelet, it gives rise to WBC. You can say hematopoietic stem cell is the father of all cells. It's a pluripotent cell. It differentiates into RBC, WBC as well as platelet. And this hematopoietic stem cell is CD34 positive. You have to learn the marker. The marker is very important. It's CD34 positive. So you can see the first cell is the hematopoietic stem cell from which RBCs are formed, from which platelets are formed, and from which the 5 type of WBCs are also formed. So this is about the hematopoiesis. Now here I am teaching you anemias. That's why I am more interested in formation of RBCs right now. I am not interested in formation of platelet and WBC right now. So first I will teach you how RBCs are formed from the hematopoietic stem cells. So this is the complete, it is not that from hematopoietic stem cells directly RBCs formed. There are so many intermediates you can see in the diagram. So first from the hematopoietic stem cell, pro-normoblast is formed. This is known as pro-erythroblast or pro-normoblast. Then it converts into early normoblast, then intermediate normoblast, then late normoblast, early, intermediate, late. Then it converts into reticulocyte. and finally RBC is formed, which comes in the blood. These all precursors are present in the bone marrow. You got my point? You got my point? So it is the hematopoietic stem cell which gave rise to pronormoblast, then early normoblast, intermediate normoblast, late normoblast, reticulocyte, and finally RBC is formed, which comes in the blood. You got my point? So these are the precursors of the RBC. Now what all important MCQs come here from the erythropoiesis? You must learn the other name of early, intermediate, and late normoblast. So other name of early normoblast is basophilic normoblast. Intermediate one is polychromatic normoblast. And late one is orthochromatic normoblast. You will say, ma'am, that we get confused how to learn these other names. So I'm having a mnemonic for that. You can learn the mnemonic BPO. BPO is early, intermediate, late. No, you will not forget. It's basophilic, polychromatic, orthochromatic. BPO, early, intermediate, late. So you may get questions on the other names of the early, intermediate, and late normoblast. The first question, right? And the second important questions on this series is that, can you tell me where the first time hemoglobin appears? Hemoglobin present, you can see this diagram. Can you see this diagram? I guess you can. This is pronormoblast. This is early, this is intermediate, this is late. And finally, it gives rise to reticulocyte, and finally, this is RBC. This RBC will come in the blood. So can you see the cytoplasm of all these cells? Look at the cytoplasm. Hemoglobin is present in the cytoplasm. So tell me the step at which first time hemoglobin appears. Hemoglobin is pink in color. You got my point? So can you see the sudden change in color here at this point? So the sudden change in color of the cytoplasm, it becomes pinkish little. At intermediate normoblast level, first time hemoglobin appears in the cytoplasm of RBC. It's very important PYQ MCQ. Intermediate normoblast, right? That is the first question. Second question, does RBC have nucleus? We all know, yes, RBC don't have nucleus. No, RBCs are non-nucleated cell. But the hematopoietic stem cell have nucleus. Here nucleus is present. So in this entire series, tell me the exact step at which nucleus is extruded out, at which the nucleus is thrown out of the cell. Can you tell me at exact stage? So it's late normoblast. Can you see here? At late normoblast, please appreciate, nucleus is thrown out. So nucleus, enucleation occurs. The nucleus is extruded out at late normoblast, and hemoglobin first time appears at intermediate normoblast. These are the two important MCQs which come in your exam from this series. Everyone give me a thumbs up. Are you people there? So you should understand it. Now about reticulocyte. Just precursor of RBC is reticulocyte. RBC से just पहले होता है reticulocyte. You got my point? So reticulocyte contain ribosomes and RNA inside it. It is also non-nucleated. The last two cells are non-nucleated, reticulocyte and RBC. So it contains RNA inside it. So can you tell me the name of the stains which is used for staining reticulocyte? Reticulocyte is always stained using a supravital stain. Supravital stain. Supravital stain is a stain which stain RNA. So since reticulocytes have RNA inside them, they will take the stain. There are two supravital stain. You must learn the names. It's very important. PYQ repeated multiple times. Supravital stain. The two supravital stain you must understand. It's new methylene blue and brilliant crescile blue. Both are blue. One is new methylene blue and one is brilliant crescile blue. Both are blue. And these both are supravital stain. They stain RNA present inside reticulocyte. So you can understand multiple MCQs can be asked on this point. Give me a thumbs up. You got my point. So can you see? This is a blood film. The first picture is stained using a Romanowski stain. You know, the normal Romanowski stain, that is Leishman stain, Jimsa stain. So here we cannot see reticulocyte very clear. This is a reticulocyte, but it's not very much different from the RBCs. We cannot differentiate it. But if you do the Romanowski, if you do the supravital stain here, you can see this is a reticulocyte, this is a reticulocyte. Inside the reticulocyte, I can see blue colored dots. Because reticulocyte have RNA inside it, RBC don't have RNA. So RBC will not take the supravital stain. Only reticulocyte will take the supravital stain. The supravital stain are two, methylene blue, new methylene blue and crescile blue. Give me a thumbs up, everyone. Jitne audience, utne thumbs up. Have you understood? So reticulocyte pe you get questions on the stain of the reticulocyte. Reticulocyte contain RNA. Name the stain, supravital stain. What is the principle? Supravital stain stains only RNA. That's why it stains only ribosomes, not RBC. So it is a specific stain for the ribosome. And it is of two types, methylene blue and brilliant crescile blue. That's it. Right? So, and Image-based question is also very common on this. You must be able to identify this image. This is the image of supravital stain, the greenish or bluish tinge. And inside that, you can see the RBCs also. I can see RBCs. But inside RBC, I cannot see the blue dots. But inside reticulocytes, I can appreciate the blue dots. You got my point? You got my point? Okay. We will be doing some polls, some PYQs or of fmge exam based on this concept. Then we will move to the next concept. Okay. So this is the first question in front of you. Can you tell me the correct answer? Any one of you? Can you tell me the correct answer? Can you tell me the common site of hematopoiesis in fetus? I am asking. I'm not asking in adult. Who is the first? Yes, yes. Very good, Vignesh. Very good. You all are right. Yes. So the first site is yolk sac, but it is not given in the options. So yolk sac is followed by liver. So I will go with liver. If yolk sac was there in the option, I will go with yolk sac also. But yolk sac is not given in the option. So we cannot leave the question in exam that yolk sac is not given. So I told you from 2 to 10 week of gestation, it's yolk sac. From 10 to 24 week of gestation, it's liver. And 24 week onwards, till death, it's bone marrow only, right? So in human, adult human, in me, you, we all are adults, of course. So inside us, it takes place in the bone marrow. But in fetal stage, it's in yolk sac and liver. So correct answer here is liver. Right, go with liver. So yes, you all are right. Very good. This is the next question in front of you. Can you tell me the correct answer? Progenitor hematopoietic stem cells originate in. Progenitor hematopoietic stem cells originate in. I'm asking about the stem cells. Progenitor stem cells. Hematopoietic stem cells are present in which organ? Of course, they are present in bone marrow. It's a very easy question and you all are right. Very good. So it's also a PYQ. Can you tell me the next question? Repeated many times in your exam. Which of the following surface glycoprotein is a marker of hematopoietic stem cell? Hematopoietic stem cell का marker बताओ. Is it CD22? Is it CD40? Is it CD15 or CD34? I told you specifically. Yes, yes. Very good, very good. You all are right. So the correct answer here is CD34. Right? Can we go ahead? Yes. Reticulocytes are stained by multiple time repeat PYQ. Multiple time. Are they stained by supravital stain or Prussian blue or HNE or reticulin stain? So most of the students get confused that reticulocytes are stained by reticulin stain. No, no, no. Reticulin stain is for fibrosis. It is for cirrhosis or fibrosis. No, it's not for reticulocyte. Reti dekhe confuse nahi hona hai. Yes, the supravital stain is the best stain. So correct answer here is A and you all are right. Right. So based on this concept, these many MCQs are already asked in your exam and new can be coming on any concept. Okay. So let's move ahead now. Let's move to the next concept. Can we go ahead? Are you people learning, enjoying? So, okay, let me come on the morphology of the RBC before teaching you the approach and classification of anemias. What is the shape of a RBC? If you look the RBC from front, it's circular. It's circular like a coin. Have you seen a coin? Sikke ke jaisa circular hai. But if you see from the side, so from the side, the coin is a homogeneously, flat, circular. But it's not flat, it's biconcave from the side view. So this is the side view of the same. This is the front view, this is the side view. So this is the shape of a RBC. From front, it's circular. And from the side view, it's biconcave. It's biconcave. If it is circular, you must tell me the diameter. The circle have a diameter, no? So diameter of a normal RBC is 7.5 micrometer. You have to learn that. 7.5 micrometer. So that is a normal RBC, right? That is about the size. What about the color? The color of a normal RBC. RBC don't have nucleus. So what is present inside the RBC? Inside the RBC, we have hemoglobin. We have hemoglobin inside the RBC. So hemoglobin is present at the periphery of the RBC, not at the center. So in a healthy human, in the RBC, which is 7.5 micrometer, the hemoglobin is present at the periphery. Peripheral 2/3 is colored. What I'm saying? Peripheral, I'm saying it again. Peripheral 2/3 is colored, but central 1/3 is empty. It is normal. Central 1/3 don't have hemoglobin. Central 1/3 is known as pellar. Pellar means it's empty. So what is the normal RBC? The normal RBC is circular. The diameter is 7.5 micrometer. The color, the peripheral 2/3 is filled with hemoglobin. Peripheral 2/3, it's colored. Right? But the central 1/3 is empty. It's known as pellar. So that's about normal. If you understood normal, don't forget this ratio. Peripheral 2/3 and central 1/3. It is normal in you, me, everyone who's not anemic. So we have this type of RBCs. That is the color of RBC. So if you understood the size and color of RBC, you may be able to understand the variations. Based on the size, RBC can be of 3 types. If RBC of normal size, 7.5 micrometer, it is known as, now the size in pathology is known as cytic. Cytic का मतलब होता है size. Pathology में the size is known as cytic. So if the size is normal, it's normocytic. Normal size, normocytic. If RBCs are bigger than 7.5 micrometer, they are known as macrocytic. Macrocyte, bigger, macro. And if they are smaller than 7.5, they are known as microcytic. So based on size, RBCs are of three types: normocytic, microcytic, macrocytic. Learn the thing that cytic means size. Cytic means size. You got it? Never forget. Cytic का मतलब होता है size. Now, the second thing. Okay, so this is the first thing you have learned. Now you will say, ma'am, we don't have a scale in a microscope. Just suppose I'm giving you a slide, a peripheral smear. I'm pricking my blood. I'm giving a needle prick here, taking my one drop of blood on a slide, making a smear, staining it and giving it to you and saying, you see my RBCs. See the size of my RBC and tell me whether my RBCs are normocytic, macrocytic or microcytic. Can you have a look in the microscope? You will say, of course, ma'am, we will have a look and we will tell you what is the size of your RBC. So you are putting the slide in your microscope in your laboratory, but microscopes, you don't measure each and every RBC that, ma'am, RBCs are 7.5 micrometer or lesser or bigger. We don't have scales there now. So what is the way to see it in a peripheral smear? The answer is that, the answer is lymphocyte. You know, lymphocyte is a type of WBC. We have various type of WBC. Lymphocyte is one of them. Lymphocyte is also having 7.5 micrometer and it never changes. It is of one size only. So in a peripheral smear, we roughly compare the size of the RBCs here, can you see the RBCs? And here, we are comparing the size of the RBC with lymphocyte. So in the first diagram, I can see all the RBCs are roughly same size as that of lymphocyte. So I say normocytic. In the second diagram, I find RBCs are a little bit smaller than the lymphocyte. Lymphocyte is looking bigger. So I will say these are microcytes. And in the third diagram, I can find the RBCs are bigger than the lymphocytes. So they are macrocytes. So we don't use scale. We roughly, it is a subjective thing. So we just compare the size of the RBC with a lymphocyte. It's also important MCQ. Lymphocyte is the criteria to decide the size of the RBC, to decide the, I'm sorry, give me a minute. Okay, to decide the size of the RBC. Right. Now, give me 1 minute. I cannot see your chat. Yeah, I can see now. Based on the color, how many types of RBCs are there? That was about the size. Now let's talk about color. Color in pathology is known as chroma. Chroma का मतलब होता है color. Cytic means size, chroma means color. Now based on color, only two types are there, not three types. So this is a RBC, this is a RBC. The first RBC, I'm drawing peripheral 2/3 is colored, having hemoglobin at the peripheral 2/3 and central 1/3 is empty. Right. In the second RBC, less than peripheral 2/3 is colored and more than 1/3 pellar is there. You can see the difference, what I mean to say. You got my point. So my point is that here central pellar is equal to 1/3. Here central pellar is more than 1/3. You got my point. So this one is normal. The first one is normal. It is known as normochromic. Normocytic nahi, normochromic. Chroma का मतलब होता है color. Normochromic. And second one, the color is less. The hemoglobin is less. The pellar is more, but the peripheral color is a thin rim at the periphery. So I will say it's hypochromic. Hypo means less, hypochromic. So based on color, RBCs are of two types, normochromic and hypochromic. Say yes, say yes. So what we have learned? We have learned something. We have learned based on size, RBCs are of three types. Based on color, RBCs of two types. Now, if you can help me in writing this, I can tell you the classification of anemia. So size means cytic and color means chromic. Chromic. If you understand the basics now, you will not confuse. Pathology is a very simple subject. Very simple, very honest, very simple, beautiful subject. Okay. So cytic, it's normocytic, microcytic and macrocytic. Am I right? Yes. So based on the size, it's cytic. Based on the color, only two things are there. Normochromic, right? And hypochromic. Don't say micro, it's hypo. So use here cytic, and use here chromic. So based on color. So now let me classify anemia in front of you. The first type of anemia in which the size and color of RBC is normal, but still the patient is having less hemoglobin. Still patient is anemic, but RBCs are normal size, normal color. So such anemia is known as normocytic, normochromic anemia. I will tell you the examples. Normocytic, normochromic anemia. The second type of anemia, the RBCs are smaller in size, and having less hemoglobin. The color is also less. The size is less, the color is less. Such anemia is known as microcytic hypochromic anemia. Microcytic, hypochromic. The size is less, the color is less. Say yes, say yes. The third type of anemia in which the size of RBC is more, not less. The size of the RBC is more, but we do not have any option of more hemoglobin. So I will take normo again. So the third type of anemia is macrocytic and normochromic. You got my point? Everyone give me a thumbs up. So based on size and color, that is cytic and chromic. Cytic and chromic means size and color, right? Size and color. So here both can be normal, that is normocytic normochromic anemia. Both can be less, that is microcytic hypochromic anemia, and size can be more but color still normal. So macrocytic and normochromic anemia. So this is the three types of anemia, the morphological classification in front of you. The morphology, there is no thing, no altus, there is no thing like hyperchromia. Hemoglobin never increases inside a human RBC. Never, never. This condition don't even exist. You got my point? So that is my point to you. So that's why I will take normo here. I cannot take hyperchromatic. Give me a thumbs up, altus. Give me a thumbs up. You got it? So can I move ahead? So this is the first classification known as morphological classification of anemia. I will be coming on that. Can you see the two types of the RBC based on color? Based on color. Okay. Look at the first one. See the pallar. I can see this area is pallar. I can see this area. So normally pallar is, it is looking like 1/3 only. Here pallar is looking like 1/3. But see the other slide. See the second slide, right hand side. So here I can see the pallar is more than 1/3. The color is very less, only at the thin rim. I hardly see any color at the periphery. So here, of course, the pallar is more than 1/3. So can I say this? The first slide is normochromic and the second slide is hypochromic. Say yes, say yes. So that is the thing. So now I would like to tell you two more terms here, two more definitions here. Can you see the first slide? Here in this slide, you can see some RBCs are small, some are normal, and some are large. I can see various shapes. I cannot see all RBCs are of same shape. Some are microcytic, some are normocytic, some are macrocytic. I'm comparing all of them with lymphocyte. You have to compare. So the variation in size is different. Some RBCs are small, some are normal, some are bigger. It is known as anisocytosis. Now don't learn. You know English, you know grammar, right? N means no. In pathology, the term N means no, right? Iso means is equal to. And cytosis, I already told you. Cytosis means size. Cytosis का मतलब होता है size. So now complete N isocytosis, no equal size. So all the RBCs are of different size. I don't learn pathology, I just understand it. So if you tell me that, ma'am, there is an isocytosis, so I will split it. N isocytosis, no equal RBC. That is, all the RBCs are of different size. You got my point? This term is known as an isocytosis. Give me a thumbs up. Right, in the first slide. But in the second slide, look at the shape of the RBC. I think this one is elliptical, this one is oval, this one is circular, this one is helmet shape, right? So I can find different shape, not different size. I'm saying different shape. Variation in shape, multiple shapes are there. Sometimes we find teardrop, right? Multiple shapes. So it is known as poikilocytes. Poikilocytosis. So anisocytosis and poikilocytosis, these are the two terms you have to learn. Anisocytosis is variation in size and poikilocytosis is variation in shape. Say yes. You got it? If you got it, give me a thumbs up. If you got it, poikilocytosis, that's what I'm telling you, Krishnakant. It's variation in shape. You got it? So variation in size, variation in shape. Anisocytosis, if I use these terminologies, you should be able to understand. Now, the most important area before coming to the classification of anemia, you should know the various shapes. I will tell you all shapes, possible shapes of RBC and the conditions in which they are present. Normal human have circular RBCs. The shape is circular. But in different medical conditions, different pathologies, we can have different shapes of the RBC. So you must be aware of the different shapes of the RBC. Can you see this column? See the shapes. And you must know the condition in which this shape is present. You got my point? So the first shape is a target cell. You know, target is the bull's eye. There is a dot at the center. Normal RBC don't have a dot at the center. The central is a 1/3 pallar. Normal RBC don't have a dot at the center. But in the RBC, the central dot is present. There is a pallar, but inside that I can see a central dot. It is known as target. Target is bull's eye. You got my point? It is seen in thalassemia. Mostly seen in thalassemia and post-splenectomy. If the spleen of the person is removed, such cells are present in the blood. It is not a normal condition. The second is the bite. You know, bite. What is a bite? So if I'm having a pie, I'm having a cake. This is a cake or a pie, a piece of a cake, and I take a bite from here. I'm eating one of the bite. I have taken one of the bite. I have taken one of the bite. So what is the remaining shape? The remaining shape is like this, because here one of the bite I have already taken out. So this shape is known as bite cell. This shape is known as bite cell. Everything has a reason behind it. Yeah, right? So see the shape here. Can you appreciate? This was a complete pie, complete cake piece, complete circle from which one of the bite is taken. So this cell is known as bite cell. You got my point? It is seen in G6PD deficiency. You have to learn G6PD. बहुत बार question आता है. Multiple time PYQ. Bite cells are seen in. It's in G6PD. Or else you will get an image-based question. In a smear, you will get multiple bite cells. You should be able to appreciate these all are bite cells. एक एक bite निकला हुआ है. एक एक bite सबने खा लिया. ठीक है? तो it is seen in G6PD deficiency. Now there is no time. कभी अगर regular batch मैंने लिया तो I will tell you reason for everything. That ये bite लिया किसने? ये bite लेता है spleen का macrophage. Spleen का macrophage take one of the bite. So actually there is a complete RBC. And in the complete RBC, this is denatured hemoglobin, not normal hemoglobin, denatured hemoglobin. When such RBC passes from the spleen, this is spleen. So inside the spleen, we have macrophages. The macrophages are present inside the spleen. They detect that this portion of the RBC have denatured hemoglobin. So this macrophage will take this bite out. It will remove this. It will not engulf the complete RBC. It will take one portion of the RBC. So this denatured hemoglobin is known as Haynes body. This denatured hemoglobin is Haynes body. So both of these things, Haynes body and bite cell, they are seen in G6PD deficiency. Because of Haynes body, only bite cells are formed. You can see. Because previously it was a Haynes body that is removed by the splenic macrophage and that results in formation of bite cell. So Haynes body and bite cell are related to each other and both of them are basically seen in G6PD deficiency. I guess you got it. I guess you got it. Right. So, okay. Okay, so let me move ahead. The next cell is a sickle shape. You all can identify, it's very easy. Sickle cell anemia, sickle cell shape. You know the sickle shape. Teardrop, you know, आंसू आता है ना आँख से, teardrop. So the shape of the RBC is like a teardrop. It is typically seen in myelofibrosis. I'm telling you, these all are your MCQs. You have to learn the condition, the shape. You have to. I will show you the MCQs. Now I'm going to tell you two type of RBCs. Okay. Both have projections on the surface. So let me draw the two RBCs, this one and this one. If the projections are sharp, can you see the sharp projections I'm drawing, and only few? All the projections are sharp. Or else I can draw the blur projections. Blur, you know, blunt. They are blunt, not very sharp, right? So this one is known as S for sharp, S for spur cell. Spur. Now you will not forget sharp and spur. And B for blunt and B for burr cell. Burr cell. So this one is a spur cell, this one is a burr cell. Now you will not forget. Spur is sharp and burr is blunt. Give me a thumbs up. Say yes, appreciate it, appreciate it. You got it? The other name of the spur cell is acanthocyte. Acanthocyte. And the other name of burr is echinocyte. That other names you have to learn. So the other name here is acanthocyte. You can see this is a spur cell. Appreciate the sharp projections. Appreciate the sharp, very sharp projections. And appreciate the blunt projections here. Blunt. This one is burr, also known as echinocytes. So learn the conditions. Spur cells are present in A beta lipoproteinemia and burr cells are present in uremia. Learn the main condition. Don't learn all. Right. So you have learned it. The next is Rowlatt's formation. You know Rowlatt's multiple RBCs stick with each other and they form a train. The bogies of a train, one behind the other. So Rowlatt's formation typically seen in multiple myeloma, right? So these were the different type of the shapes of the RBC. Here also they are summarized. We will be doing some PYQs based on the shapes of the RBC. We are done with this topic also. I guess we must do some PYQs. You have to write your answer, but otherwise I will not launch polls. If you participate in that, then only I will launch. So the first question is in front of you. Can you tell me the condition in which burr cells are seen? Give me a minute. Can you tell me the condition in which burr cells are seen? Please help me in answering it. The four options are in front of you. The burr cells are like this. They are blunt projections, also known as echinocytes. Yes, it's in uremia. It's a PYQ. You have to learn. Just now I told you, right? Okay, so burr cells are seen in uremia. This is the burr cell. Appreciate the blunt projections. The next, bite cells are seen in. I've told you, bite cell as well as Haynes body. Haynes body. They are present in what? They are present in what? Bite cell and Haynes body. So one of the bite of the RBC is taken out because this portion contains the denatured hemoglobin or Haynes body by the splenic macrophage. Yes. So it not A. Many students are saying A. No, it's not A. It's G6PD deficiency. So in G6PD deficiency, Haynes body and if I change the question, instead of bite cell, I ask you Haynes body, then also answer is G6PD only. So in G6PD, Haynes body and bite cell both are present. Yes, you all are right. Very good. Very good. So correct answer here is D. Shall I move ahead? Shall I move ahead? You can see the bite cells here. Where are the bite cells? I can see it here. It's in G6PD deficiency, right? Coming to next, Rowlex formation is seen in. Rowlex means train of RBC. They are sticking to each other one behind the other. Can you tell me the correct answer here? Rowlex. Rowlex formation, the train of the RBC. They are sticking to each other. They are sticking to each other. Yes, you all are right. It's seen in multiple myeloma. Multiple myeloma have Rowlex. Now, do you know the reason? Why? What happens in multiple myeloma? Why RBCs stick to each other? Why RBCs stick to each other and they form a, stack? It is known as stacking. They form a stack, a train of RBC. Why? Do you know the reason? Yeah, the correct answer is this. But do you know the reason? There is a reason. Everything have a reason. So normal RBCs have negative charge on them. Let me draw few normal RBCs. They have negative charge on them. That's why they repel each other. Your RBC, normal RBCs. That's why our RBC do not stick to each other because they have negative charge and they repel each other. Now there is a person who is having multiple myeloma. What is multiple myeloma? It's a disease. In this disease, abnormal immunoglobulin is formed. In a normal immunoglobulin, 2 light chains and 2 heavy chains are there. It is normal immunoglobulin, 2 light, 2 heavy chains. But in multiple myeloma, there is some mutation. So only light chains are formed. Heavy chains are not formed. So I cannot call it a immunoglobulin because it is incomplete. Yes, plasma cell mutations are there, plasma cell dyscrasia is there. I cannot call it immunoglobulin. It's not complete. It's abnormal. So I will say some abnormal light chain, kappa lambda light chains are formed. And these are highly positively charged. So they are present abundantly in blood. Multiple myeloma patients have these light chains abundant in the blood. So these positively charged will go and neutralize the negative charge of the RBC. Positive will neutralize the negative, so RBC stick to each other. They form Rowlex. This is the reason. It's also a PYQ. So instead of solving PYQs, we are learning the concepts. You got my point? So this is my way of teaching. I give you concepts, right? Multiple concepts, so that any question coming in your exam, you can correlate. You can correlate. Yes. So this is the reason why RBCs stick to each other in this thing. Multiple myeloma. Yes, definitely, Shashi. Mott cells are also seen in multiple myeloma because abnormal light chains are present inside the plasma cells, and plasma cells containing abnormal light chains is Mott cell only. So that is the thing. Let me move ahead to the next question. The next question is in front of you. Can you identify in the image what is shown by the arrow? Look at the arrows. I have drawn 2 arrows here. The first arrow, the second arrow. Can you identify this cell, this cell? Is it a target cell? Is it a cystocyte? Is it a sickle cell? Is it a spherocyte? Yes? So yes, most of you are right. It is a cystocyte. It's not target cell. Target cell have a dot at this one is target cell. It is having a dot at the center. This one is target, dot at the center. But the cell which are marked by arrow, they don't have a dot. So the shape is irregular, like a helmet or some irregular shape is there, right? So the irregular shape RBCs are known as cystocytes, right? So cystocytes are the RBCs which have normal RBC have circular shape. But cystocytes are the fragmented, टूटे-फूटे. Hindi में कहूँ तो टूटे-फूटे. They are the fragmented RBCs. The fragmented RBCs are known as cystocytes. Now you must ask me, ma'am, the condition in which they are present and why they are formed. You must have questions in your mind. You got my point, ma'am? Why cystocytes are formed? Name the condition in which it is formed. Why the RBCs are fragmented? Tell me the reason. Tell me the reason. Okay. So there is a condition which is known as MAHA. Have you heard about MAHA? Microangiopathic hemolytic anemia. MAHA, microangiopathic hemolytic anemia. It's a type of hemolytic anemia in which there is a problem in the lumen of the blood vessel. Normal lumen of the blood vessel, the endothelial lining is very smooth, very smooth. So when RBCs pass from it, there is no problem. But in some persons, inside the lumen of the RBC, there is thrombus formation. In the morning, I told you thrombosis. So thrombus is formed. So whenever this RBC is passing from here, it will collide with this thrombus and get fragmented. So it will convert into cystocytes. So RBCs will convert into cystocytes. This condition is known as MAHA, and the RBCs here are known as cystocytes. Right? So give me a thumbs up. You got it? So cystocytes are seen in MAHA. It is also an MCQ. And it is formed due to the collision of the RBCs with the fibrin, or with the thrombus, you can say. So that's why it is known as, the problem is not in RBC. The problem is in the blood vessel. That's why it is known as microangiopathic hemolytic anemia. Microangiopathic means microvasculature. The problem is in the vasculature, not in RBC. Right? Okay. So MAHA is microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia. That is MAHA, microangiopathic, in which multiple thrombus are formed in the lumen of the RBC. Can you do the next question, the last question here on this concept for me? Give me a minute. Can you see? Can you identify the RBCs here? I can see the RBCs with sharp projections. Sharp, not blunt. So what the RBCs with sharp projections are known as? So of course they are spur. Spur ka S, sharp ka S. I told you. What is the other name for the spur? Is it acanthocyte or echinocyte? You all are right. Very good. It's acanthocyte. So these all are your PYQs, IBQs. You know, hematology is the area from which multiple IBQs can come. You agree? So see the next question. Can you identify the arrows? I have drawn two arrows. This one, can you see? What is this? What is this? What is this? Is it microcytic RBC? Is it evidence of hemolysis? Is it sickling, or is it Rowlatt's formation? Yes, everyone is right. It is Rowlatt's formation. Multiple RBCs are sticking to each other. You can see beautifully. It is seen in multiple myeloma. And you know the reason also. I guess you know the reason now. So let me come on the next concept immediately. Right. Classification of anemias. Can you classify anemias for me? We will do two types of classification of anemias, morphological and pathological. Morphological we have already done, the three types of anemias, right? RBC is normal size, normal color. It's normocytic, normochromic. RBC is less size, less color. So it is microcytic and hypochromic. RBC is more size, but normal color. It's known as macrocytic and normochromic, right? I have already explained you, if you are attending 5 minutes before I explained you. Based on size, RBCs are of 3 types. Based on color, RBCs are of 2 types, right? If we compile them, we will get the 3 types of anemia. So these are the 3 types of anemias based on morphology. You can see the peripheral smear of the 3 types of anemias. In the first smear, I can see the RBCs, they are smaller. They are very small. And you can see the color is also less. So these are microcytic, hypochromic. The color is present only at the periphery, not the central pallor is very big. It's more than 1/3. In the second, I can see the size is also normal. See the lymphocyte. Okay, in all 3 sides, the must thing, give me a minute. In all 3 slides, the must thing is the lymphocyte. Can you see here, lymphocyte, a lymphocyte has to be given to compare the size of the RBC. In the second, all the RBCs I can see nearly same as that of lymphocytes. So size is normal, color is also normal. In the third, the RBCs are bigger, but the color is normal, right? Yes. So that is the 3 types of the anemias. You got it. Now that was the first classification. Now you tell me, ma'am, what is the reason for these? Reason. Why the RBCs become smaller, bigger, larger, normal? What is the reason? Reason for anemia. So second classification is etiological classification or pathophysiological classification of anemia. In the end, I will compile the 2 classification. So let me tell you etiological classification also. Now you imagine why RBCs will be less. What is anemia? Can you define anemia for me? This is the blood vessel of a person. What is normal RBC count? How many RBC you are having in your blood? If you are not anemic, you are healthy. I'm healthy. I'm not anemic. So how many RBCs are present in my blood vessel? The normal count is 4.5 to 5.5 million RBCs per deciliter. This is the normal count. So if RBCs are less than this is anemia, right? Now we don't measure RBC. We measure the hemoglobin inside the RBC. All RBC have hemoglobin. So of course the common sense says that all RBC contain hemoglobin. So if RBC will fall, the hemoglobin will also fall. So it is an indirect measure of anemia that we measure hemoglobin. Actually, hemoglobin fall is not anemia. Anemia is RBC fall. RBC कम होता है तो हम कहते हैं anemia है पेशेंट को, लेकिन हम RBC मेजर नहीं करते, वो डिफिकल्ट है मेजर करना. So indirectly हम hemoglobin मेजर करके ये assume करते हैं क्योंकि hemoglobin कम है तो RBC भी कम होगा, because RBC is directly proportional to hemoglobin. Say yes. Say yes. You got it. You got it. So there can be 3 reasons why RBCs are less. So 3 reasons of anemia. Imagine a person who is having an accident, road traffic accident, or the person is having a major surgery. So in the accident, in the surgery, he's having blood loss, severe blood loss. So all the RBCs present in the blood, they go out, so person will be anemic. So most simple reason for anemia, blood loss. Blood loss can be acute, It can be sudden, like accident, can be surgery, or it can be chronic, daily small amount of blood is lost, like peptic ulcer, like hemorrhoids, right? Like nasal bleeding. There can be multiple internal bleeding. Small amount of blood is lost daily. So it can be acute, it can be chronic. So I'm not going to explain you this. Now you can understand. The second thing, the production of the RBC is less. So problem is in the bone marrow. The production takes place in the bone marrow. You know the complete sequence, right? So there is some problem in the production of the RBC. And the third thing is that the production is normal, but destruction is more. So the RBC is formed normally in the bone marrow. It's coming in the blood. And after coming in the blood, it is destroyed at a higher rate. Normal RBC is destroyed after 120 days. The normal lifespan of RBC is 120 days. You got it? But here the destruction of RBC occurs at less than 120 days, and it is fastened. So such anemias are known as hemolytic anemias. So that is the classification. Give me a thumbs up. Give me a thumbs up. So blood loss can be acute, can be chronic. We have understood that. Now decreased production. Why the production of RBC is less? Why the production of the RBC can be less? Can you tell me the reason? What is the problem? What is the problem? Okay. Let me draw a bone marrow to explain you why production can be less. Inside that, let me draw few RBCs. So this is the precursors of the RBCs, hematopoietic stem cell, early, intermediate, late normoblast, and finally RBC is formed. After forming, it is coming in the blood vessel. So let me draw a blood vessel. In the blood vessel, this RBC is coming after formation, right? This is normal. This normally happens. Now RBC have two things. RBC have two things. Number one, the cytoplasm of the RBC have hemoglobin. The cytoplasm of the RBC have hemoglobin, and number two is nucleus. You will say, no ma'am, no, RBC don't have nucleus. I know, RBC don't have nucleus, मुझे पता है, I know that. But the precursors of the RBC have nucleus ना, उसके पूर्वजों की तो है ना nucleus. RBC don't have nucleus, I know. At late normoblast state, it is enucleated. I know that. But the precursors of the RBC have nucleus. Now, if I say there is problem in the formation of the RBC, RBC formation is less. It is formed less. So there can be two problems. Either the nucleus cannot be formed, that's why it is delayed, it is not forming, or the cytoplasm hemoglobin is not formed. So where is the problem? The problem is in the nucleus or the problem is in the cytoplasm. If any one of them is delayed, cannot be formed, either the nucleus is not formed or the cytoplasm hemoglobin cannot be formed. So the complete RBC cannot be formed, so production of the RBC will be less. You got my point? So production can be less due to two reasons, the nuclear problem or cytoplasmic problem. Nucleus. For the formation of the nucleus is made up of what? It is made up of DNA, we all know. And for the formation of DNA, we require B12 and folic acid, vitamin B. So if someone do not eat, I don't eat, just suppose I don't eat vitamin B12 and folic acid in my diet. So what will happen inside my blood? You tell me what will happen. If I don't eat vitamin B12 and folic acid, there will be a problem in synthesis of DNA. So DNA will not form. So nucleus of the RBC will not form. So nucleus is not formed, so mature RBC cannot form. I know RBC don't have nucleus, but the precursor of the RBC cannot be formed. A precursor ही नहीं बनेगा तो RBC कहाँ से बनेगा? You got my point. So this type of anemia is due to nuclear defect and it is known as megaloblastic anemia, right? And in the cytoplasm, there can be problem in the cytoplasm. Nucleus is normal, but there is problem in the cytoplasm, that is hemoglobin. Now hemo and globin. The problem is in heme or globin. उसको भी split करो. Heme is made up of iron. If you don't eat iron in your diet, na, heme will not form. Heme will not form, so hemoglobin will not form. So cytoplasm of the RBC will not form. And you will have anemia, right? The anemia due to decreased production of RBC, right? Or heme is normal, you are eating adequate iron, right? So globin can be defective. Globin दो तरह का defective हो सकता है, sickle cell anemia and thalassemia. So this is the complete classification in front of you. Give me a thumbs up. You got it? You got it? So there can be a defect in the cytoplasm or in the nucleus. The nucleus defect is megaloblastic anemia and cytoplasmic defect is heme or globin. If it is heme, it's iron deficiency anemia, sideroblastic anemia, anemia of chronic disease. And if it is globin, it is thalassemia or sickle cell anemia. It is globin. Everyone give me a thumbs up. So this is the classification, or else the third problem can be that inside the bone marrow, what is the first cell? The first cell is hematopoietic stem cell, the father of all cells. वो ही नहीं है. God forget to give you hematopoietic stem cell to some person. तो उसमें कुछ भी नहीं बनेगा. Neither RBC is formed, nor WBC is formed, nor platelet is formed. So person have anemia, person have thrombocytopenia, and person have leukopenia. So basically person have pancytopenia. So such a anemia is known as aplastic anemia. So what is the problem in aplastic anemia? In aplastic anemia, father is absent. Like hematopoietic stem cell is absent. It is not there. Either it is hereditary congenitally absent, or it is acquired, inhibited, or destroyed by some drug, by some chemotherapy drug. Give me a thumbs up. You got it? You got it? So that is stem cell mein problem hai. That is aplastic anemia. So this is the complete classification of anemia. That is due to decreased production. What about increased destruction? Destruction कब कब होता है आरबीसी का? So increased destruction of RBC have 6 causes. It occurs in autoimmune hemolytic anemia. This is MAHA. I told you, microangiopathic hemolytic anemia, paroxysmal nocturnal hemoglobinuria, right? It can be thalassemia, it can be sickle cell anemia and G6PD deficiency, spherocytosis. So you can learn the causes. These all are causes of hemolytic anemia, that is increased destruction. I know too many names are there, but have a look. Don't try to mug everything, but please understand these are the causes of the anemia. You have to understand by problem kya hai. Just suppose, now of course not suppose, you are a doctor now. So you are a doctor and a patient is coming to your clinic with a complaint, doctor, आई एम हैविंग फटिग, मुझे बहुत थकान होती है आजकल, आई कैन नॉट कंसंट्रेट इन एनीथिंग, आई ऑलवेज फील टायर्ड, स्लीपी एंड आई एम लैक ऑफ एनर्जी, आई डोंट फील एनर्जेटिक एट ऑल, राइट? सो दीज आर माई प्राइमरी कंप्लेंट्स, डू समथिंग. So investigate. So you will say, okay, do a CBC. The first thing you will ask the patient to do a CBC. In the CBC you find that WBCs are normal, platelet are normal, but hemoglobin is 6. Oh my god, it's 6 gram per deciliter. Normal hemoglobin for a male or female, it should be 12, 13, depending male or female. So but it's 6, it's very less. So definitely the patient is having anemia, and that's why these symptoms are there. The patient is anemic, but anemic ये तो खुद रिपोर्ट देख के भी समझ जाएगा पेशेंट, डॉक्टर साहब हीमोग्लोबिन कम आया है तो मुझे अनीमिया है. But being a good doctor, your job is to find which type of anemia, classification, because the treatment of all type of anemias is different, right? So you have to ask the patient a detailed history. What is your diet? Do you eat iron in your diet? Is it iron deficiency anemia? Do you eat vitamin B12 in your diet? Do you eat folic acid in your diet? Is it megaloblastic anemia? Is it iron deficiency anemia, right? You have to take again a blood sample and make a smear. Okay, you take a slide and take one drop of the blood and make a smear here. Inside that sees the RBC of the RBC. The RBCs are microcytic, normocytic or macrocytic, right? So that will give you differential diagnosis. Give me a thumbs up. And based on that, you have to go on the classification exactly what the type of anemia the patient is having. Accordingly, you will give the treatment. ऐसा नहीं है patient आया anemia है iron दे दो. It is not always iron. I know 90% it's iron deficiency anemia, but it's not always 90%. And it can be some other type of anemia also, right? So that is the classification of the anemia you must understand, right? Now let me compile the two classification. I told you the first classification based on morphology, it's microcytic, normocytic and macrocytic, right? And the second type of classification based on etiology, it's a big classification having multiple names inside it, right? Let me compile the two. So I'm having mnemonics for that, for your approach, quick approach in your exam. So tell me, there are only 4 anemias on this world which are microcytic, in which RBCs are small, microcytic. Only 4 anemias in this world in which RBCs are small, microcytic. The mnemonic for that is Sita, S-I-T-A, Sita of the Ramayana, right? S-I-T-A, right? S is sideroblastic anemia, I is iron deficiency anemia, T is thalassemia, and A is anemia of chronic disease. Never forget, many PYQ comes on this. The PYQ will be like that. Which of the following is a microcytic anemia, or which of the following is not a microcytic anemia? So you can pick the options. If you know these 4 names, you can rule out and you can make out. Give me a thumbs up. Say yes. Say yes. So sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease. So meat, you are saying lead poisoning. So basically lead poisoning leads to sideroblastic anemia. I will tell you when I will teach you. So it's not definitely lead poisoning separately, but lead poisoning lead to sideroblastic anemia, and sideroblastic anemia already a cause of microcytic. So technically you are right that lead poisoning also lead to microcytic anemia. Technically you are right, but you should know the proper channel, right? So this is the thing. Shall I move ahead? Say yes. So how many anemias you know with normocytic? There are, okay, don't say normocytic, first say macrocytic. How many anemias you know which are in which RBCs is larger? Macro, not micro, macro. Again 4. In the 4 RBCs is smaller and the next 4 RBCs is larger, right? So the mnemonic is Lady Harding Medical College, LHMC, Lady Harding Medical College, right? It's a good medical college. You may be knowing that in India. So L stands for liver disease, H stands for hypothyroidism, M for megaloblastic anemia, and C for cytotoxic drugs, the chemotherapy drugs like methotrexate and phenytoin. So these 4 anemias have macrocytic RBCs. Now coming on the normocytic. How many anemias you know in which the RBCs are of normal shape? So I will say all hemolytic anemias. All hemolytic anemias are basically normocytic. So if you want to learn the name, there is a mnemonic SHAPE, S-H-A-P-E. S stands for sickle cell. H stands for hereditary spherocytosis. A stands for autoimmune hemolytic anemia, AIHA. Right? P for paroxysmal nocturnal hemoglobinuria. And E for enzyme deficiencies like G6PD deficiency. Right? So say, have you got it? You may get multiple MCQs based on this classification, believe me. Which of the following is a microcytic, which of the following is a normocytic, which of the following is a macrocytic, or which of the following is not microcytic, normocytic, or macrocytic. So if you know this classification now, you can make out many MCQs in your exam. Can we go ahead? Right. Okay. So first I'm going to teach you hemolytic anemias. From hemolytic, I will teach you only two. I cannot teach you all here. So I will teach you the two important, sickle cell and thalassemia, from which many time MCQs are coming, right? So let me teach you the hemolytic anemia. Before coming on that, let me tell you the two type of hemolytic anemia. The two type of hemolytic anemia. Okay, just a second. I have told you in hemolytic anemia, RBC destruction is more. So where is the destruction taking place? Normally, RBC destruction takes place where? So this is the blood vessel and this is the spleen. This is the spleen of human. This is the spleen. This is the blood vessel of a healthy human. Just suppose my blood vessel and spleen I have drawn here. Give me a minute. If I'm switching off AC, it's hot. And if I'm on, switching on, it becomes cool. I don't know what to do. Anyways, so it is a blood vessel and this is a spleen, right? Inside the blood vessel, I can see the RBCs here. After 120 days, what happens to these RBCs? What happens to these RBCs after 120 days? After 120 days, these RBCs move to the spleen. And inside the spleen, there are macrophages. This is known as reticuloendothelial system. RE system, that is reticuloendothelial system, that is the macrophages present inside the spleen, and they destroy this RBC. So RBC destruction takes place inside the macrophage. So free, if RBC is ruptured now, it is inside the macrophage. So free hemoglobin is not coming in the blood vessel. The free hemoglobin is inside the macrophage. This happens normally in me, you, in all of you. This happens normally. Say yes, you got it, you got it. So this is normal. But now in hemolytic anemia, there are two types of hemolytic anemia. The first type in which RBC destruction takes place inside the blood vessel only. And the second type in which RBC destruction takes place inside the spleen. So whether the RBCs are ruptured here or whether the RBCs are ruptured here. Based on that, it's of two types. This is known as intravascular because it is inside the blood vessel. And this is extravascular, outside the blood vessel but inside the spleen. So the two types of the hemolytic anemia, intravascular hemolytic anemia and extravascular hemolytic anemia. No need to learn, just understand, right? So intravascular, the RBCs are ruptured in the lumen of the blood vessel, and extravascular, the RBCs are ruptured inside the macrophage of a spleen, right? So here, if the RBCs are ruptured, imagine what happened. The hemoglobin is leaked out, right? So free hemoglobin is present. So patient have hemoglobinemia and hemoglobinuria. The free hemoglobin will go to the urine also via kidney. So blood and urine both have free hemoglobin. It is known as hemoglobinemia and hemoglobinuria. So this anemia, this type of intravascular hemolytic anemia have hemoglobinemia and hemoglobinuria. Hemoglobin is present in the blood and in the urine, right? Hemoglobin get converted to methemoglobin. So methemoglobinemia and methemoglobinuria, right? Hemoglobin get converted to hemosiderin. So hemosideриnemia and hemosideриnuria. All these things are present in the intravascular one. When the RBC is rupturing now, at that time, the LDH present inside the RBC, it also leaks out. So LDH concentration is very high here, very high. But on the contrary, everything is opposite here in extravascular. The RBC is ruptured inside the macrophage. So there is no hemoglobinemia, no hemoglobinuria, no methemoglobinemia, no methemoglobinuria, no hemosideриnemia, no hemosideриnuria. Because hemoglobin is not at all coming in the blood vessel. Everything is absent here, right? And no LDH rise. LDH will not come. Right? It's all things is present inside the macrophage. Inside the macrophage, when the RBC is rupturing, the hemoglobin of the RBC convert into bilirubin. And bilirubin will come in the blood and it causes severe jaundice. Right? So in extravascular one, patient have severe jaundice. So there is a difference. You know, the patient is coming to you, you will investigate if you find hemoglobinemia, methemoglobinemia, hemosiderin. So it's intravascular. And if the patient is coming to you and patient is having two things, anemia and jaundice together, the combination, anemia with jaundice, it has to be extravascular hemolytic anemia. Give me a thumbs up if you got the concept. You got it? So there are two types of hemolytic anemias. I guess you already know this concept now. The two types of hemolytic anemia. Whether the destruction takes place inside the blood vessel or whether the destruction takes place in the spleen, macrophages. Give me a thumbs up, say yes. So if it is intravascular, inside the blood vessel, so there is hemoglobinemia, hemoglobinuria. Methemoglobinemia, methemoglobinuria. hemosideриnuria not written here, right? And jaundice is there, but less, not very much. Less jaundice is there. But if it is extravascular, there is no hemoglobinemia, no methemoglobinemia, no hemosideриnuria, but there is severe jaundice. And here extravascular is taking place inside the spleen. So there is splenomegaly and hepatomegaly. That is the feature here. So if you're, what is having your, so can you enumerate the features of the two types of the, this thing? Intravascular hemolytic anemia and extravascular. Many MCQs based on this concept. I will show you the polls. Intravascular and extravascular hemolytic anemia. Can you tell me the features? Let me write it. In intravascular, let me enumerate. Hemoglobinemia, hemoglobinuria. Okay. Methemoglobinemia, methemoglobinuria. Okay. Hemosideриnemia and hemosideриnuria. Okay. Very easy to understand. After that, jaundice is there, but mild. But yeah, LDH is very much elevated here. Right. So these are the features here. But in extravascular, no hemoglobinemia, no methemoglobinemia, no hemosideриnuria. Jaundice is very, very, very severe. And along with that, there is hepatomegaly and splenomegaly. Give me a thumbs up. Now, any question coming on this concept, you are able to solve because you have understood the concept. You have not learned it. You have understood it. You have understood it, right? Type of LDH, I don't know. All that LDH will be raised here because the RBC is rupturing. So whatever LDH is present inside the RBC, it will leak out. Can we go ahead? So the same differences are written in front of you. You can understand. Now don't learn this table. You can understand this table very well. Extravascular, intravascular. You can see the location. It's inside the RE system, that is spleen and liver. And this one is inside the blood. And you can see where what is present in which of them. What is present in which of them, and you can make it out. Now, among the hemolytic anemias, which of them have extravascular, which of them have intravascular? This is the distribution. This is the distribution. You can see G6PD deficiency is coming both sides. So it is the only anemia, G6PD deficiency, which is having both type of hemolysis. The intravascular as well as extravascular, it's your PYQ. You have to learn it. You have to learn it, right? Now, let me tell you sickle cell anemia. Sickle cell anemia and thalassemia, I'm going to tell you in short so that your MCQs can be framed on that, right? And after that, we have to understand the leukemias also. So I will be a little bit fast. Okay? So, you know, humans have hemoglobin. We all have hemoglobin. There are three types of hemoglobin. Hemoglobin A, in which 2 alpha and 2 beta chains are there. Fetal hemoglobin, it's in which 2 alpha and 2 gamma chains are there. And hemoglobin A2, in which 2 alpha and 2 delta chains are there. You can see alpha is common in all of them, right? So, it's alpha 2 beta 2, it's alpha 2 gamma 2, it's alpha 2 delta 2. How much is having you? You are having how much of each of them? I'm having how much? A normal individual is having how much of each of them? I am having 98% of hemoglobin A. I'm having nearly less than 3.5%, 95 to 98% A, 3.5% of A2, and less than 1%, hardly anything of fetal hemoglobin. So that is the distribution in a normal human being. Now let's start sickle cell anemia. Actually, sickle cell anemia and thalassemia, I'm going to teach you two things. Now, there are two types of hemoglobinopathies. Sickle cell anemia and thalassemia, both of them are hemoglobinopathies. So, there is problem in the hemoglobin. Ab hemoglobin mein kya problem hai? What is the problem in the hemoglobin? Okay. There can be two types of problem in the hemoglobin. One is quantity, one is quality. Do you understand the word quantity and quality? Quantity का मतलब क्या होता है? What do you mean by quantity? And what do you mean by quality? What do you mean by quantity and what do you mean by quality? Quantity means the amount, right? So hemoglobin is present, but the globin is present in less amount. It is normal. So alpha is alpha only, beta is beta only, but they are present less. That is quantitative abnormality. They are less. It is known as thalassemia. So in thalassemia, normal hemoglobin is present, but the only thing they are either less or absolutely absent. So that is thalassemia as a quantitative abnormality. And qualitative, the quality is not good. Quantity is okay. The hemoglobin levels are normal. They are 12 to 15 grams per deciliter. The quantity is normal, but quality wise, it's not good. The beta chain is not good. The beta chain is affected. There is mutation in the beta chain. So this happens in sickle cell anemia. You got my point? So thalassemia is the quantitative abnormality of the hemoglobin and sickle cell anemia is a qualitative abnormality of the hemoglobin. Basically, both are hemoglobinopathies. There is problem in the hemoglobin, but in one of them, there is a problem in the quality and in one of them, there is a problem in the quantity. Give me a thumbs up. You got it? You got it? So let me teach you the sickle cell anemia. Sickle cell anemia, the quality is not good. So what is the problem in the quality? So is there a problem in the alpha chain or there is a problem in beta chain? My first question to you. So there is a problem in the beta chain, no problem in the alpha chain. Alpha chain is absolutely normal. The patient with sickle cell anemia, they have abnormal beta chain. Alpha chain is absolutely normal. So, okay, there is a problem in beta chain. Actually, there is no problem in beta chain. There is problem in the gene of the beta chain. The gene of the beta chain is present on chromosome number 11. On the chromosome number 11, let me draw a human cell. Inside the human cell, this is the nucleus of the human cell. Inside the nucleus of the human cell, we have 46 chromosome. You know that? Or 23 pairs of chromosome, right? So this is pair number 1, pair number 2, pair number 3. Let's talk about pair number 11. I'm interested in pair number 11, not all. Pair number 11, there is a gene. Let me draw the gene. The gene is for beta chain. This is a segment of the gene present on chromosome number 11. So, the chromosomes have triplets known as codons. So, it is adenine, guanine, cytosine, uracil. So, triplet codons are present. So, what is the problem now? Normally, this is beta chain ka gene. The gene for the beta chain present on chromosome number 11. So, normally, the sequence is like this, GAG, right? But due to mutation, adenine is replaced by thymidine. One of the nucleic acid is replaced. Instead of adenine, there is thymidine. So GAG codes for glutamic acid. One triplet codes for one amino acid. So if there is GAG, it codes for glutamic acid, which is normal. I'm having glutamic acid, you are having. But instead of GAG, it is GTG. A is replaced by T, right? So GTG codes for valine. So instead of glutamic acid, there is valine in the beta chain of the hemoglobin. So this beta chain is abnormal. This beta chain is abnormal. So this question comes to multiple time in your exam. What is the problem in sickle cell anemia? What is the problem in sickle cell anemia? There is no problem in alpha chain. There is a problem in beta chain. In the beta chain, there is a problem in the gene of the beta chain. In the gene of the beta chain, the adenine is replaced by thymidine, because of which the glutamic acid is replaced by valine. And that's why this beta chain is abnormal. This beta chain is abnormal. Yes, you can learn like that. The Irfan is giving you a good mnemonic. So the glutamic acid is gone. G for gone. This one is gone. And the valine is welcomed. Welcome ka spelling W की जगह V से याद कर लो. Welcome. So valine is welcome. So one is going, one is coming. So you will not do the reverse. In your option, you will get both options. The glutamic acid is replaced by valine, or valine is replaced by glutamic acid. So in exam, we get confused. So learn G for G. Glutamic acid is gone. And instead of which, the valine is welcomed. Thank you, Irfan. Can we go ahead? Can we go ahead? Yes? Yes, yes, yes. So learn like that. So this is the problem in sickle cell anemia. You will say, then what is the problem? If one of the amino acid instead of glutamic acid, there is valine, is there any problem? Yes, there is a problem. Okay, can you see this RBC? Yes, you can see this RBC, inside which this is the hemoglobin, 2 alpha, 2 beta. And this is the RBC, inside which this is the hemoglobin in which 2 alpha but abnormal beta. Due to the abnormal beta, hemoglobin stick to each other and they form chains. They form polymers or chains. Normally, hemoglobin is dispersed. It is present at the peripheral two-third. But if it forms chains, now the shape of the RBC becomes sickle shape. You can imagine if I have to accommodate this inside the RBC, or I have to accommodate this inside the RBC. I have to accommodate this. This is also hemoglobin. This is also hemoglobin. So here RBC can be circular, but here is no way RBC can be circular. So if I have to accommodate this, RBC have to become sickle shape. So this is the reason why sickling takes place. You should know the reason why sickling takes place. Sickle shape का क्यों होता है? RBC की membrane में there is no problem. Inside the RBC, the rod-like structures are present. अब उस rod को accommodate करने के लिए that the RBC becomes sickle shape. Give me a thumbs up. So that is the problem. So you will say, मैम sickling में क्या problem है? रहने दो, मेरे अंदर RBC गोल है कि sickle है, मुझे क्या फर्क पड़ता है? How does it matter for a human being inside me if RBCs are circular or sickle shape? Even a normal human being don't know, layman don't know that the RBCs are circular. So if sickle shape, what is the problem? The problem is that the sickle shaped RBCs are sticky. They are very sticky. They form clumps. They form clumps and they cause obstruction. This is the problem, right? So there are three consequences of sickling. Because RBC becomes sickle shape, and they are sticky, they cause occlusion. So it results in ischemia of various organs. So the sickle shaped RBCs are there, they form polymer rod like structure. It will give classical sickle shape to the RBC and they are very sticky, very sticky. That's why they stick to each other and they form a thrombus and it causes obstruction. It causes obstruction, number one. When such sickle cell RBC passes from the spleen detected and causes the rupture of this RBC. Spleen detect that this is abnormal RBC, it is not normal. So spleen will cause the rupture. Spleen will cause the rupture. So it results in extravascular hemolysis inside the spleen, right? So it results in hemolytic anemia, patient hemoglobin will be less. Right. So these are the consequences you can understand. Patient have anemia and patient have vaso-occlusive phenomenon. Vaso-occlusive phenomenon means ischemia of all organs. Right. So ischemia of all organs. Which organs is ischemia? Most commonly ischemia occurs in the bone. The ischemia occurs in the bone. Patient have severe painful dactylis. The fingers are very painful. In the fingers and the digits we have and arteries. Na? Here only one artery is there. One. And that too occluded. That too occluded because the sickle RBCs are forming clumps here in the arteries. So patient have severe painful dactylis. It is known as hand-foot syndrome. So patient comes to you in the crisis with severe pain in the hands and the foot. That is digits of the hand and the foot. Because of the end arteries, the chances of obstruction are more here. You got my point? You got my point? That is number one. Right? Can you see the vertebra? The X-ray of the vertebra is shown here. The X-ray. So I can see this is a vertebra. This is a vertebra. Let me mark. This is, so the shape is typical fish mouth. Fish. It is looking like a fish mouth. You know, the mouth of a fish. You see here. It's looking like a fish, right? It's looking like a fish mouth appearance. Why does the fish mouth appearance? Because of the ischemia, the shape of the vertebra like this. This is also due to ischemia. This is also due to ischemia. You got my point? Now, where is the RBC formation takes place in humans? In bone marrow, right? So it takes place in all bones, the major bones. The cheekbones are one of them. You know, I'm having maxilla in the cheekbone. In our cheek, हमारे गालों के नीचे जो bone है ना, that is maxilla. So RBC formation takes place here also. So imagine if in human body RBC destruction is more. Spleen is destroying all the RBCs because all the RBCs are sickle shape. Maximum RBCs are sickle shape. So spleen is destroying all of them. So bone marrow will try to compensate. Oh my God, most of the RBCs are destroyed. I have to produce more. I have to produce more. I have to compensate. So the bone, especially the cheekbone will enlarge. So typically the face of the person is like this. This is known as prominent cheekbone. Can you appreciate the cheekbones are prominent? So as soon as the patient, the child enters in your clinic, at the door only you should identify this child is a hemoglobinopathy child. Either the child have sickle cell anemia or the thalassemia. Looking at the face, I can identify. I can have a clue at least. So I can do the diagnostic test. Prominent cheekbone अलग ही दिखते हैं ये बच्चे. You got my point? That is due to compensatory mechanism. And the compensation takes place in the skull bone also. We have skull inside which the bone marrow is compensating. So because the bone marrow is expanding to try to form more RBC, it gives like this appearance. Can you see this appearance? It is looking like hairs on a X-ray of the skull bone. It is known as crew cut appearance. So these all, yeah, hair on and appearance or crew cut, one and the same thing. Very good. So these are the, can you see the image-based questions? All these are the image-based questions on sickle cell anemia. You got my point? Give me a thumbs up if you got it. Everyone give me a thumbs up. Yes. So these all. So the bones, these things happens in the bone. What about spleen in a sickle cell anemia patient? What happens to the spleen? Spleen first enlarge because all the destruction of the RBC takes place in the spleen, and later on spleen undergo atrophy. It is known as autosplenectomy. It is also a MCQ, right? Now tell me the test for diagnosis, screening and diagnosis of sickle cell anemia. Imagine a patient in your clinic, a child in your clinic. The child, if you do the CBC, the hemoglobin of the child is very less, right? It's 6 gram, 5 gram, severe hemoglobin, less hemoglobin. And patient have hand-foot syndrome and all other features. So you are highly suspecting the patient is have sickle cell anemia. So what is the screening test? What is the screening test? You know, if you take the blood sample out in a test tube of this child and make a slide, make a smear from this blood, make a smear here. So what RBCs you can see? My point is that RBCs are not always sickle. Normally, RBCs are circular in these patients also. But at the time of deoxygenation, RBC becomes sickle shape. Normally, during oxygenated state, RBCs are circular only. So just suppose in my OPD, there is a child sitting in front of me. The child is anemic. But currently at this point, when the child is sitting in front of me in my OPD, the child is not in crisis. So basically the child is in oxygenated state. If at this moment of time, I take the blood out, it is oxygenated, so RBC is going to be circular. So how I will make the diagnosis? I cannot confirm now. Looking at the circular RBC, I cannot sure that this is a normal or the patient is not in crisis right now. To make the diagnosis, I have to give a deoxygenated state. So I cannot, I cannot stop the oxygen of the child. Like, you don't inhale for some time, I have to take your blood sample. I cannot do that now. The child is oxygenated constantly now. The child is taking the oxygen, the child is inhaling, right? I cannot stop the inhalation, the respiration of the child, of course, right? So I cannot torture that. So I have to create a pseudo deoxygenated state in this test tube. So I will put a chemical inside this, few drops of a chemical here or on the slide. So the name of that chemical is sodium metabisulfite, on which many times PYQ occurs. Sodium metabisulfite. It is a reducing agent. It will produce a deoxygenated state. If you directly make a smear, it will be circular. And if you put sodium metabisulfite and after that make a sphere, so in sickle cell anemia on deoxygenated state, the RBC converts sickle shape and your diagnosis will be confirmed. Say yes, it's a screening test. What about diagnostic test? In the diagnostic test, you will find the sickle cell, you will find Howell Jolly body, a dot-like structure, Howell Jolly body, right? The best is to do electrophoresis. You will do electrophoresis. On electrophoresis, it's confirmed that what type of hemoglobin is there. So here normally hemoglobin A is present, here hemoglobin S is present. So electrophoresis is the diagnostic test, the most important diagnostic test. Yes. So high performance liquid chromatography is equally good, as equivalent as electrophoresis only. So that's all about sickle cell anemia. Many questions come from that. So yeah, one more chemical, sodium dithionate, can also be used instead of sodium metabisulfite. You can use sodium dithionate also. Both are reducing agent, but commonly in the laboratory, sodium metasulfite is used. You got it? Afros. Can I go ahead? Can I go ahead? Okay. Okay. So coming on the next topic, that is thalassemia. So as I have told you, thalassemia is a quantitative abnormality in which the quantity of hemoglobin is not good. The hemoglobin is less synthesized because globin is less synthesized. It is of two types. If the alpha hemoglobin is not synthesized, it's alpha thalassemia. And if beta is not synthesized, it's beta thalassemia. You got my point? Whether alpha or beta. So it can be of two types. There are two alpha chains and two beta chains. So alpha is of four types. Alpha thalassemia are of four types. There are four genes now. This is chromosome number 16, the pair of chromosome number 16. Two genes are present here and two are here. So four alpha genes are present. How many of them are mutated? One is mutated, two is mutated, three is mutated, or four are mutated. So four types of alpha thalassemia are there. You got my point? If only one is mutated, it is known as thalassemia carrier, no symptom. The patient is asymptomatic throughout the life. Even patient को पता भी नहीं चलेगा कि मुझे alpha thalassemia है. It's asymptomatic because the other three are normal ना. Only one is mutated. If two are mutated, it's almost normal or mild, very mild anemia is there. Not much, mild anemia. But if three are mutated, it is known as hemoglobin H disease. It is known as hemoglobin H disease, and patient have severe hemolytic anemia, may require blood transfusion, may require. And if all four are mutated, patient even don't survive. Inside the uterus of the mother, it will die. It is known as hydrop fetalis. Give me a thumbs up. You got it? In utero only it will die. So if one gene is mutated, two is mutated, three is mutated, or four mutated, how many alpha genes are mutated? If one is mutated, it is known as alpha carrier, alpha thalassemia carrier, asymptomatic. If two are mutated, it is known as trait. Alpha thalassemia trait, mild anemia, hardly any. So hemoglobin, mild, even not bothersome, right? But if three are mutated, it is bothersome. It is known as HbH disease, hemoglobin H disease, right? And here patient may require, it is severe anemia and require blood transfusion. But if all four are mutated, patient will die. Patient will die in utero. Inside the uterus of the mother, it will die. It is known as hydrop fetalis. Everyone give me a thumbs up. The four types of alpha, not beta. Beta is of three types. I'm coming on that also. This is the classification of the alpha. I guess you got it. Let me teach you the classification of the beta. The three types of beta. Beta, minor, intermediate, major. It is of three types. Minor, intermediate, major. Right? So beta gene are only only two, not four like alpha. So if one is mutated, one is normal, it's minor, right? Here also multiple mechanisms, one is mutated, one is normal, it's intermediate. If both are mutated, it's major, right? So the three types of that also. So here I would like to stop for thalassemia. You can do the questions on the thalassemia also. Let me move ahead. Let me move to the iron deficiency anemia. Can I move to the iron deficiency anemia? Are you people there? Can I start iron deficiency anemia? Important points in iron deficiency anemia. Give me a minute. Just a second. Okay. So iron deficiency anemia. what important topics comes. So you should know the normal absorption of iron to understand iron deficiency anemia, the important topics, the important questions from iron deficiency anemia. Do you eat iron in your diet? Where is the iron present? What do you eat? What is the source of the iron in your diet? Iron is present in vegetarian diet also, non-vegetarian diet also. By the way, I'm a pure vegetarian, but yeah, both diets are good. Whether it is documented that iron is more absorbed in non-vegetarian diet. In vegetarian diet, it is present in green leafy vegetables. It is present in good, So it is present in jaggery. Many sources are there. In non-vegetarian diet, it is present in meat, especially in red meat. Okay. So whatever iron you are taking in diet now, whether vegetarian or non-vegetarian, it is ferric iron, Fe3 positive. So you are, yes, green leafy vegetable is palak only, right? So spinach, palak, good, that is jaggery, I told you. So whatever iron you are eating, it is ferric. So you are eating it, it is going in your mouth, it is going in your esophagus, it is going in your stomach. But the problem is that this is the cell of the intestine which will absorb iron. Can you see? This is the cell of the intestine. It will absorb iron. It will absorb only ferrous iron, not ferric. Fe3 positive को absorb नहीं करेगा, Fe2 positive को करेगा. So you have to convert Fe3 positive to Fe2 positive. That is ferric to ferrous first. So this conversion takes place in the stomach. The HCl of the stomach converts ferric to ferrous. Can you see? The HCl of the stomach is converting ferric to ferrous. Say yes, ferric to ferrous. And this ferrous iron is now coming into the intestine. In the intestine, this is a cell of intestine. Just behind the cell of the intestine, you can see a blood vessel. Can you see? This is a blood vessel. This is the blood vessel here. So if you want to absorb iron here, so two transporters are required. The first on the luminal side, this one, and second on the basolateral side, this one. So first iron will be absorbed from the lumen inside the cell, and from inside the cell, again it will move into the blood vessel. So this transporter is DMT, divalent metallic transporter. It takes only divalent iron. That's why we have converted ferric to ferrous. And the second transporter is ferroportin. The second transporter here is ferroportin that will take the iron from the cell into the blood vessel. After going in the blood vessel, iron requires a transporter. The iron require a vehicle like a car. Iron don't walk like this, right? Iron require a vehicle. The vehicle, the transporter of the iron is transferrin. Transferrin is the transporter of the iron. Iron will sit on the transferrin and transferrin carries the iron in the blood here and there. So iron is required in the bone marrow for the synthesis of hemoglobin. So all the iron is given here in the bone marrow. Whatever remaining, it will go to the liver and stored in the liver in the form of the ferritin. So ferritin is the storage form of the iron. Two MCQs come here. What is the storage form of iron? Answer is ferritin. And what is the transporter of iron? Transporter of iron. So answer is transferrin. Everyone give me a thumbs up. Two types of iron are given here. The transporter of iron is transferrin and the storage form of iron is ferritin. Do you have any doubt? These two are your MCQs. You have to learn that. Right. Now, okay, factors you can do. Clinical symptoms you already know, anemia, weakness, fatigue. But the important clinical feature on which MCQ come here is in the nails. In the nails, there is koilonychia. You know, spoon-shaped nails. Can you see the shape of the nails here? It's spoon. It's like spoon, spooning of the nails. It's known as koilonychia. Koilonychia is the spooning. Koilonychia is the spooning of the nails. You got my point? So many times image-based question can come here. This is the normal tongue. The normal tongue is shiny, right? See your tongue in the mirror. It's shiny, it's glossy, it's good. But see, the tongue in iron deficiency anemia become atrophic. It become atrophic. You can see the change here, right? And the angles of the mouth become inflamed. It's known as angular stomatitis. Angular. So these are the symptoms on which image-based question can come in your exam, and you must be aware of that. You must be aware of that. Can we go ahead? Okay. One more important thing you have to learn in iron deficiency anemia is Plummer-Wilson syndrome. Plummer-Wilson syndrome. Have you heard about it? Yes, Kelly-Brown syndrome, Prince. The Plummer-Wilson syndrome, one and the same thing. It's a triad of three things. One of them is iron deficiency anemia. One of them in the esophagus, the rings, the valves are present in the esophagus. And because the esophagus have the valves, the patient tried to chew and swallow anything, patient have pain while swallowing. It is known as dysphagia. What is dysphagia? Pain on swallowing. Just suppose if I'm chewing anything and trying to swallow it. When I swallow, I'm having pain in the esophagus because the esophagus have the constrictures, the valves, right? So this triad is known as Plummer-Wilson syndrome. So along with iron deficiency anemia, sometimes patient develops esophageal valves, because of which the patient have dysphagia. And this typical triad is known as Plummer-Wilson syndrome. It's your PYQ. You must understand the triad of Plummer-Wilson syndrome. What is the triad here? What is the triad of Plummer-Wilson syndrome? Say it. Can you tell me what it is? So it is iron deficiency anemia, esophageal VAPS, and dysphagia. You have to learn it. Are you people there? Give me a thumbs up. Awaken, sleeping. We will do some polls here and move to the next chapter, that is leukemias. Right? So, okay. The first question is in front of you. The first question is in front of you. Can you tell me the answer? The earliest sign of iron deficiency anemia. As soon as the person develops iron deficiency anemia, what will happen? What will happen to that person? Is it increase in binding capacity, decrease in serum ferritin level, decrease in iron serum level, or all of the above? Or all of the above? What would you say? So I have told you that ferritin is the storage form of the iron. It's a backup. So as soon as the person develops iron, just suppose from today I'm not eating iron in my diet. I stopped eating iron in my diet, just for suppose. So what will happen? Today I will develop iron deficiency anemia. No, no, no. I will not develop iron deficiency anemia today because I'm having a backup in my liver. In my liver, there is a storage form of iron, ferritin is present. This ferritin will give iron to the bone marrow for synthesizing hemoglobin, right? So for many months, many days, I'm having the backup. Even if I don't take iron in my diet, for the next few months or few days, I will not have any problem, right? Once the ferritin is decreased, the ferritin is completely utilized. And now I don't have any ferritin. Then the RBCs which are formed, that will be defective, microcytic, hypochromic, and person develops iron deficiency anemia, the symptoms of that. So the earliest thing, hemoglobin to baad mein kam hoga. The earliest thing, ferritin drop hoga. So ferritin is the most sensitive marker for iron deficiency anemia. Just suppose I want to test in myself whether I'm having iron deficiency anemia, yes or no. It may happen that my hemoglobin is normal, but if my ferritin is less, I have not developed it yet, but I'm about to develop. You got my point? So before falling hemoglobin, ferritin levels fall. And common sense, you can understand why ferritin is falling before hemoglobin. Because ferritin is the backup now. So first body utilize all the backup. Jitna bhi backup hai. Once backup is completed, then hemoglobin start falling. Say yes if you got it. So most sensitive marker for iron deficiency anemia is always ferritin, not hemoglobin. So that was the question, and you can mark it ferritin. So I guess, okay, we must move ahead to the next topic, that is leukemias and lymphomas. So give me a minute. Yeah. So let me move on the leukemias and lymphomas. So for understanding leukemias and lymphomas, you must understand the 5 types of WBCs. What are the 5 types of WBCs? So there are 3 types of granulocytes and 2 types of agranulocytes. So total 5 types of WBCs, they are in front of you. Granulocytes are the WBCs which have granules in their cytoplasm. So if the granules are pink and purple, you can see it is neutrophil. If the granules are red color, it is eosinophil, and if the granules are black or dark blue color, it is basophil. So these 3 are granulocytes, you can see. And if WBC don't have any granules in their cytoplasm, you can see no granules, no granules. It's either lymphocyte or monocyte. So lymphocyte and monocyte don't have any granules in the cytoplasm. Say yes. So it's about the WBCs. You know the 5 type of the WBCs, right? Now, please tell me how these 5 type of WBCs are formed in the bone marrow. How does these 5 type of WBCs are formed in the bone marrow? So see, a simplified version. Most of the students, I guarantee, they don't understand leukemia. They are afraid of leukemia, and from leukemia, image-based questions come in your exam. Usually, either classification or image-based question, very commonly asked. So I'm going to tell you the most easiest way to understand leukemia, but please everyone concentrate here on your gadgets. Please everyone. So listen. There is hematopoietic stem cell in the bone marrow. From the hematopoietic stem cell, 2 blasts are formed. 2 blasts. Blasts are formed. 2 blasts. One is myeloblast, one is lymphoblast. One is myeloblast, one is lymphoblast. You got my point? Myeloblast give rise to 4 type of WBC out of 5. It give rise to neutrophil, eosinophil, basophil, and monocyte. Which is left? Only lymphocyte. So lymphoblast give rise to lymphocyte. So this is how the 5 type of WBCs are formed in the bone marrow. Out of the 5 type of WBCs in the bone marrow, the first 4 types are formed from the myeloblast. And the last one, that is lymphocyte, are formed from the lymphoblast. Give me a thumbs up on this point. If you understood this now, you will understand all type of leukemia. Have you understood this? Have you? Everyone? Anuj, Prince, Saad, Shashi, everyone. Please, everyone. Give me a thumbs up. You got it? So the 2 type of the blast, the myeloblast, the lymphoblast. So this is how the WBCs are formed. You must understand the precursors also. So in this series, myeloblast, the most important is the neutrophil. And from lymphoblast, only one is there, lymphocyte. So you must understand the precursors also. So first is myeloblast, then it will give rise to promyelocyte, it will give rise to myelocyte, metamyelocyte, band form, and finally neutrophil. Right? Lymphoblast give rise to prolymphocyte and finally lymphocyte. Right? Now this is the blood vessel. This is the bone marrow and this is the blood vessel. So after forming the mature form, that is neutrophil and lymphocyte will come in the blood. Immature forms do not come in blood. In my bone marrow, these all are present. In your bone marrow, these all are present. But in our blood, we have the mature forms. We don't have immature forms in our blood. My point is that. Please understand again. In our bone marrow, blasts are present. Myeloblast, lymphoblast, these are the immature forms. The blasts are present in the bone marrow. I'm having blast in my bone marrow. You are having. It's normal. But in our blood, there is no blast. There is no blast. Arrival of the blast in the blood is leukemia. You got it. You got it. What is leukemia? Arrival of the blast in the blood. Blast in blood. Blast in blood. That is leukemia. Normally, blasts do not occur in blood. Blasts are present in bone marrow. It's a normal thing. But once the blast become so abnormal, they are dividing, uncontrolled mitosis is there. So blasts leave the bone marrow and they just come in the blood. And this is known as leukemia. You got it? Say yes. Yes, 20% is the cutoff. So if 20% of the blast come in the blood, that is the WHO definition of the leukemia. Right? Now, from the blood, if they enter in solid organs, can you see? Usually the liver, the spleen, and the lymph node or the bone marrow. So not bone marrow, these are the three organs, right? So if from the blood they enter in solid organs, they form mass in the solid organ. It is known as lymphoma. So what is leukemia? Leukemia is blast in blood. And what is lymphoma? Lymphoma is blast in solid organ. Say yes. Blast in bone marrow is normal. Blast in bone marrow is normal. But if blast is coming in the blood, it's leukemia. And from the blood, if blasts are moving to the solid organs, it's known as lymphoma. You got it? So this is leukemia and lymphoma, right? So you got it? Leukemia is a problem of the blood vessel. It is a blood cancer. And lymphoma is not a blood cancer. Lymphoma is a cancer of the solid organs. Lymphoma is the cancer of the solid organs. So leukemia is a cancer of the bone marrow and lymphoma is a cancer of the solid organs. Now, tell me the classification of leukemia. You got it. What is leukemia, lymphomas? So, depending which blast is coming, let's talk about leukemia. Let's first talk about leukemia. Which blast is coming in the blood? Two types of blast are there, na? Myeloblast or lymphoblast. If myeloblast is coming, it's known as myeloid leukemia. Myeloid leukemia. If lymphoblast is coming, it's known as lymphoid leukemia. The two types of leukemia. Very easy. So basically, leukemia is blast in the blood. So which blast is coming? Myeloblast or lymphoblast? If myeloblast is coming, it's myeloid leukemia. If lymphoblast is coming, it's lymphoid leukemia. Now, whether it is acute or chronic, acute or chronic, there are four types of leukemia. Acute myeloid leukemia, AML. Chronic myeloid leukemia, CML. Acute lymphoid leukemia, ALL. And chronic lymphoid leukemia, CLL. So this is the classification. You got it? So if myeloblast is coming, it's myeloid. If lymphoblast is coming, it's lymphoid. Now, whether it's acute, chronic, you can see the four types of leukemia. AML is acute myeloid leukemia. CML is chronic myeloid leukemia. ALL is acute lymphoid leukemia and CLL is chronic lymphoid leukemia. Right? This classification, if you understood, half job is done. The next other half job, it's based on the which blast. You must be able to understand the blast. Imagine this is my patient. I'm suspecting the patient is having one of the four leukemia. So what I will do, I will take the blood sample of this patient and I will make a smear. From this blood sample, I will make a smear. I will see the smear in the microscope. Now I can see the blast inside that. I should be able, the first thing should be able to identify whether it is a myeloblast and lymphoblast. Then I can identify which type of leukemia is it. Because the classification of leukemia depends on the type of the blast. So see the two type of the blast. Myeloblast, lymphoblast, the diagrams are given to you. Myeloblast is larger, lympho is smaller. First thing you can see in the diagram. The most important difference is iron rod. Iron rod. What is iron rod? Iron rod is a red color, rod-like structure. It is known as iron rod. It is present in myeloblast, iron rod, but it is absent in lymphoblast. So looking at that, you can identify whether the blast is myeloblast or lymphoblast. Everyone give me a thumbs up. You got my point? You got my point? So you have to see whether it's myeloblast or lymphoblast. So your patient is in front of you. You just take the blood sample, make a smear, look at the smear in the microscope. In the microscope, if you see the blast, the first thing your eyes should be trained whether it is a myeloblast or lymphoblast. If it is a myeloblast, it should have an iron rod in the cytoplasm. Lymphoblasts don't have iron rod in the cytoplasm, right? So this is how you classify. Now, आधा काम तो हो गया ना, whether it is myeloid leukemia or lymphoid. The second, you have to see whether it's acute chronic, right? So this is how we classify leukemias. You got my point? So I will show you the next point. I will show you the blood picture of the 4 types of leukemia, because image based questions are very common in all competitive exams from leukemia, and most of the students lack here. I have seen students have a much problem in solving the image based questions based on leukemia. It's very easy. We will start in this sequence. I will teach you CML ka picture, then I will teach you AML ka picture. So myeloid is done. Then we will come on lymphoid. In the lymphoid, first I will tell you ALL. And then in the end, I will tell you CLL. So in this sequence, I'm going to teach you the 4 pictures. Let's start with CML, chronic myeloid leukemia, right? Can you see this is CML? In CML, what you can see in the blood? A beautiful picture I have drawn for you. Beautiful picture. Listen, I have told you now, in the bone marrow, this is the hematopoietic stem cell. It is giving rise to myeloblast and lymphoblast. What are the precursors ahead? Myeloblast give rise to what? It gives rise to promyelocyte, myelocyte, metamyelocyte, then band form, and then neutrophil. I told you to learn the complete sequence, if you remember, right? Actually, and this is a blood vessel. Let me draw a blood vessel. All of these, including myeloblast, it is coming in blood. Myeloblast to aa, that's why it is myeloid leukemia. Myeloblast to aa blood mein. Myeloblast is coming. But myeloblast is not coming alone. It is coming with a party. Everyone. बोल रहे तुम भी चलो, चलो सब चलेंगे. Everyone come. So everyone is coming in the blood. So if you are taking the blood in a test tube and making a smear, this is the smear. Everyone is doing a party. Everyone is there. Everyone. कौन hai? Who is there in the party? Everyone. So there is a promyelocyte, there is a metamyelocyte, there is a band form, there is a basophil, eosinophil, neutrophil, everyone is there. So it is looking like a, it is looking like different type of cells. All type of cells are there, right? Including myeloblast. Yes, it's known as garden party appearance. Very good. In the garden party, everyone is in different dress. Everyone is in different dress. That's why the different type of the cells. It's typical CML. It's typical CML. I can see one of the eosinophil with red granules. Yes. I can see one of the basophil with black granules. Yes. I can see one of the neutrophil with purple granules. Yes. I can see few band forms. Band forms are C-shaped. Apart from that, I can see the blast. I can see promyelocyte, myelocyte. Even if you can't identify कि कौन सा cell क्या है, don't worry. भाड़ में जाए. Multiple cells are there, na? It's CML. It's CML. Give me a thumbs up, everyone. Yes. Are you people there? Can we go ahead? Okay. Yes, except lymphocyte, it's everyone. Yes, absolutely right. Absolutely right. Bharat, absolutely. So coming on the next. The next is AML. In AML, only myeloblast will come. Where is the next diagram? Okay, I will draw it again. So, you know the sequence again. It's hematopoietic stem cell. It gives rise to myeloblast, it gives rise to lymphoblast. Myeloblast gives rise to promyelocyte, myelocyte, metamyelocyte, band form, and neutrophil. So here in the blood vessel, everyone is not coming. Only myeloblast is coming. Not all are coming, only myeloblast. So it is known as AML. If only lymphoblast is coming, it is known as ALL. And if everyone is coming, it was CML. It was CML. You got it. I guess everyone got it. If all are coming, it's CML. If only myeloblast is coming, it's AML. If only lymphoblast is coming, it's ALL. CLL बताती हूँ. CLL में इनमें से कुछ भी नहीं आएगा. No one will come in the CLL. CLL में क्या होगा? I will tell you separately. First, understand these 3. You got it? Give me a thumbs up. Right. So in AML, I can see only one type of cell. It's known as school appearance. In school, everyone is in uniform, na? Everyone is same. The CML was like college appearance. Everyone was in different dress. The garden party, college, whatever you say. But here everyone is the same uniform. Everyone. I can see only one type of cell, not multiple. So this, and the one type of cell is what? If you can see, zoom the image, and if you can see in the cytoplasm, I can see red color rods. Oh my God, what are these? These are iron rods. In few of the cell, I can see iron rods. So definitely iron rods are present in myeloblast. They are not present in lymphoblast. Right. So these cells are myeloblast. In some of them, iron rods are noticed. So of course, it's a diagram of AML. You got it? Can we go ahead? Now this is the next diagram. In this diagram, again, I can see one type of cell. यहाँ पे भी एक type के cell थे, यहाँ पे भी एक type के cell हैं. Here also I can see only one type of cell, but none of the cell is having iron rod. You can see all of them are little bit smaller, scanty cytoplasm. None of them have iron rod. So I conclude these all are lymphoblast because they don't have this thing. They don't have iron rod. You got it? That's ALL. That's ALL. And the last one is CLL. Okay. अब CLL की बारी आ गई तो समझा देती हूँ. I will explain you CLL again. For this, again, I have to draw the same thing. Okay. Last time. We will revise everything here. Master diagram. Hematopoietic stem cell give rise to what? It gives rise to myeloblast. It gives rise to lymphoblast. Myeloblast give rise to promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. This is the complete sequence. Lymphoblast give rise to pro-lymphocyte. And finally, it gives rise to lymphocyte. Right? Okay. Let me draw the blood vessel. This is a blood vessel. Everyone here on the screen. If everything is coming, what is the answer? Everything is coming in the blood, including myeloblast. Everything is coming. What is the answer? I'm asking you, what is the answer? Please reply. So yes, if everything, myeloblast, promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil, everything is coming. The answer is CML. The answer is CML. If only myeloblast is coming along with iron rod is compulsory. So it's AML. It's AML. If only lymphoblast is coming without any iron rod, lymphoblasts don't have iron rod. So it's going to be ALL. It's going to be ALL. Okay. The last one, CLL. In CLL, lymphocyte, the mature lymphocyte come. Lymphoblast, blast आता ही नहीं है यहाँ. Blast don't come. The mature lymphocyte come. You will say, ma'am, mature lymphocyte तो हम में भी आता है ना. Normal humans also it is coming. Then how does CLL different from the normal? In me, my blood also I'm having lymphocyte. You are also having lymphocyte. But these lymphocytes are abnormal in the CLL patient. They are not normal lymphocyte. How they are abnormal? So the patient have 99% of the lymphocyte only. In my blood, you will get 20 to 30% of the lymphocyte. Remaining are neutrophils. Maximum we have neutrophils. 20 to 30% are lymphocytes. But here in CLL patient, you have maximum lymphocytes. The first difference, right? The second, they are very fragile. They just burst up. Normal lymphocyte, my lymphocyte don't burst up. But here in a patient with CLL, they just burst up. You got my point? And once the lymphocyte get bursted, it is known as smudge cell. Yes. So smudge cell is not a cell. Basically, it is a bursted, the ruptured lymphocyte. So basically, you got it. Shall I remove it? Okay. Can you see this is a slide? In this slide, what are all these cells? Let me mark. What are all these cells? All these cells are not blast. These all are lymphocytes. But I can see only lymphocyte. I can't find even a single neutrophil. I can't find any other cell, eosinophil, basophil. All of them are lymphocyte, right? And few of them are bursted. This one, this one, this one, this one, this one. So the bursted one are known as smudge cell or basket cell. Smudge or basket cell. So these are the two hallmarks of CLL, right? So this is the summary. No one in this world will teach you with such a simplicity, the 4 types of leukemias. No one will teach you. Everyone, please appreciate my efforts. I have given much efforts to make this concept simplified to you. Everyone, please give me a thumbs up. You got it? The 4 types of leukemias are in front of you. Can you see multiple cells here? Garden party appearance. Multiple type of cells, all type of cells, garden party appearance. Can you see in AML, only one type, in ALL, only one type. So this is school appearance, one type. This is also school appearance, one type. But there's a difference in the uniform. The uniform of the 2 schools is different, right? In AML, they have iron rods. They have iron rods in the cytoplasm. They have iron rods in the cytoplasm, right? But they don't have iron rod. ALL don't have iron rod. And these one are the college. This one, I can say, is the college. College means they have different type of cells, different type of dresses, garden party appearance. The last one is the CLL, in which 2 findings are there. The most important finding is the ruptured lymphocytes, which are known as smudge cells or basket cells. Nuclei are pale or dark? What you are asking? So nuclei are more prominent in AML, less prominent in ALL. It's not pale or dark, I don't know, but they are more prominent in AML, in myeloblast, but in lymphoblast they are less prominent. It is visible here. Yes, anything else? Can we go ahead? Can we go ahead? Give me a thumbs up. So that is a leukemia. Now let me teach you, these are the pictures I have created for you. Now let me give you the real pictures. Can you look at this picture and tell me what is the answer? In this picture, what you are looking? In this picture, what is the correct answer? I can see a band form here. I can see this is blast. I can see promyelocyte, again a band form. This is a neutrophil. So multiple type of cells I can see basically. So it's CML. It's CML, right? In this diagram, what I can see? I can see one cell only. But in one cell, multiple iron rods. So it's basically AML. Iron rod आया मतलब AML और कुछ हो ही नहीं सकता. By the way, one more thing, a myeloblast with iron rod. Myeloblast with iron rod is known as Faggot cell. It's also an MCQ. It's known as Faggot cell. Faggot cell is myeloblast with iron rod. Give me a thumbs up. Can we go ahead? Yes. This is the diagram. Can you see? These all are lymphoblasts. Only one type of cell. None of them have iron rods. Hardly any cytoplasm. Scanty cytoplasm. All of them are lymphoblasts. So this is ALL. This is ALL. The last diagram, you can see the bursted. Can you see this one is bursted? This one is bursted. The bursted lymphocytes, that is smudge cells along with multiple small lymphocytes. So it is a CLL. So I guess if any image-based questions coming in your diagram exam from the leukemias, you are able to identify it. Say yes. Say yes. Can I move ahead? Can I move ahead to the next topic? The next topic is the lymphomas. I'm going to the lymphomas. The two types of the lymphomas are there: Hodgkin's lymphoma, non-Hodgkin's lymphoma. In your exam, Hodgkin's lymphoma are more important, right? So Hodgkin's lymphoma is categorized by the presence of the RS cell. RS cell is Reed-Sternberg cell. It is a special type of cell which is present in Hodgkin's lymphoma. Hodgkin's lymphoma have RS cell. Non-Hodgkin's lymphoma do not have RS cell. So based on the RS cell, we divide whether it's Hodgkin's lymphoma or non-Hodgkin's lymphoma. Now RS cells are of 4 types. Can you see the 4 types of RS cells? Beautiful diagram, right? The first type of RS cell is known as classical RS cell, in which you can see the cell, you can see the cytoplasm. The cell have 2 nucleus. It is always binucleated. The 2 nucleus are mirror image of each other. You can see the 2 nucleus, which are mirror image of each other. Inside each nucleus, there is a prominent nucleoli. There is a prominent nucleoli. It's looking like owl eye appearance, ullu ki aankh, owl eye appearance. Can you see the 2 eyes of an owl? It's looking like that, right? It is known as classical RS cell. Give me a thumbs up. It comes for the image-based question. It can come. It can come, right? The second type of RS cell is same. The only thing, this is the cytoplasm. This is the nucleus. This is the nucleoli. But around the cytoplasm, a clear space is present, which is known as lacuna. Lacuna. Around the cytoplasm, a clear space is present, which is known as lacuna. That's why known as lacunar. Lacunar types of RS cell. Right. The third type of RS cell having multi-lobated nucleus. The nucleus. It's looking like a popcorn. Do you eat popcorn? Right. You may be eating. So you know the popcorn, how does it look like? How does the, popcorn look like? So it is multi-lobated, looking like a popcorn. It is also known as popcorn RS cell or LNH. That is lymphohistiocytic RS cell or LH cell or popcorn cell. You got it? The last one having multiple nucleus. Multiple nucleus. It is known as pleomorphic. So the 4 types of RS cells are in front of you, right? So the 4 types of RS cells: classical, lacunar, popcorn or LH, and pleomorphic. You have to learn the 4 types of RS cells. Now let me classify Hodgkin's lymphoma. Hodgkin's lymphoma are of 5 types. RS cells are of 4 types, but Hodgkin's lymphoma are of 5 types. I will tell you which RS cell is present in which type of Hodgkin's lymphoma. You have to learn the classification. Many MCQs are coming from the classification of the Hodgkin's lymphoma. So we divide basically Hodgkin's lymphoma into 2 broad categories. Classical type, जिसके अंदर 4 type आते हैं. The classical contains 4 types, and non-classical type, which contains only 1. So in this way, total 5 types are there. What do you mean by classical and non-classical? There is RS cell present here, they also, and here also. Because RS cells is present, then only they are Hodgkin's lymphoma. Since they all are Hodgkin's lymphoma, they all have RS cell inside them. Okay? But the immunophenotype of RS cell is different. You know, here the RS cell are CD15 and CD30 positive. That's why known as classical. They all 4 have RS cell which are CD15 and 30 positive. Right? It's a very important MCQ. But in non-classical type, the RS cell is CD15 and CD30 negative. It's CD20 positive. So that is the biggest difference between them. Everyone give me a thumbs up. So how to classify? Okay, let me tell the names also. In classical, there are 4 types. The first is nodular sclerosis. The second is mixed cellularity. The third is lymphocyte rich. The fourth is lymphocyte depleted. Lymphocyte rich and depleted, they are opposite to each other. Right? And non-classical means lymphocyte predominant. Now don't get confused between lymphocyte rich and predominant. The meaning is same, but they are different variant. Let me classify again. For those who are confused, let me classify again. Lymphoma. The lymphomas are of 2 types. What are the 2 types of lymphomas? Can you tell me the 2 types of lymphomas? Hodgkin's lymphoma, non-Hodgkin's lymphoma. right? Based on the RS cells. Here RS cells are present, here RS cells are absent. Now Hodgkin's again is of two types. What are the two types of the Hodgkin's? Classical and non-classical. Classical and non-classical. Based on the immunophenotyping of the RS. Here RS cells are CD15 and CD30 positive. Here they are CD15-30 negative but CD20 positive. So RSL is present but immunophenotyping is different. So you have to classify accordingly. Here 4 variants are there. Here 1 variant, total 5 variants. Everyone give me a thumbs up. Everyone. So these are the 5 variants. You have to learn this ultra important master table. That's it. ये master table याद की तो lymphomas का question तुम्हारे pocket में. So these are the 5 types. The first 4 are classical. Nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted. These 4 are classical. See here in all of them, the RS cell is CD15 and CD30 positive. In charo mein, you can see CD15 positive, 30 positive, 15 positive, 30 positive, 15 positive, 30 positive. But see the last one. See the last one. The last one in lymphocyte predominant one. It is non-classical type. Non-classical have only one type. Here the RS cell is CD15 negative, CD30 negative, and CD20 positive. Right? These all are your lines से MCQs and PYQs and you have to understand it. You have to. There is no escape. कोई shortcut नहीं है यहाँ पे. Right? So it's CD20 positive. So that is the 5 type. The first thing you must understand. The second thing you have to learn, which is the most common. Most common among the 5. There are total 5 types now. Which is the most common? It's an MCQ. So there are 2 questions. Most common in the world. It's nodular sclerosis. And most common in the India, it's mixed cellularity. In the world, it's second most common. You got my point? So there are 2 PYQs in your papers. Most common in the world. If not mentioned anything, you consider world only. Most common if it is asked, you consider they are asking in the world if nothing is mentioned. But if they are asking most common in India, the answer is different. You will get the 4 options from these only. Most common in the world, answer is nodular sclerosis. Most common in India, it's mixed cellularity. Actually, mixed cellularity is second most common in the world. ये 2 हो गए. तीसरा MCQ, most common in HIV patients. In HIV, it's not this, it's not this. In HIV, the most common is this one, lymphocyte depleted. Lymphocyte depleted. It's also a MCQ. So you got 3 MCQs here. Okay. Say yes. Say yes. Now, what about male and female predominance? So all of them are more common in males. Unfortunately, they are more common in males as compared to females. Only one is equal in male and female. It is a very important MCQ. Which among the following is equal in male and female? Answer is nodular sclerosis. I'm putting MCQs in front of you. Say yes. Yes. You got it? You got it? Now I have told you the 4 types of RS cell. Tell me the type of RS cell in each of them. So, the nodular sclerosis have lacunar type of RS cell, having a lacuna around, the space around, the lacuna. Remembering the diagram? The mixed cellularity and lymphocyte rich, they both have classical. This is also classical, the aula appearance. This is also having classical, the aula appearance. The lymphocyte depleted one have pleomorphic. The pleomorphic, the last one, multiple nucleus. And lymphocyte predominant have popcorn wala. Popcorn, that is LNRH. इस पे you can't imagine कितने MCQs आते हैं. You can't imagine. You can check your PYQs if you don't believe me. So which type of Hodgkin's lymphoma have which type of RSL, you have to learn. I have shown you diagrams also. You can draw the diagrams, small diagrams here. Say here, yes. The next point is EBV. EBV virus ka association. Which of these are caused by EBV? The first and the last don't have any association with EBV. No, they are not caused by EBV. But the middle 3, they have association with EBV. So learn like that. The first and the last, no association. The middle 3 have association. You will not forget now, right? The next is the prognosis. The first and the last have excellent prognosis. The first and the last have excellent prognosis, right? Here it's good. Here, good. This one is poor. This one is the worst. This one is the worst. So learn first and the last is the excellent. Usme bhi zyada excellent the last one. The last one, the most excellent prognosis. And usi ke paas wala, this one is the worst. So you have to learn that. You have to learn that, right? So that is the important question coming from the Hodgkin's lymphoma, right? Can we move ahead? Can we move ahead? So leukemias and lymphomas are done. I guess the hematology is done. I guess the hematology is done. It's time to start the systemic pathology. So in systemic pathology, I will tell you only important topics, right? I cannot teach you complete pathology in one day. Of course, it's a major subject. But yeah, important points will be covered here. We have covered many important topics in the hematology, anemias, leukemias, lymphomas. You can imagine, if you study this yourself, you will require the complete day. But I have covered in 1 and 1.5 hours, right? So, okay. Okay, so in systemic pathology, we will be starting with blood vessel, move on CVS, move on respiratory, move on kidney, move on GIT, move on liver. So we will be taking the topics in this sequence. So let's take a break of 5 minutes. And then we will be starting the systemic pathology. So currently it's 7:51 right now. I can see this time in my watch. So it's 7:51. I will be starting at 7:56 or 57. Let's take a break for 5 minutes and we will be back. So I'm not ending the session. The session will be on only. On this link only you have to click. There is no another link. On this link only I will come live, right? So I'm muting myself and I will come live just after 5 minutes. Just take a break for 5 to 6 minutes. Okay. Hello, am I back? Can you see me? Can you hear me? Is everything good? If everything is good, can you give me a thumbs up in the chat box so I can start it ahead? Are you people there? Anyone can see me, hear me? Is it good? Okay, thank you, Rani. Thank you. So thank you for replying. So I guess we must continue with the systemic pathology. So we have already covered general, we have already covered hematology. Let me continue with the systemic pathology, the important topics in the systemic pathology before ending this session, right? So let me start with the blood vessel. In the blood vessel, the first important topic, I will be taking only important topic in the particular system. So let me start with the atherosclerosis. To understand the atherosclerosis, you must know that in the wall of a blood vessel, there are three layers: tunica intima, tunica media, and tunica adventitia. Intima, media, adventitia. So you can see the three layers. The innermost is the tunica intima, the middle is the media, and outermost is the externa. So you can see the same here. So this one is the lumen here. This one is intima. My point is that just intima is made up of two things: the endothelial layers, and just below the endothelial layers, there is subendothelial tissue. So two things constitute the intima: the endothelium and subendothelial tissue. These two together known as intima. After that, the thickest one is the media, and the outermost one is the adventitia. So you may be knowing that. Now, what is atherosclerosis? Do you know what is atherosclerosis? So you can see this is a blood vessel. So normal blood vessel, the lumen is empty and lining is smooth, the endothelial lining. But if any fibrofatty plaque is formed, can you see there is a fibrofatty plaque? You can appreciate this fibrofatty plate. This fibrofatty plaque is protruding into the lumen and causing the obstruction in the flow of the blood, right? So that protrudes into the lumen and causes the obstruction. It is known as atherosclerosis. Now, my point is that I'm asking you a question. You know the three layers: intima, media, externa. You tell me this atherosclerotic plaque is formed in which layer? Is it formed in intima? Is it formed in media? Or is it formed in externa? So this fatty plaque, that is atherosclerotic plaque, is formed in which layer? I'm asking you this question. Do you know the answer? Yes, it is formed in intima. In the intima, I told you there are two things: endothelium and subendothelium. So just in the subendothelium, can you see this is the endothelial lining? Just below the endothelial lining, it is formed. So it is a disease of intima. It's your MCQ. Most of the students do mistake here. They take as media. No, atherosclerosis is not a disease of media. Atherosclerosis is a disease of intima. It's your MCQ and you will not forget it. Now I have highlighted and you will not forget it. So in human body, several arteries are present. So it most commonly it affects which artery? Do you know the sequence? Yes. So the first most common artery affected is abdominal aorta, followed by coronaries of the heart, followed by popliteal artery, followed by descending thoracic artery, followed by internal carotid artery, right? And followed by cerebral artery, circle of Willis. You will say, ma'am, it's difficult to learn the sequence. Don't worry, I'm having a mnemonic for you. So what is the mnemonic here? The mnemonic here is ACP Delhi traffic is cute. ACP Delhi traffic is cute. It's a mnemonic, right? So A stands for abdominal aorta, C stands for coronaries of the heart, P stands of course for popliteal artery. Delhi ka D and T, Delhi traffic stands for DT, descending thoracic. Delhi traffic, descending thoracic. Say it again: Delhi traffic, descending thoracic. Is ka I is internal carotid and cute is cerebral or circle of Willis. So you can say ACP, Delhi traffic is cute. You will try to say the full form. It's very easy. Abdominal aorta, coronaries of the heart, popliteal artery, descending thoracic. DT is descending thoracic, right? I is internal carotid and C is circle of Willis. Everyone give me a thumbs up. Everyone. So the sequence is very important for your MCQs. You may be knowing the risk factor of the atherosclerosis. Some of them are modifiable, some of them are non-modifiable. Modifiable one, you can modify. You can decrease the obesity, you can control the lipid profile, you can control the hypertension, diabetes. But non-modifiable, you cannot change your age, right? Whatever is your age, you cannot decrease it, right? You cannot change the gender. It is more common in males, so of course it's more common in male. You cannot change the gender. So it's more common in type A personality. You cannot change the personality. So these are the non-modifiable risk factors, right? So yeah, one more important recent discovery: there are three organisms, infectious organism, which are the risk factor of atherosclerosis. Can you name them? One is bacteria, two is virus. One is bacteria, two is virus. I'm repeating, total three organisms. The bacteria is chlamydia. The bacteria is chlamydia pneumoniae. And two viruses is cytomegalovirus and herpes virus. So chlamydia, cytomegalovirus, and herpes simplex virus. These three are the microorganism which increases the risk of atherosclerosis. This question is recent. It is an highlight. There is high probability this question can come in your exam. You know, it is a recent discovery. You must know about it, right? That is the atherosclerotic risk factors. Coming on the next topic. Next topic is aneurysm. Do you know what is aneurysm? Do you know what is aneurysm? Aneurysm is protrusion in the wall of a blood vessel, a protrusion, you know. So focally, this point of the wall is weak. So that's why it protrudes out. So it is due to the weakness of the wall. If the wall of the blood vessel is weak, it just protrudes out. So protrusion in the wall of the blood vessel is known as aneurysm. Due to the weakness of the wall, it just protrudes out. It is known as aneurysm. Aneurysm. So, okay. What is the classification of the aneurysm? We classify aneurysm by three ways. The first way is depending on the composition of the wall. Can you see? This is a normal blood vessel having the three layers. You can see this is intima, this is media, this is externa. I can see the three layers, right? If all the three layers are protruding out, give me a minute. Okay. If all the three layers are protruding out, intima, media, and externa, it is known as true aneurysm. So the wall of the aneurysm is made up of all three layers, intima, media, externa. It is known as true aneurysm, right? Imagine other situation, there is a injury here. In the wall of the blood vessel, there is an injury. Due to the injury, there is a defect. Due to the injury, there is a defect. So what will happen? Of course, blood will come out. The blood will come out. To withhold the blood, body will form a connective tissue. A connective tissue so that bleeding stop temporarily, right? So it is basically a hematoma. It is not an aneurysm, but it looks like aneurysm. दूर से देखो तो ऐसा लग रहा है कि protrusion है, but it is not a protrusion. The wall is formed by connective tissue. The wall is not formed by tunica, intima, media, and externa. You got my point? So it is known as false aneurysm or pseudo aneurysm. Give me a thumbs up. So based on the composition of the wall of the aneurysm contains tunica, media, intima, and externa. It is known as true aneurysm, and the wall of the aneurysm is made up of connective tissue. It is not a true aneurysm, it is a pseudo or false aneurysm. Give me a thumbs up. You got it? You got it? So this is the aneurysm, the two type of the aneurysm, true and false. You can get MCQs on that. The second is the depending on the shape of the aneurysm. The shape can be circular like this. It is known as secular. It can be on everywhere. It can be circumferential. So it is known as fusiform. It can be parallel. It's cylindrical like a parallel. It can be multiple small dilatation. It's known as serpentine, and it can be interconnected arteries. It is known as racemose. So these are the 5 different types of the shapes of the aneurysm, right? And the third most important classification is based on the pathogenesis. I told you aneurysm occurs because of the weakness of the wall. So you have to tell me what is the cause of the weakness. What is causing the weakness? What is the cause of the weakness that is causing the aneurysm? There can be 3 causes. The most important is the atherosclerosis. We have just seen atherosclerosis. So if atherosclerosis is causing the weakness of the wall, it is known as atherosclerotic aneurysm. The second is the syphilis. Syphilis wala is known as lutic. The syphilis aneurysm is known as lutic aneurysm. So syphilis is causing, syphilis is caused by a bacteria known as Treponema pallidum. That is causing the infection of the wall, because of which the wall is weakened and it protrudes out. So that is syphilis or lutic aneurysm, right? And the third one is the mycotic. Now it's a misnomer. Mycotic dekh ke you may feel like it's fungus. Mycology is fungus, na? But no, not only fungus, any infection. It can be bacteria, it can be virus, it can be parasite, it can be fungus. The 4 microorganism, anything. If there is a blood vessel and blood vessel got infection, the wall of the blood vessel is infected either by a bacteria or by a virus or by a parasite or by a fungus. So that portion of the wall become weak because of infection. And such aneurysm, such protrusion because of the infection is known as mycotic aneurysm. So there can be 3 types of aneurysm depending on the pathogenesis. So we have seen the classification. Definition is important. Classification, the 3 types of classification, true and pseudo, and depending on the shape, depending on the pathogenesis, you may be able to classify aneurysm. After that, the next important topic, in the atherosclerotic aneurysm, among them, this is the most common cause. The atherosclerotic is the most common. 90% of the aneurysm are atherosclerotic aneurysm only. Tell me the location, where they are. Tell me the location. They are present in aorta. Do you know the complete aorta? Okay, this is the heart. This is the left ventricle of the heart. Left auricle, left ventricle. From the left ventricle, the aorta comes out like this. Like this. This is the aorta. So this is known as ascending aorta. This is known as arch of aorta. And this is known as descending aorta. We divide descending aorta into 2 portions. This one is thoracic descending aorta because it is in thorax, above diaphragm, and this one is abdominal. Abdominal is below diaphragm. We divide abdominal aorta again into two parts. You may be knowing this, I guess, right? This is the renal artery supplying to the kidneys, right? So abdominal is divided into two parts, suprarenal and infrarenal. So you can see the complete aorta, ascending aorta, arch of aorta, descending aorta. In the descending, it's thoracic, it's abdominal. In the abdominal, it's suprarenal, it's infrarenal. Give me a thumbs up. So my question to all of you, can you tell me the location of the atherosclerotic aneurysm, where it happens in the aorta? Exact location. Sirf aorta bolna is not sufficient at your stage. You should tell me which portion of the aorta. So it's descending aorta. It's abdominal aorta, and in the abdominal, it's infrarenal. Let me draw it here. Here, it's infrarenal. So what is the exact location you say? Is it ascending? No. Is it arch? No. Is it descending? Yes. In the descending, is it thoracic? No. It's abdominal. Yes. In the abdominal, it's infrarenal. To be very specific. Give me a thumbs up. So it's the most common location is the infrarenal abdominal aorta. You can see in this diagram, beautifully it is shown here. So can you see this is the atherosclerotic aneurysm? It's below renal artery. See, just below the renal artery is present. It's very important PYQ. The location of the atherosclerotic aneurysm. Can we go ahead? The syphilitic aneurysm, also known as lutic aneurysm. The syphilitic aneurysm, also known as lutic aneurysm, it occurs in tertiary stage of syphilis. Syphilis are primary, secondary, tertiary. It usually occurs in. So what is the location? What is the location? It occurs in ascending aorta. It occurs in ascending aorta, not in arch, not in descending, usually near the aortic ring. So shape is different. You can see it's in ascending. It's in ascending aorta, right? It's ascending aorta. Now there are 2 or 3 important points here. Due to this aneurysm, I'm talking about syphilitic or lutic aneurysm. If you cut the aorta from that portion, you can see this is heart, this is ascending aorta. I have cut open the ascending aorta, and this is the aneurysm. This portion is having the syphilitic aneurysm, the ascending aorta. If I see it properly, it's looking like the bark of a tree. The aorta is looking like the bark of a tree. It is known as tree bark appearance. Very important MCQ, very important. You can't forget. Tree bark appearance is seen in syphilitic or lutic aneurysm. Very simple question, repeated multiple times. Can I go ahead? Right. So you have to learn all these points from the aneurysm topic. This list is important. So what is the most common site of aneurysm? So what is the most common type of aneurysm? It's atherosclerosis. Most common cause of aneurysm is atherosclerosis, right? In the ascending aorta, most common cause is hypertension. In the arch of aorta, most common cause is again atherosclerosis. In descending, again it's atherosclerosis. So you have to learn, but syphilitic occurs in ascending aorta. That I have already told you. You have to learn that. Now coming on the next topic is aortic dissection. You know what is aortic dissection? Do you know what is aortic dissection? So you know there are 3 layers, intima, media and externa. Imagine in the intima there is a defect. Defect means hole. There is a hole. There is a defect in the intima. So what will happen? Blood will enter from the intima and blood will go in the media. Media is very thick. So blood divides media into 2 portions, inner and outer. Blood is dividing. So basically blood is doing dissection of the media into 2 portions. So 2 blood channels are there. This is true blood channel. This is true and this is pseudo. I can see 2 parallel blood vessels. One is real, one is false. You got my point? Say yes if you got it. Yes, it is the tearing. It is the chest pain radiating to the back. Very good. So this is known as aortic dissection. You got my point? So there is a tear in the intima. Blood enters through that tear and dissects the media into 2 portions. This is known as aortic dissection. The blood separates the media into 2. It is highly painful. This is the longitudinal diagram. Here you can see the transverse diagram. In the transverse diagram, you can see there is a tear. Blood is entering from the tear and dividing the media into 2 portions, inner and outer. You can see the 2 portions, inner and outer. So that is aortic dissection. Now my point is that why does that tear occur? What is the cause? So 90%, the most common cause of that tear, is hypertension. If the blood is having hypertension, it will lead to. So hypertension is the most common cause of aortic dissection. Right. So that's all about it. We will do some polls on the blood vessel and move to the next chapter, that is heart. In the heart, I'm going to teach you MI, rheumatic heart disease and endocarditis. These are the important topics in the heart. Right. Okay. We will be doing some polls here. Can you tell me the answer? Tree bark-like calcification on X-ray is seen in which of the following disease? Just now I shown you the diagram of tree bark. Is it syphilitic aneurysm? Is it aortoaortitis? Is it neurofibromatosis or is it atherosclerosis? What is the correct answer? Yes, yes, very good. It's syphilitic aneurysm. Very good. It's syphilitic aneurysm. So the correct answer here is A. Can we go ahead? Say yes if you can go ahead. Give me a minute. Okay. Okay, I'm sorry. Are people there? Right? So correct answer here is A. So tree bark, it's repeated many times. What is the most common cause of abdominal aneurysm? What is the most common cause? Is it atherosclerosis? Is it trauma? Is it Marfan syndrome? Is it congenital? Just now I told you we divide the aorta into multiple portions. This is left ventricle. So these are the three basic portions in the aorta: ascending, arch, and descending. Can you tell me the most common cause of aneurysm in ascending? The answer is hypertension. Most common cause of arch of aorta, it's atherosclerosis. And most common in descending, it's again atherosclerosis. And overall most common cause, again it's atherosclerosis. So you have to understand the question very beautifully. What's the most common cause in ascending or arch or descending? Currently they are asking in abdominal aorta. Abdominal aorta is a descending aorta. So my answer will be atherosclerosis. You got my point? You got my point. But on the contrary, if I say, what is the most common site of the syphilitic aneurysm? So your answer will be here. It's the ascending aorta, although it's not the most common cause of ascending aorta aneurysm. You got my point? Am I audible? So correct answer here is atherosclerosis, A, because it's abdominal aorta. So you have to understand the question. The next question in front of you: in aortic dissection, blood enters in which layer? Is it dissecting intima or media or adventitia or any of the above? What is the correct answer? What happens in aortic dissection? So there is a tear in the intima. From that tear, the blood enters inside and then form a parallel channel in the media. So it divides the media into two portions. Yes, you all are right. The correct answer here is media. Very, very, very good. So these are the questions. Most common cause of aortic dissection. Why does tear happens? Why does tear at all happens? So tear happens in hypertensive. 90% causes hypertension. In hypertension, tear happens and the blood can enter from that tear and divides the media into two portions. Yes, the correct answer here is hypertension. Can we go ahead? The next topic to be understand here is vasculitis. Itis. Itis का मतलब होता है inflammation. What do you mean by vasculitis? Itis is inflammation of that particular organ. So vasculitis is inflammation of the blood vessel wall. So there are three layers, na, intima, media, and externa. You can see the three layers. When these three layers got inflamed, it is known as vasculitis. So you must know the classification, only classification of vasculitis. Maximum questions will be on classification. There are two questions, two type of classification system for the vasculitis. The first on the basis of the size of the vessel, and second on the basis of the type of the inflammation, right? On the basis of the size of the vessel, there are three type of blood vessels in human body. We are having large blood vessels like aorta, like, we are having medial blood vessels, medium sized blood vessels like renal artery and all. And we are having small blood vessels like capillaries everywhere. So large, medium and small, three type of blood vessels are there based on the size. So vasculitis is occurring in which blood vessel? Is it occurring in large blood vessel? So you have only two options, TT. TT. What are the two options? TT, temporal arteritis, also known as giant cell arteritis, and Takayasu. Takayasu arteritis, also known as pulseless disease. So you must understand the classification, very, very important. Large blood vessel, only two options. Coming on medium. In the medium, you have three options. The mnemonic is PKB. The P is PAN, polyarteritis nodosa. Very important, very commonly asked. PAN is a type of medial vessel, medium vessel vasculitis. K is for Kawasaki and B is for Berger. So these are the three types of the medium. And coming on the small blood vessel vasculitis. Now the small one is again divided into two portions, ANCA positive, ANCA negative. What do you mean by ANCA? Does anyone know the full form of ANCA? ANCA क्या होता है? होता क्या है ANCA? You understand? It's anti-neutrophilic cytoplasmic antibodies, ANCA. So we all know we have neutrophils in our blood. So this is a neutrophil having multilobated nucleus, right? Now in the neutrophil, granules are present, right? So antibodies are formed against the granules of the neutrophil. That's why it is known as anti-neutrophilic cytoplasmic antibodies. That is the full form of ANCA. You got my point? Anti-neutrophilic cytoplasmic antibodies. Now it's of two types, P-ANCA and C-ANCA. Both of them are antibodies against the neutrophil. P-ANCA and C-ANCA, both are antibodies against the neutrophil. But P-ANCA is perinuclear. Can you see? It's just around the nucleus. If you can see, okay, it's just around the nucleus. That's why perinuclear. And the C-ANCA is present haphazard in the cytoplasm. See the green color. It is haphazard anywhere in the cytoplasm. So P-ANCA and C-ANCA. So you have to learn that. In P-ANCA, you have only, in C-ANCA, you have only Wagner's granulomatosis. Only one example. In P-ANCA, you have two examples, microscopic polyangiitis and Church-Strauss. So let me summarize. Don't confuse. Let me summarize. Based on the size, we divide vasculitis into 3 categories. What are the 3 categories? Can you tell me? Large blood vessel, medium blood vessel, and small blood vessel. Can you help me, please? So in large blood vessel, we have only 2 options, T and T. You will not forget. Temporal arteritis, also known as giant cell arteritis, and Takayasu arteritis, also known as pulseless disease. You should know these 2 are large. In the medium one, we have 3 options. What are the 3 options? Pan, right? Very good, very good. Pan, then Kawasaki, and then Berger. These 3 are medium. The medium blood vessels are involved. And in small, we divide them into 2 categories. Anka positive and Anka negative. Anka negative, not really important, you can leave. But Anka positive again of 2 type. Is it P Anka or is it C Anka? Which Anka? There are 2 types of Anka, na? So in C Anka, we have only one example. It's Wagner. You have to learn Wagner's granulomatosis is C Anka positive. Very important question. And in P Anka, you have 2 options. Microscopic cholangitis, you can say microscopic PAN. Dekho, PAN is medium, but microscopic variant of the PAN is small blood vessel vasculitis. Microscopic PAN and one more Chuck-Strauss. You have to learn this classification for attempting the MCQs, right? The second type of classification is based on the inflammation. There are 2 types of inflammation. Whether the granulomas are formed or necrosis happens. In the wall of the blood vessel, granuloma ban raha hai ki necrosis ho raha hai. So this classification you can skip, not really very important. So we are done with the vasculitis also. So let me come on the next topic, that is MI. So one more thing here, Reynolds phenomenon. 2-3 years back, there is a question. So I must cover Reynolds phenomenon also. What do you mean by Reynolds phenomenon? What is Reynolds phenomenon? Now, there are some people in which on exposure to cold or emotion, the hands, the digits, the finger of the digits show sequential change in color. First, it become white, then it become blue, and then it become red. So what is the sequence? White, followed by blue, followed by red. What is the reason of the sequence? This sequence change in color of this sequence is known as Reynolds phenomenon. It is known as Reynolds phenomenon. So basically it is episodic change in color, sequential change in color of the digits. So on exposure to either cold or emotional, it usually occurs in females, young females. So whenever they are very emotional, they are very sad, so this happens. Or usually it occurs in the exposure to the cold, when the fingers are exposed to some ice, cold or something like that. So this happens. So the reason for the 3 I'm telling you. So as soon as, just suppose these are the fingers, I'm the patient. I'm taking ice on my hand, on my digits. So the blood vessels undergo exposure to cold. So here the blood vessels, the arterioles undergo vasoconstriction or vasospasm. All the arteries, due to exposure of the cold, they undergo vasospasm. So no blood supply. No blood supply. That's why the reason it's ischemic or white color. It become white color. You got my point? Now blood is not coming. Pure blood is not coming. Impure blood is accumulating there. Pure aa nahi raha or impure ja nahi raha. The pure is not coming and impure is not leaving. So impure blood is accumulating here. Because it is accumulating here, it will look cyanotic or blue. So second reason. And after that, if I remove ice and again warm it, so again the blood vessel will open. It will open and entry of the blood will take place. So again it will become red. That is the recovery phase. So can you tell me the sequence? What is the sequence in the Reynolds phenomenon? The sequence is white, followed by blue, followed by red. This typical sequence takes place on exposure to the cold and emotions in some females. Not normal, it is a disease. And it is known as Reynolds phenomenon, and you know the reason for each of them. This one is due to vasoconstriction or vasospasm. This one is due to cyanosis, due to the accumulation of the impure blood, and this one is due to reopening, that is recovery, right? So you may be knowing. So last year there was a question on Reynolds phenomenon, so we have covered that also, right? Okay, let me come on the next unit. We have covered blood vessel completely. Now in CNS, I'm going to cover only one topic, meningitis. You usually get question on meningitis. Meningitis ka question, the NEET PG exam was also having now. Before that, INI-CT में भी था, and FMG exam also commonly have this question. So we can't skip the topic meningitis. It hardly take 5 minutes, but very high yielding topic, right? So in central nervous system, only one topic we will cover right now, meningitis. The central nervous system is made up of 2 things, the brain and the spinal cord. Can you see? The 2 things together known as central nervous system, the brain and the spinal cord. Now, brain and spinal cord both have 2 things, the parenchyma and the meninges. Parenchyma is the actual substance made up of the neurons. यहाँ पे पूरे neurons हैं. The neurons are making the parenchyma. The cells, the brain cells, you know, the spinal cord cells, that is neurons. That is neurons, right? The neurons, neuroglia, microglial cells, these are the cells which make the parenchyma. But what do you mean by meninges? The meninges means the covering. Meninges का मतलब होता है covering. There are 3 covering. इसके ऊपर 3 covering है. 1, 2, 3. Over the brain and the spinal cord, we are having 3 coverings that are known as meninges. So can you see the innermost is the pyometer? Yes, say yes. The innermost, which is just adhered to the brain, it's pyometer. It is chipka hua hai brain se. It is adhered to the brain and the spinal cord. The middle one is the middle one is the arachnoid. Can you see blue one? It's middle. Middle one is arachnoid. And the outermost one is the durameter. Can you see the outermost, the green color? The outermost is the durameter. So can you tell me the sequence from inner to outer? It's pyometer followed by arachnoid followed by durameter. And so there is pyometer, then arachnoid, then durameter, and outer to the durameter there is skull. Can you see the blue color skull I have drawn? Right? Skull and the vertebra. So these are the vertebra and the skull. Yes. So yeah. So that is the sequence you can see. Now what is meningitis? What is meningitis? Meningitis is the inflammation of the meninges. Inflammation of these coverings, meninges. So usually pyometer and arachnoid, the inner two are inflamed. That is known as leptomeningitis. Less commonly dura is inflamed. Dura inflammation is not very common. But if durameter is inflamed, it is known as PEQs. Dura can inflame alone, but these two cannot inflame alone. They inflame together only. So basically meningitis is of 2 types, PEQs meningitis and leptomeningitis. Right? This is the first classification, but this one not very important. Now the 3 main classification of the meningitis. Now this table is going to be a master table. You will get 1 MCQ from this table. You will get 1 MCQ from this table. Listen, the bacterial meningitis, the lymphocytic meningitis, the bacterial one is caused by the bacteria. Of course, the bacterial caused by the bacteria. Since the bacteria form pus, that's why it is known as pyogenic. So either you say bacterial meningitis, एक ही बात है, या फिर कहो pyogenic meningitis, एक ही बात है, bacteria form the pus. ठीक है? This one is acute. This one is acute. The second one is the viral. Viral is also acute. Viral is, so bacterial is acute, viral is acute, right? But the third one is the chronic. The chronic कौन कराता है? Chronic is caused by 1 bacteria and 1 fungus. I will tell you the names. So there are basically 3 types of meningitis. Can you tell me what are the 3 types of meningitis? Anyone? So the first one is the bacterial. The second one is the viral. These both are acute. Acute bacterial or pyogenic. Acute viral or lymphocytic or aseptic. And third one is the chronic. The third one is the chronic. The 3 main type of meningitis. The most important finding, whenever any patient is coming to your clinic, they all have same symptoms. Patient have fever in all the meningitis. Patient have severe headache. Patient have high grade fever or maybe in viral low grade fever, but fever is there. Patient have headache. The typical thing is the neck stiffness. Patient have stiffness on the neck on bending. Typical history given to your doctor. Whenever I bend my neck, I'm having stiffness here. I'm having. So it points towards the meningitis, right? And the fourth one, change in the mental changes, unconsciousness, coma, death can occur in case of severe meningitis. Now the point is that how you differentiate the 3 types. The treatment of all 3 is different. Now, it's bacterial, give antibiotic as a treatment. If it is viral, give antiviral as a treatment. And if it is tubercular, give DOTS as a treatment. Now, treatment is absolutely different. Come on. You cannot miss that. Symptoms of all of them are same, but treatment is different. So you have to make the diagnosis. How you will make the diagnosis? How you make the diagnosis in a case of meningitis? There is no blood test for meningitis. You have to take the CSF. You have to take the CSF out by lumbar puncture. Do a lumbar puncture. Take the CSF in the test tube like this. Can you see? This is the CSF test tube. Now, in the CSF, we will see the findings and decide the type of the meningitis. You got my point? Say yes. You got it? So see, normal CSF, if you take a CSF out of a healthy human, it's clear and colorless. Normal CSF is clear and colorless. But the bacterial one is purulent. It's purulent like pus. Can you see? This is bacterial one. It's looking like a pus. If you can see, it's not clear like water. It's like pus. It's like pus. So it's like pus here. Viral is clear. Viral one is clear. It's like normal only. But the chronic one, it will form a wab on standing. It is known as cobweb. What do you mean by wab? This is known as wab. Can you appreciate the wab? This is fibrin. This was the question in INICT, the recent INICT, the fibrin wab. Yes. So this one happens in chronic. So based on the appearance, take that in a test tube and look at the test tube. Test tube is looking like pus, or is it looking like cobweb, or is it clear? So based on that, you can decide the type of the meningitis. Is it bacterial? Is it viral? Is it chronic? Say yes, you got it. You got it. Moving to the next. So measure the pressure. Normal CSF pressure is 60 to 150 mm. Normal CSF pressure, it's 60 to 150 mm. In bacterial, it's more than 180. In viral, it's more than 250. And in chronic, it's more than 300. So all of them have more pressure, but you have to learn the values. The most important finding is the cells in the CSF. You have to look the cells. Normal CSF have lymphocyte. How many? If I take my CSF, your CSF, and measure and see the cells, it may have lymphocytes 0 to 4 lymphocytes. How many lymphocytes does it have? It has 0 to 4 lymphocytes. But in bacterial meningitis, it's 100 to 10,000. It's 100 to 10,000. In viral, it's 10 to 100. It's 10 to 100, and in chronic, it's 100 to 1000 again. Here, 100 to 10,000 neutrophils are there, and here lymphocyte and lymphocyte. So based on the cell, you can decide. Based on the cell, you can decide. Apart from which, there is glucose and protein. You can learn the normal values. Here, glucose will reduce and protein will increase. Can you tell me the reason? Here, both are normal. Here, both are normal. Almost normal. But in bacterial, the glucose is reduced and the protein is more. So imagine this is the test tube. This is the CSF present in the test tube, inside which these are the bacteria are present. Right? This is the bacteria present. Now, bacteria eat glucose. Do you know that? So, normal glucose present here is consumed by the bacteria as a nutrition. So, bacteria, the glucose level will fall here. Right? And the cell wall of the bacteria is made up of protein. So, protein level will rise. So, this is the reason why glucose fall and the protein rise in bacterial one. Viruses do not consume glucose and virus don't have cell wall. So the both things will be normal in viral one. So based on that, you can make out the questions. Can you see this one? Can you make the diagnosis? Can you see the two images and make the diagnosis? I can see it's pus-like and I can see only neutrophils. I can see in the microscopy only neutrophils. So that's why it's bacterial. That's why it's bacterial. Here in this diagram, I can see most of them are lymphocytes. So that's why it's viral, right? And here I can see the cobweb appearance. That's why it's chronic. That's why it's chronic. In the chronic, there are two causes, either TB, Mycobacterium tuberculosis, it's a bacteria, or it can be Cryptococcus. Cryptococcus, which is a fungus. So that's all about the meningitis. So we have covered CNS, meningitis also. We have covered blood vessel. We have covered meningitis. Now the next important topic to be covered here is MI. Let me start MI. Can I start MI? Can I start MI? Are you people there? Can we go ahead with the MI? So let me start with myocardial infarction, MI. Okay. So what is MI? It is the infarction, of course. So why does MI happens? Do you know the reason? Okay. So when the left ventricle contract, it gives blood to the aorta, and via aorta, blood is supplied to all the organs. We all know that. Who supplies blood to the heart? Who supplies blood to the heart for doing contraction? When heart is doing systole, blood is given to everyone. But who is giving blood to the heart? Who is giving? So the blood to the heart is given by the coronaries. Can you see this is a coronary here? This is a coronary here. So this is a coronary artery, and blood is supplied to the wall of the heart via coronaries. So imagine a situation if there is an obstruction in the wall of the blood vessel. Can you see there is an obstruction? There is atherosclerosis. There is obstruction. So what will happen? What will happen? The coronaries will not give blood to the wall of the heart. The coronaries are obstructed. So whenever any cell do not receive blood, in the morning I told you it undergoes coagulative necrosis, the first type of necrosis. Have I told you in the morning? So the wall of the heart, the cells of the wall of the heart undergo coagulative necrosis. They are dead. So just suppose this portion of the heart wall is dead. It will not participate in contraction now. And this situation is known as myocardial infarction. So that is the myocardial infarction. Most common reason is atherosclerosis of the coronary. Now the most common MCQs which come in your exam from this topic is the type of infarcts. There are two types of infarcts, transmural and subendocardial. What do you mean by that? Transmural and subendocardial. Okay, let me zoom this portion for you on next page. I am drawing the left ventricle. Understand here. This is the left ventricle, the wall of the left ventricle. This is the lumen of the left ventricle. Left ventricle ka lumen. This is the wall of the left ventricle. Now let me draw a coronary. This is the main coronary, bigger coronary, from which small coronaries are coming and supplying the wall of the heart. So can you see the small coronaries are coming and they supply from outer to inner. The wall of the heart is supplied from outer to inner side, not from inner to outer. Right? The lumen contains the blood. So the coronary is giving blood from outer to inner. Now I am obstructing the coronary. I am obstructing the coronary. Here is the obstruction. So no blood is coming in this coronary. Here is the obstruction. No blood. So since the bigger coronary don't have any blood or less blood, so less blood go here, less blood go here, less blood go here. Now this is the complete thickness of the left ventricle wall, right? Complete thickness. Let me divide the left ventricle into two portions, inner half and outer half, right? Inner half is near endocardium. This is endocardial layer. Endocardium, it's near endocardium, and outer half is near pericardium. This is pericardium. So heart have three layers, endocardium, myocardium, pericardium. I'm dividing the myocardium into two half, inner and outer. You got my point? So inner half is known as subendocardial region. It's myocardium, but it's below endocardium. It's known as subendocardial. And outer half is known as subpericardial. It's subpericardial because it's just below the pericardium. You got my point? Now you tell me, whenever there is an obstruction in the coronary, which myocardium have necrosis first? Subendocardial or subpericardial? The inner half or outer half? I'm asking you this question. The blood supply from outer to inner. तो पहले ही blood outer to inner है तो अंदर पहुंचते पहुंचते कम हो जाता है. Whenever blood is going from outer to inner side, the inner portion is already compromised. उस पे भी सोने पे सुहागा, you have compromised the coronary. So the inner half, yes. So it is not subpericardial. No, 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 no. It will start from subendocardial because the inner half is already compromised. Now, I'm saying again and again, the blood is supplied from outer to inner. So outer portion is rich in blood and it is going gradually inner, it is compromised in blood. So the inner portion is already compromised. And if you obstruct the coronary, it is completely devoid of blood. You got my point? So the infarct starts from the inner half. So it starts like this. It starts like this, right? And gradually, after starting like this, it will proceed and involve the complete wall. So you can see the two type of infarcts. If only inner half is involved, it's known as subendocardial infarct. And if complete wall is involved, it's known as transmural. So what are the two type of the infarcts? Can you tell me? It's subendocardial and transmural. Can you see here? I have drawn this diagram, beautiful diagram from the Robbins. You can see, everyone see here. This is the coronary. Right, it is open. There is no problem. There is no obstruction in this coronary. So complete wall thickness is normal. None of the cell is dead. But now the coronary is obstructed. So the infarct is starting from the inner half. Inner half. This is subendocardial infarct. Gradually, if the coronary is not open, no treatment taken, so gradually infarct will proceed, progress, and full thickness will be involved. So this is subendocardial and this is transmural. Everyone give me a thumbs up. You got it? If you got it, give me a thumbs up. Indicate that you got it. Can we go ahead? So the two type of the infarcts, it's subendocardial and transmural. The two type of the infarcts. You must understand. Transmural is full thickness and subendocardial is inner half is involved. Inner 1/3 is involved. Inner 1/3 is involved. Right? That is the thing. So that is the classification of the infarct. Give me a minute. Yeah. The next important point, how you identify the infarct grossly. How you identify the infarct grossly? Do you know something, some special stain for that? It's very important MCQ. Okay. Imagine a person is dead. Imagine a person is dead. Whenever it's a police case, the police is asking what is the reason for the death. Another person with this person, the person is saying he was having a heart attack before the death. He was having chest pain and within minutes before I carry the person to the hospital, he was dead. But the police is suspecting some foul play in this. The police is not believing the person and police want to do the postmortem. So the dead body is brought to the hospital. This dead body is brought to the hospital for postmortem, and just suppose I am the doctor performing the postmortem on this dead body. So what is my responsibility? My responsibility to take the heart out and find out whether MI is present or absent. Say yes. That is the responsibility, right? So whether the MI is present or absent. So my point is that if I take the heart out of the body, this is the heart I have taken out. I have taken the heart out in a tray, right? Now how I will find where is the infarct? We know infarct most commonly present in the left ventricle, 99%. So I will cut the heart into multiple slices. I will cut the entire heart into multiple slices. Now in each slice, if I take each slice, it will be like this. It will be like this, having two lumen. This one is right ventricle. This lumen is right ventricle and this one is left ventricle. You got it? So I have to look for the infarct here in the four walls of the left ventricle, anterior, posterior, medial and lateral. So I have to look in each slice, But you will say, ma'am, it's a very tedious job. You will take each slice and you will see in the light whether infarct is present or not. Sometimes infarct is very minute, small, dot-like. So what if you have missed? In your report, you will write there is no infarct and give it to the police. But it's not a right report. It is a wrong report. It's a false negative. Actually, the infarct you are missing. So what to do in that case? Infarcts are very small now. Sometimes we cannot see with the naked eye. Right? So what to do in that case? So in that case, there is a solution. You take a bucket. You take a bucket, fill that bucket with a red colored dye. The name of this red colored dye is TTC, tetraphenyl tetrazolium chloride. What is the name of this dye? It's tetraphenyl tetrazolium chloride. This is the name of that dye. And put all the slices, whatever you have cut the multiple slices now, all the slices here. You have put the slices, all slices here. So this TTC, the red colored dye, is taken only by the viable area, the live area, the viable area. The dead area, the necrosed area, the MI area do not take the dye. So all the viable area become red in color and dead area remain yellow in color. It will not take. So the slice will be like this. Can you see? So now I can see the infarct very clearly as a contrast. So complete red is the viable area. Complete red is the viable area. And yellow, the yellow one is the dead area. Give me a thumbs up. Yes, you are right, Prince. Yes. So this is the TTC. TTC is very important, tetraphenyl tetrazolium chloride. Everyone give me a thumbs up. So on this MCQ is there few years back. You have to learn the name of the dye, it's TTC. So viable area becomes red and dead area remains pale. So that is the thing. Now you may ask me a reason, ma'am, why viable is taking the dye but dead is not taking the dye. So I'm having an answer for that also. In the viable area, all the cells are intact. They are not ruptured. They are live. They are intact, right? But in the dead area, the cells are ruptured. You know, necrosis, the cells are ruptured, the leakage of the cytoplasm, right? Now, heart cells have an enzyme known as dehydrogenase. So in the intact cell, dehydrogenase is present, right? So the dye bind with dehydrogenase. Dye, this TTC dye, it is binding with dehydrogenase. So that's why viable area have dehydrogenase, so they bind with the dye, they look red. But the dead area, they busted out. They don't have dehydrogenase. It is already lost. It's leaked out. It already leaked out. So they don't have dehydrogenase. So they do not bind with the dye. They do not take the dye. They do not become red color. Give me a thumbs up. You got it? That is the dehydrogenase. So that is the thing. The next important topic, the last topic in the MI, the important topic in the MI is the duration. Is the duration before the death. Just suppose the same dead body. This is the same dead body. The police has brought to me, madam, please perform an autopsy on this dead body and let us know whether MI is present or absent. Whether MI is present or absent and whether the cause of the death is MI, yes or no. Because we are suspecting a foul play in this case. It is a medico-legal case. So can you please help us? Give us an expert opinion. So I will perform a dead body. I will perform a post-mortem on this dead body. I will take the heart out. I will put the heart into TTC dye. And if I find the pale area, that pale area is MI. So I will inform the police, yes, MI is present. I will inform the police, yes. In my report, I will write, yes, MI is present. I found the yellow area on putting it in a TTC dye. But the police will ask, ma'am, what is the age of this MI? Is this MI 10 hour ago, 4 hour ago, 10 year ago? हो सकता है MI पहले आया हो. Now the cause of death is something else. Maybe the patient is having heart attack 10 years before. The wife of the patient is saying, the family members are saying the person was having a heart attack 10 years ago also. So maybe it is that MI. Can you find out the age of the MI? Can you find out the age of the MI? For finding the age of MI, we have to make a slide. Grossly, we cannot say. Looking at the MI, grossly, I cannot say what is the age of the MI. For that, I have to make the slide. We divide it into 10 time zones. I will show you 10 diagrams now. 10 diagrams. So based on that, you have to match the diagram in which time zone it is falling, and based on that, you can tell the age of the MI. So the 10 time zones are in front of you. It's 0 to half hour. The MI is half hour old, or half hour to 4 hour old, or 4 hour to 12 hour old, or 12 to 24 hour. Please see, these are hour, ghanta, hour hai, ghante hai ye, right? 24 hours means 1 day. Now we are coming to the days. So 1 to 3 day, 3 to 7 day, 7 to 10 day, and 10 to 14 days. So ये चारों days हैं. You got my point? 14 days मतलब 2 weeks. Now we are talking about 2 weeks. 2 to 8 weeks or more than 2 months. You got my point? So I'm dividing into 10 zones. What are the 10 zones? 0 to half hour, half to 4 hour, 4 to 12 hour, and 12 to 24 hour. It's hour. From 24 hour, it's 1 day. 1 to 3 day, 3 to 7 day, 7 to 10 day, or 10 to 14 day. It's day. And after that, you can say it's more than 2 months. So these are 9 or 10 time zones I am dividing. Now you get many clinical questions, medical legal cases. Here forensic may be important. Yes. So you have to look the slide. So it's very easy. Don't worry. In Robbins it's complicated, but I have super simplified this concept for you. So 0 to half hour you don't find any change. It's normal. You miss MI. Till half hour no change come. It's a MCQ. Till half hour there is no microscopic change. After half hour only the changes are coming. So after half hour, from half to 4 hour, the first change is the waviness. You know what do you mean by waviness? Can you see the heart fibers? They are wavy. Normally they are not wavy. Normally they are straight. The cardiac muscle is straight. But I can see the waviness. Waviness. So the first thing is the waviness. Give me a thumbs up. Have you got it? Have you got it, everyone? The first thing is the waviness which occurs at half to 4 hour. Half to 4 hour. Before half hour, it's normal. It's normal. It's straight. It's normal. There is no problem. Right? Now coming on the next point. 4 to 12 hour. 4 to 12 hour is coagulative necrosis. What does it happen? Can you see the upper half of this diagram? Can you appreciate the fibers? Can you see they become pink? Normally fibers have striations. I can see the striations here. I can see the nucleus here. But nucleus striations all are gone. And dark pink color, tombstone or ghost appearance. So I can see the coagulative necrosis. Right? So it's 4 to 12 hour. It's coagulative necrosis only. From 12 to 24 hour, along with coagulative necrosis, I will find few neutrophils. See, I can find few neutrophils also. Can you see these cells? These all are multilobated neutrophils, but they are few in number, right? I can find few neutrophils. From 1 to 3 day, along with coagulative necrosis, I find abundant neutrophils. See this diagram. Can you see coagulative necrosis is there, but I can find abundant neutrophils. Can you see? Abundant neutrophils. Say yes. After that, neutrophils go on decreasing and macrophages go on increasing. The macrophage. Let me mark the macrophage in this diagram. I can see this. 4 5 macrophages I can see here. Macrophages have one nucleus. Neutrophils have multilobated nucleus. So I can differentiate the macrophage. So neutrophil go on decreasing and macrophage go on increasing. What are macrophage? Say, ma'am, macrophages are phagocyte. Why phagocytes are coming to eat the dead muscle? They will start eating the dead muscle. The phagocyte, the macrophage start eating the dead muscle and everything will be disappeared. So whatever is remaining, that is known as granulation tissue. Can you see this is going on disappearing? It is disappearing. The dead muscles, they are disappearing. Macrophage is going on eating it. So granulation tissue is formed. The next thing is granulation tissue and in the end scar is formed. Everything will go and fibrosis will come, that's scar. Everyone give me a thumbs up. Everyone. Can you help me again in making that table? Once, only once. Because I will show you many questions based on that concept. So it's 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour. Say hour. Right? Don't get confused. It's hour. After that, say day. 1 to 3 day, 3 to 7 day, 7 to 10 day, 10 to 14 day. Say it's day. And after that, more than 2 months. It's month. So we will start writing. Please start writing. 0 to half hour. Say no change. No change. It's a MCQ. No change. The negative finding is important here. It's no change. Come on. Right. Half to 4 hour. In half to 4 hour, what was it? You say waviness. Only waviness is there. 4 to 12 hour, it's only coagulative necrosis. 12 to 24 hour, along with coagulative necrosis, few neutrophils. Only few. You have seen the diagram. From 1 to 3 day, along with coagulative necrosis, abundant, brisk neutrophil. Brisk neutrophil. From 3 to 7 day, neutrophil go on decreasing and macrophage go on increasing. The macrophage first time coming at 3 day. It's a MCQ. Macrophage first time coming at 3 day. After that, macrophage will eat everything and granulation tissue is formed and in the end scar is formed. That's it. That's it. If you learn this now, you can't imagine how many MCQs you are securing. There is a high probability MCQ can come from this table. You got it? So, okay, I will show you your PYQs only. Then only you will believe. So, please help me in answering. We are done with MI. We are done with MI. The diagnosis of the MI, help me in solving it. Can you tell me reversible injury in the myocardium occurs till what age? You cannot detect it. I've told you till what time you cannot detect, you can miss MI. Is it 2 minutes? Is it 30 minutes? Is it 2 hour or 5 hour? So yes, absolutely right. Absolutely right. Yes, the correct answer is 30 minutes. So from 0 to half hour, it's reversible. So it's your PYQ in one of your paper. I have covered your past 5-year papers here. Right. So correct answer here is B. Correct. If you read my PDF completely, my notes completely, you are attending my lecture now. So you are securing many PYQs or the new topics coming from that PYQs, the new questions. So I'm not covering only the previous year question, I'm covering new topics also. Anyways, the next question is in front of you. The next question, very easy question, and many times it's asked. I will share it with the team. I can share it. Shoaib, I can share it with the Prosium team, and you can ask the team members for that, right? I don't know where to share. That's why I will share it with the team members. Anyways, can you read the question for me? During autopsy, I am performing the autopsy of a person who is dead due to suspected MI. So I took the heart out of the body of that dead body, and I put it into TTC. What is TTC? Tetraphenyl tetrazolium chloride. My question is that, can you tell me the color of the viable? Can you tell me the color of the viable myocardium? What is the color of the, why you are not giving the answer? Yes, I'm asking the viable. The viable is red. The viable is red. The correct answer here is C, and you all got it. Yes, it is a repeat MCQ in multiple exams. High probability of coming. Image-based question also comes from this. So you know. And if I change the question, instead of viable, if I ask the dead myocardium, what is the color? Dead myocardium का क्या color होता है? So it's pale, but pale is not given in the option. I will go with dark brown. If pale, I cannot say ना pale नहीं है तो मुझे tick नहीं करना है. Pale नहीं है तो उससे related जो whatever is there you can go. So I will go with dark brown in that case. You got my point. So coming to the next question now. The next question is in front of you. Can you tell me the earliest change in MI? Earliest. Can you change me the earliest change? Among the four, what is the earliest? Is it macrophage which comes earliest? Is it neutrophil which comes earliest? Is it waviness which is the earliest? Or is it coagulative necrosis is the earliest? Yes, you all are right. The correct answer here is C. Okay, again KBC, fastest finger first. Arrange them from earliest till late. पूरा sequence बताओ. Is it ABCD, CBDA, DBA, ABC? What is the sequence? Arrange them. इन सबको आगे से पीछे एक क्रम में लगाओ, एक सीरीज, एक सीक्वेंस में लगाओ. Right. So who will tell me the correct sequence? From first to last event. Yes. So Abhi is saying CDBA and everyone is saying CDBA. So I guess CDBA is the correct sequence. So C is the waviness, followed by neutrophil, followed by macrophage. No. C is waviness, followed by coagulative necrosis. So first waviness, then coagulative necrosis, then neutrophil, then macrophage. Yes, so C, D, B, A, you all are right. So you can imagine how many new questions we can create. I always launch a poll, put that question, and I always twist the question to make you the new questions in front of you. So you should be able to answer all of them. Right. So correct answer here is yes, CDBA. Right. Coming to the next question. Now this is a tricky one. Don't confuse. Take a breathe, understand it, and then tell me the answer. So there is the MI showing granulation tissue. Early granulation just started. Can you tell me the age of the MI? At what age just granulation tissue appears? Granulation tissue appears at what age? Granulation tissue appears at what age? I'm asking you this question. So most of you are saying C. Is it within 1 week? Let me check. I don't know. I have to check with the table. Okay, I have not put the table here. I will go back. Give me a minute. To see the granulation tissue, I will go back to the table. Where is my master table? Here is my master table. Where is the granulation tissue in this table? Can you see? Granulation tissue first time coming at 7 to 10 days. Yes, now 7 to 10 days is my correct answer. Now I will see the options. Whatever best fit, I will go with that. So where is the question? Here is the question. No, here is the question. Yes. So 7 to 10 days. 7 to 10 days is not given. So, but the most related option will be within 1 week. So I will go with within 1 week. Yes, C is the correct answer. Best is agar 7 to 10 days diya hota, so I will go with that. The correct answer here is C. You got my point? Can you tell me the answer? In MI, microscopic picture of coagulative necrosis with neutrophilic infiltrate seen at what age? Coagulative necrosis plus neutrophil. This picture occurs at what age? Now two options are correct. Two options. You will get confused. Let me write it. So 0 to half hour, half to 4 hour, 4 to 12 hour, 12 to 24 hour, 1 to 3 day. Pura nahi likhti. This is the thing you know. Okay. 0 to half hour it's normal. Half to 4 hour it's waviness. Right. Here it's only coagulative necrosis. Here coagulative necrosis with few neutrophil, and here coagulative necrosis plus brisk neutrophil. This is a question 2 years back NEET PG, not FMG. But answer even I don't know, it's controversial question actually. Let me give you my overview. मुझे क्या लगता है? So these both options are correct because in the question it's not mentioned the neutrophil is few or brisk. That is the problem. I can consider both now. If you say that neutrophil is few, my answer will be 12 to 24 hours. Answer will be B. But if you say ma'am neutrophil is brisk, so my answer will be 1 to 3 day. My answer will become C. So answer definitely from B or C, not A and D.
Answer is either B or C. But who will decide what is the correct answer? Because in the question, it is not mentioned few or breast. So ideally, the examiner must mention. Don't confuse the student. I don't like to confuse the student. My question should be crystal clear. If I am the examiner, I will put it whether the few or the brisk. So your answer will become 1. So in your question, if it is few, go with this. If it is brisk, go with this. But currently in this question, nothing is mentioned. So actually it is B and C both are true. But it is not a PGI, na? You can mark only one option, not two. So according to me, if I was in this exam, na, I will go with C. Because few नहीं mark करूंगी ना मैं. फिर मैं वो mark करूंगी जिसमें brisk है. I will take a chance. I am taking a chance. I don't know. Actually, both answers are correct. So sometimes controversies happens in exam. Then best judgment जो है. So most of this controversial question pe most of the authors have said the same, that we should go with C. Go with 1, 2, 3. It's your choice. Right. Okay, we can take when neutrophil appears first. A B. Agar first, the word first is there in the question, go with B. But if first word is not there in the question, go with C. And at the end, choice is yours. Actually, both options are correct. Okay. 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 Can we go ahead? Okay. The next question in front of you. Can you tell me the name of the cell which first time appears at 72 hours? By the way, 72 hours is 3 days. Can you tell me the name of the cell which first time appears at day 3? Day 3. Not in ours, day 3. Day 3 पे न्यूट्रोफिल आता है कि लिम्फोसाइट आता है कि मैक्रोफेज आता है कि मोनोसाइट आता है? आई एम आस्किंग अबाउट एमआई, द सीक्वेंस ऑफ द एमआई. व्हाई यू ऑल आर सेइंग ए? मैक्रोफेज अकर्स एट डे 3 ना. न्यूट्रोफिल्स तो डे 4 आवर्स पे ही आ जाता है, 4 to 12 आवर्स. 4 to 12 hours पे neutrophil first time appears. It's 12 to 24 hours. It's not at day 3. At day 3, macrophage come. Neutrophil decrease and macrophage appears. I'm not writing it again. The correct answer here is C. You got my point? Coming on the next thing, can you tell me how to diagnose MI? Imagine a patient coming to you. You are getting a call at 2 a.m. at night from the nurse of a hospital where you work. The nurse is saying, doctor, there is a patient with chest pain. Severe chest pain, come fast. So what instructions you will give to the nurse? You will get up from your bed, you will run towards the hospital, you are a cardiologist, and what instructions you will give to your nurse till I'm coming, I'm on the way, I will be there in 5-10 minutes. But meanwhile, you do what? It's an emergency, no? You have to do the diagnosis. If it's MI or simple acidity or angina, these are the 3 differentials of a chest pain. Right. So if it's MI, we have to take quick action. The patient can die before you reach the hospital. You want to save your patient, right? So you have to make the diagnosis. So you will ask the nurse to do a ECG. The most important, you do a ECG. Meanwhile, I'm reaching, take the strip of the ECG. The number 2, take a blood sample of this patient and send it to the pathology laboratory. Ask them to do the cardiac markers. There are 5 cardiac markers they will perform. Meanwhile, you will reach the hospital, you will get the reports. So there are 2 ways to diagnose the MI. ECG and cardiac markers, which is done on the blood. So ECG mein 3 changes are there. You may be knowing the 3 changes. You read this topic in medicine also. It's ST segment elevation. Can you see? ST segment, elevation of the ST segment, right? T wave depression. You know PQRST, I guess you know. T wave depression and deep Q wave. Can you see? Deep Q. So ST elevation, T wave inversion and deep Q. So these are the 3 findings on the ECG which quickly help you in diagnosing the case of a MI. Right. Now coming on the cardiac markers. What are the cardiac markers? Whenever there is a MI, the cells in the heart, they are rupturing. So the enzymes present in the cells of the heart, they are leaking in the blood. And if you take the blood sample of a patient, you will find these 5 markers. These 5. It's myoglobin, CPK, troponin, SGOT and LDH. The most specific among them is troponin. Troponin, most sensitive and specific marker, it's a MCQ. It's a MCQ, most specific. But first to appear is myoglobin. Within 2 hours, it will come in the blood. First to appear, first to go. The myoglobin. Last to appear and last to go is LDH. ये तीनों MCQ हैं. First to appear, it's myoglobin but non-specific. LDH, it appears till 10 day. It is last till 10 day तक भी होता है. But it's not specific. The most sensitive and specific is troponin. Give me a thumbs up. Give me a thumbs up. We will do some polls based on this. Can you tell me the answer? Can you tell me the first enzyme to be raised in MI? The name? The first enzyme to be raised in MI? Is it CPK? Is it LDH? Is it myoglobin? Is it troponin? What is the correct answer? Is it A or C? I'm asking the first one. The first one is the myoglobin. Yes, you all are right. I have told you myoglobin, it appears within 2 hours. The first to come, the first to go. It's myoglobin, but non-specific. So correct answer here is C. You all are right. Can you tell me the marker which is present post MI till 10 day? 10 day tak bhi rehta hai blood mein. The marker of the MI which is last I want to ask. The last one. till 10 day it is there in the blood. The next question, yes, till 10 days there in blood. You all are right. Yes, it's LDH. So first पे भी MCQ आता है, last पे भी आता है, right? And the most sensitive, I have not put the question, most sensitive specific, the answer is troponin. So उस पे भी question आता है, right? So coming on the next topic, okay, endocarditis. You know what is endocarditis? Give me a minute. Okay. You know what is endocarditis? Heart have three layers: endocardium, myocardium, and pericardium. So endocardium is the innermost layer. Endocarditis is the inflammation of the endocardium. Now endocardium is of two types. The walls of the heart. Can you see? These are the walls of the heart. The walls of the heart are also lined by the endocardium. So whenever there is endocarditis, inflammation of so this endocardium is known as valvular endocardium. It is present on the walls of the heart, and at remaining heart, the remaining rest of the heart, the rest of the heart have another lining. It is endocardium only. The such endocardium is known as mural endocardium. So basically we divide the endocardium into two portions, the one which is present on the walls and the one which is present in the rest of the heart. You got my point? So it is valvular and mural endocardium. Endocarditis is inflammation of the endocardium. So valvular endocardium is also involved. It will lead to vegetations, and mural endocardium is also involved. The remaining endocardium is also involved. So there are four type of endocarditis in your syllabus on which usually MCQs come. We will not see the details. We will see what important MCQs from these four type of endocarditis usually come in your exam, right? So it's rheumatic endocarditis, it's Libman-Sack endocarditis, it's non-bacterial thrombotic, NBTE, non-bacterial thrombotic endocarditis, and it's infective, bacterial or infective endocarditis. So these are the four type of endocarditis in which endocardium of the heart is involved. So the most important among them, the first and the last, the main thing you have to understand, the location of the vegetation is different in all four. So you have to understand the vegetation to sab mein banenge because endocardium is involved, so wall is involved. So vegetation to sab mein banenge, everyone will have vegetation, but the location and consistency and the gross of the vegetation is different. That will differentiate the type of the endocarditis. So let me tell you the first one, rheumatic one in short. Rheumatic may the most MCQs come from the Jones criteria. So let me tell you what is rheumatic endocarditis in short. Can you see there is a child? This is a child. Rheumatic heart disease, rheumatic fever occurs in a child. So these are the tonsils of the child. You can see the two tonsils of a child. So the two tonsils of the child is infected by a bacteria. We have tonsillitis now. Whenever we were kid, we also have tonsillitis very frequently. Even till date, I am having tonsillitis very frequently. So the most common bacteria which causes tonsillitis, it's group A beta streptococcus gas. Group A streptococcus bacteria, which causes tonsillitis. You will say, ma'am, it's very common to have tonsillitis. What is the problem in that? Okay. The child is having tonsillitis. The body will form antibodies against the bacteria. There is no problem. These antibodies will kill the antigen, bind with the antigen, and kill the antigen. You will say, ma'am, then what is the problem? What is the problem? The problem is not the bacteria. The problem is the antibodies. Actually, the bacteria have an antigen on it. The antigen on it. There is this bacteria have an antigen on it. The similar antigen is present on 5 human organs. Can you see? The similar antigen is present on 5 human organs. Which 5 human organs? It's brain, it's heart, the two vitals, brain, heart, it's skin. Skin. Just below the skin, we have subcutaneous tissue, and just below that, we have joints. Brain, heart, skin, subcutaneous tissue, and joints. So, brain, heart, skin, subcutaneous tissue, and joints. These 5 organs have similar antigen. These 5 organs have similar antigen. Can you see? So the body is forming antibodies. Actually, the antibodies will kill the bacteria, but they will get confused and they will think it is also a bacteria. It is also. So they will go and damage the 5 organs, causing 5 diseases in the 5 organ. So basically, the antibodies are autoimmune antibodies. They are killing the body's self organs and causing the self destruction of the cells. The cells of the body are destroyed by the antibodies, auto antibodies. The problem is not bacteria. Bacteria बेचारा कुछ नहीं कर रहा, वो तो tonsillitis करा के चला गया. But the antibodies वो पूरा धमाल मचा रहे हैं. The antibodies are causing 5 diseases. You got my point? So what are the 5 diseases in 5 organ? In the heart, it's pancreatitis, rheumatic heart disease. In brain, it's Sandam's chorea in the brain. In the skin, it's erythema marginatum in the skin. Just below the skin, in subcutaneous tissue, it's subcutaneous nodules. It's subcutaneous nodules. And in the joints, it's migratory polyarthritis in the joints. These 5 diseases together known as rheumatic fever. Can you define rheumatic fever for me? What is rheumatic fever? Yes. Rheumatic fever is a multi-systemic disease involving 5 systems, 5 different systems, you know the names. It is always post-streptococcal. So first bacteria causes tonsillitis, then only this all happens. Without bacteria, it cannot happen. Although bacteria is not causing it, it is caused by autoantibodies, but without bacteria, it cannot come. It is an autoimmune disease. Yes, absolutely right. And it is non-suppurative. Bacteria is not causing the damage to the 5 organs. 5 organs ke paas bacteria nahi ja raha, nahi, no. The antibodies are causing the damage. Yes, it's autoimmune. Right. So Jones is a scientist who has discovered all this. So he has given 3 types of criteria. Jones major criteria, Jones minor criteria, and supportive criteria. Right. The major criteria are 5. The minor criteria are also 5. And supportive criteria are 3. You have to learn the list. Right. The 5 major criteria are same as that of the 5 organs. Right. These are the 5 major criteria you already know. In the heart, it's pancarditis. In the joints, it's polyarthritis. In the brain, it's syndrome scoria. In the skin, it's erythema marginatum. And in the subcutaneous tissue, it's subcutaneous nodules. These are the 5 major criteria. Give me a thumbs up. You got it. You can see the 5 major criteria here. Right. What is there in the joints? Can you repeat? What is there in the joints? I want to explain you something. It's arthritis, polyarthritis. Multiple joints are involved. Poly, say the word, arthritis. Itis means inflammation of the joint. It's major, right? So you can see the child. In the child, you can see the tonsillitis. Can you see the tonsillitis in the child? And because of the tonsillitis, these are the 5 type of major criteria, right? Coming on the minor criteria. Coming on the minor criteria. Minor criteria, whenever there is pus in the tonsil, the child will have fever, right? Fever is a minor criteria. Now see, it's arthralgia. That's why I have highlighted arthritis there. वहां पे arthritis था. The word arthra मतलब होता है joint. Pathology में joints are known as arthra. So there can be 2 things in the joint. Arthritis, that is inflammation of the joint. Itis is inflammation of the joints. And arthralgia. What do you mean by algia? Algia is pain in the joints. It's not inflammation. It's pain in the joint. You got my point. So this one is a major criteria and this one is a minor criteria. No one will teach you such minute details. And you get multiple MCQs. I will show you now in your PYQs on this concept. Students get confused in the exam. It was arthralgia or arthritis. They get confused. So mind my words. I'm repeating again. Arthritis is major, but arthralgia is minor criteria. You got my point? So the second minor criteria is arthralgia, not arthritis, not arthritis. The third one is the previous history of rheumatic fever. It occurs again and again, right? The fourth one, 3 things in the lab, in the blood is increased. 3 things. ESR is raised in the blood, C-reactive protein is raised, and WBC count is raised. These 3 things are raised. And last one, on the ECG, PR interval is elongated. PR interval is raised because of vasculitis. So we are done with 5 major. We are done with 5 minor. But along with this, there are 3 supportive criteria. These are 5 major, these are 5 minor. Nowadays, minor 4 ही हैं. The repeat history is removed nowadays. Only 4 minor are there. You can learn like that. Lekin supportive criteria are 3. Okay, imagine a patient is coming in my clinic. There is a child, 3-year-old girl. With the parents, it is coming. I'm asking what happens. If I'm a pediatrician, I'm asking what happens to the child. The parents are saying my child is having irresistible movement in the air, like chorea, like the child is having erythema marginatum, subcutaneous nodules. I have auscultated the child, it's valvulitis also, like vegetations are present. So multiple systems are involved and I am having high suspicion that this child is having rheumatic fever. So I asked the mother, does this child have tonsillitis few days back before all this happens? So mother is saying, I don't remember. No, it's not there. The child is saying, no, I don't remember, it's not there. So still, would you like to say this case is rheumatic fever without tonsillitis? No. Without tonsillitis, we cannot say. If all are present and tonsillitis is absent, we cannot document it. You have to document that this all is related to the tonsillitis, then only it's rheumatic fever. Without rheumatic fever, it's not there. You got my point? You got my point? So for documenting tonsillitis, sometimes it's painful, so the mother remembers or the child remembers. But sometimes it's very mild and it goes unnoticed. It goes unnoticed. So in that case, you have to do the throat swab. Number 1, like in COVID, we are doing the swab now. Do the throat swab and do a culture on the agar plate, blood agar. or take the blood sample and see the autoantibodies, that is ASO titer, anti-streptolysin O antibody or anti-DNA antibody. These are the autoantibodies which we are looking for. So any one of these is present, it is the supportive criteria. Can you help me in revising? Can you help me revising the Jones criteria? Who will help me? The major criteria, the minor criteria, and the supportive criteria. Please kindly help me now. The 5 major criteria. In the heart, it's carditis. In the brain, it's Sundance chorea. In the skin, it's erythema marginatum. In the subcutaneous tissue, it's subcutaneous nodules. And in the joints, it's arthritis, not arthralgia. Coming on the minor, can you help me with the minor, please? Yes. In the minor criteria, it's fever. Number 1, it's fever. Number 2, it's arthralgia, not arthritis. Here it was arthritis, here it's arthralgia. After that, the 3 things in the lab are raised. It's ESR, WBC, and C-reactive protein. And on ECG, the PR interval is raised. The 4 minor criteria. And the 3 supportive criteria. Do a culture of the throat swab and see for the 2 type of antibodies, ASO and anti-DNAs. Everyone give me a thumbs up. So this is the diagnostic criteria of a rheumatic fever. Many questions come from this diagnostic criteria, right? Now I'm going to teach you only heart here. I'm not going to teach you all. I'm going to teach you only one criteria here, the heart. In the heart, there is pancarditis. The most important thing you have to understand here, it's pancarditis. All the 3 layers of the heart are involved. Endo, myo, and peri. So there is endocarditis, there is myocarditis, there is pericarditis. That is all 3 layers of the heart are involved. That is known as pancarditis. That is known as pancarditis. In the endocarditis, the walls of the heart are involved, valvular endocarditis, and the mural, the remaining heart is also involved. That is mural endocarditis. So when the walls of the heart is involved, its vegetations are formed. Can you see the walls of the heart? Here there is tricuspid wall. Here I have drawn mitral wall. And on the walls of the heart, I have drawn these vegetations. What do you mean by the term vegetations? These are the nodules on the walls heart. They will cause valvular defects, either stenosis or regurgitation, right? So these are known as vegetations. Okay. Now the point is that where these vegetations are present in rheumatic heart disease, where these vegetations. Okay. What I mean to say, this is the heart, this is the left ventricle, left auricle, and left ventricle. Let me draw the mitral wall, which is a bicuspid wall. It's a mitral wall, that is bicuspid wall. The 2 cusps are present. Imagine my 2 hands are 2 cusps of this mitral wall. So above my hands, it's auricle, and below my hands, it's ventricle. So if I am saying these are the 2 cusps of the heart walls of this wall, which is shown in the diagram. You can see the diagram also. Where is the vegetation? On the upper surface, small vegetations are there, or lower surface, small vegetations are there, or at the junction, where they are present. I'm asking you where they are present, upper or lower or junction. I'm giving you 3 options. I'm giving you 3 options. So correct answer here is at the junction. So the vegetations here are formed at the junction. They are formed at the junction, neither on upper nor on lower. They are formed at the junction. It is known as line of closure. Line of closure. So can you see here in the diagram, beautifully I have drawn the vegetations at the line of the closure. It's very important MCQ. So in rheumatic heart disease, the vegetations are formed at line of closure or junction. In tricuspid wall also, in bicuspid wall also, Bharat, it's always formed at line of junction, neither on upper nor on lower. Please mind my words. The vegetations are small, multiple, they are formed at the junction. Now in the heart, there are 4 walls. This one is tricuspid. This one is mitral. Here we have aortic and here we have pulmonary, right? You know the 4 walls. Can you tell me the sequence? Vegetations formed most commonly, second, third, fourth most common. Can you tell me? So the mnemonic is there, MATP, M-A-T-P, MATP. Mitral wall, most common. Aortic, second most common. Tricuspid, third most common. And pulmonary, least common. In this sequence, vegetations are formed. It's very important MCQ. Most common पे भी MCQ है, PYQ में least common पे भी है. So learn their location. It's the junction line of closure. Learn their sequence. The sequence is MATP. In सब पे question है. In सब पे question है. So learn the sequence. So that's about the vegetation. So this is about the vegetation, that is valvular endocarditis. But what about the rest of the endocardium? Now, in rest of the endocardium, there are 4 chambers in the heart. The 2 auricles and the 2 ventricles, we already know that. But only one of the chamber is involved. Name of that chamber is left auricle. Can you see in the left auricle, I have drawn a yellow patch. This is known as McCallum patch. So McCallum patch is present in left auricle. Left auricle. Now, left auricle is a three-dimensional structure. It is having anterior wall, posterior wall, medial, lateral, everything. So, it is present on the posterior wall of the left ventricle, or left auricle. Left auricle की posterior wall पे है, McCallum patch just above the mitral wall. Right? This is the exact location of the McCallum patch. So, in the endocardium, we are having two things. Vegetations and McCallum patch. Everyone give me a thumbs up. These all are your PYQs. McCallum patch का location पे multiple time PYQ है. Answer is left auricle posterior wall. That is the answer out of the four chambers. Yes, say something. React at least. Are you sleeping or you are awakened? How does that know? React, at least react. You got it? So awaken. Okay, awaken. Live. Awaken. Right? Okay. So that is about the endocarditis. What about myocarditis? In the myocarditis, Ashkoff bodies are formed. Ashkoff bodies is the pathogmatic feature of rheumatic heart disease. You will say, ma'am, what is Ashkoff body? We don't know what is Ashkoff. Okay, I'm coming on myocarditis. See the four type of this thing, endocarditis. I'm teaching you currently rheumatic heart disease. The next is infective endocarditis. The next is non-bacterial thrombotic endocarditis. And the next is Libman-Sack. You have to see the location of the vegetation in the four. That makes difference. And you will get multiple MCQs, either image-based or the theory MCQs based on the location of the vegetation. They all have vegetation. We can see the yellow color vegetation on the, this is the cusp of a wall, the mitral wall. In the rheumatic heart disease, I can see the vegetations are present at the line of junction. They are present just at the border, at the line of junction. Line of junction, just now I have explained you, right? At the line of the junction. In NBTE also, they are present at the line of the junction, but they are bigger in size. They are line of junction, here also line of junction, but they are small, and here they are large, right? But the location in these two are same, right? In infective endocarditis, it's on upper surface. I'm repeating, not at the line of junction, it's upper surface, not lower. Not lower, only upper surface. I'm writing the word upper. And they are very big, the biggest among the all. Very big, right? Infective endocarditis or bacterial. The last one is the Libman-Sack. You know why does Libman-Sack happen? Libman-Sack happens because of SLE. It happens because of SLE, right? In Libman-Sack, the vegetation occurs on the both surface. You see the beauty. This diagram is from Robbins and I salute Robbins. वो diagram में सब बोल देते हैं. You got my point. उनको थ्योरी पढ़ने की जरूरत नहीं. रॉबिन्स के डायग्राम देखो, इट्स सेल्फ डिस्क्रिप्टिव. उसने फ्लिप किया है वन ऑफ द वॉल, वन ऑफ द लीफलेट, और नीचे भी दिखा दिया है. इट इंडिकेट्स अपर प्लस लोअर, right? It is clearly visible in the diagram. So the vegetation on the upper plus lower. In rest of them, it is not flipped. Intentionally, this one is flipped in both sides. Yes. Now, if you can understand that, you can solve any MCQ on endocarditis. You have to learn the location of the four. Right? Yes. Give me a thumbs up. You got it? So can you see the real diagram of a vegetation? This one is rheumatic heart disease, and you can see the vegetation at the junction. The vegetations at the junction. The vegetations at the junction. Now coming on the myocardium. In the myocardium, I told you there are Ashkoff bodies. Have I told you? Now look at the myocardium. In the myocardium, can you see these nodules? The myocardium also have nodules. These are small nodules. Small nodules in the myocardium. These are known as Ashkoff nodules. Actually, Ashkoff nodules, this is the diagram of Ashkoff nodule. So, Ashkoff nodule mein in the center, there is fibrinoid necrosis. Today morning lecture, have you attended it? I have told you the 5 type of necrosis. The 5th one was fibrinoid. Have you attended it? So, the center contains fibrinoid necrosis, which it is MCQ. It is surrounded by 5 type of cells. Can you see the 5 type of cells? I will draw it on the next page. So, in the center, let me draw fibrinoid necrosis. I am drawing one of the Ashkoff nodule. There are multiple. I am drawing one. Right? It is surrounded by 5 type of cells, but 2 are important. So the first type of cell are Ashkoff cells, which are giant cells, multinucleated giant cells. Multinucleated giant cells, these are known as Ashkoff cell. Ashkoff cell. Ashkoff cell. The second type of cells here are uninucleated cells known as anti-Ashkoff cell. Anti-Ashkoff cell, the nucleus is like owl eye. The nucleus is like owl eye if you look from front, and if you look from side, the same nucleus look like caterpillar. So they have 2 type of nucleus, either caterpillar or owl eye. These all cells are anti-Ashkoff. Anti-Ashkoff cells. Ashkoff, anti-Ashkoff. Apart from this, the cells are very simple. They are lymphocytes. You know what are lymphocytes? I'm not explaining you. Lymphocytes, there are fibroblasts. There are fibroblasts and there are plasma cells. Small plasma cells. So these are, there is no neutrophil. Mind my words, it's also an MCQ. There is no neutrophil. So this is the diagram of a Ashkoff body. You got it? Now, you will ask me, ma'am, what is Ashkoff and anti-Ashkoff cell? We have not heard about it. Both of them are modified macrophages. The macrophage get modified and it converts into Ashkoff and anti-Ashkoff. Ashkoff is multinucleated and anti-Ashkoff is either owl eye or caterpillar appearance nucleus. You have to learn that. These all are your MCQ. So see, this is a Ashkoff body. All the cells are drawn. Or else you can see this is Ashkoff body. You can see this one is the multinucleated giant cell and this one is the owl eye appearance. Owl eye or caterpillar appearance. These two are the anti-Ashkoff cell. Please appreciate it. Say yes. So this thing is also over. What says? Ashkoff bodies, myocardium. Coming on the last, pericardium. What happens in the pericardium? We have seen what happens in endocardium. We have seen what happens in myocardium. Let's come on the pericardium. Pericardium में क्या होता है? Osama, what happens in pericardium? Pallavi, what happens? Prince, Irfan, Mupeneni, what happens? In pericardium, there is pericarditis, which is known as bread and butter pericarditis, that is fibrinous pericarditis. You will say, ma'am, what does it mean? What do you mean by bread and butter? Okay, let me explain you. You know, humans have a space which is known as pericardial space. You, me, everyone have this space. So the heart have three layers. This is endocardium, this is myocardium, and this is pericardium. So between myo and peri, a small space is present. It is known as pericardial space. So usually a very small, minute amount of fluid is present in this space, which is present in me, you, everyone. It is watery in consistency, very watery, thin, watery in consistency. This fluid is known as pericardial fluid. It's normal. But in rheumatic heart disease, this fluid become thready. You know thready. हिंदी समझता है? हिंदी में कहूँ तो धागेदार. धागेदार in consistency हो जाएगा. The word is thready. Thready in pathology is known as fibrinous. Fibrinous का मतलब होता है thready in consistency. So can you see I have drawn here the threads. If you can appreciate, it's thready. Can you see I have drawn the threads here? So instead of watery, the fluid become thready in consistency, and this is known as fibrinous pericarditis. Give me a thumbs up. This is known as fibrinous pericarditis, right? You will say, ma'am, okay, we got it. What is fibrinous pericarditis? In the pericardium, the fluid become thready, and that's why instead of watery, it is thready, and it is known as fibrinous pericarditis. We got it. But what do you mean by bread and butter? What do you mean by bread? Do you eat bread butter sandwich? I usually eat in the breakfast. So what is a bread and butter sandwich? I take two slices of bread, one slice of the bread, another slice of the bread, and I put butter in between, right? So that is the sandwich. The butter is in the between, the two bright slice of the bread and the butter in the between. Have you ever tried to separate the two slices of bread apart from each other? Have you ever tried? If you not, try it next time. So what you will feel, what you will find, if you separate the two slices away from each other, you will find the threads of the butter in between. You will see the threads of the butter are separating from each other, the threads of the butter, right? This is known as bread and butter appearance. So how I relate this with the pericarditis here? Imagine the child is dead. The child with the rheumatic heart disease, unfortunately, is dead, and I'm doing the autopsy on this child. So what I will do, I will take the heart of this child out of the body, the dead body, right? So once the heart is out, I will cut the pericardium to expose the myocardium. I'm doing dissection of the heart. So can you see there is a scissor? Okay. Here is the scissor. With the scissor, I am cutting the pericardium. This is all pericardium, and below it there is myocardium. So whenever I either cut the pericardium with a scissor and try to separate it from the myocardium, see what I have noticed. See, in this diagram, I'm noticing the threads. Can you appreciate the threads? So this is bread and butter appearance. So this is one slice. This is another slice of the bread. We are separating them and we are looking the butter at the between. So the two slices of the bread is myocardium and pericardium. And we are looking at butter in between. This is known as bread and butter appearance. It's very important MCQ. Now, once you have understood, now you will never forget. Say yes. So this is the summary. You get question on each and every point here. So this is rheumatic heart disease. The point is that in rheumatic heart disease, there is pancreatitis. That is all three layers of the heart are involved. In endocardium, two things happen: vegetation and McCallum patch. McCallum patch occurs in left auricle. That is the only question asked on that. Vegetations, you should know the location. It's the junction, line of closure, and the mnemonic is Mattup. You know what is Mattup. Ashkoff bodies, you know what are Ashkoff cell, what is anti-Ashkoff cell. In the center, there is fibrinoid necrosis. You know that. So question will be on that. And in pericardium, it's fibrinous pericarditis, which give bread and butter appearance. Now you can solve any question based on that. Whether it is an image-based question, theory question, clinical question, whatever. You are perfect in that. Say yes. So we are done with rheumatic heart disease. And among all these, what is the most specific or pathognomonic feature? Pathognomatic feature is only one. Pathognomatic feature is only one. And the pathognomatic feature, which is Ashkoff bodies, that is only one. So it is also MCQ. Everything happens, but the specific feature is Ashkoff body. Now we will solve some questions based on that. Okay, we are done with rheumatic heart disease, but I'm not teaching you the other type of endocarditis. You can read by yourself. I've told you the location in each of them. Now let me help you in solving some PYQs on endocarditis. Can we solve it? Can you read a question for me and help me in answering it? Please, can you do so? So there is a 10-year-old boy, Pappu, who is dead. So the first clue in the question, there is a child. And the child is dead. And the diagnosis is given, it's rheumatic fever. So we are doing the autopsy of the child. So we can expect everything in the autopsy except what is not present in this child at autopsy. So yes, you all are right. Ashkoff nodules, they are present in the myocardium. McCallum patch, it's present in the endocardium, mural endocardium. Fibrinous pericarditis, it's present in the pericardium, the bread and butter appearance. But rupture of chordotendini, no way. No, it's not happening. So the correct answer here is B, and you all are right. Very good. I'm very happy that you got it. So the next question in front of you, what are anti-Ashkoff cells? I've told you Ashkoff and anti-Ashkoff cell. What are they? Are they modified macrophages? Or are they modified neutrophil, modified B lymphocyte, or modified RBC? What are they? So they are modified macrophages, I told you. So those who have listened it attentively, they can answer it. If I'm changing the question, instead of anti-Ashkoff cells, I'm asking Ashkoff cells. What is your answer now from ABCD? Is it same or would you like to change? If I'm changing the question, would you like to change the answer or would you keep your answer as same? Say it now. So yes, answer is still same. So Ashkoff as well as anti-Ashkoff, both cells are modified macrophages, but the diagram is different. Ashkoff cell is a giant cell, multinucleated giant cell, and anti-Ashkoff cell is this. It is the same cell. I'm drawing two cells. The view is different. This is the front view, and if you cut it and look it from the side, it will be like owli. So this is owli and caterpillar, the same cell but with a different view. You got it? Can you tell me which of the following is not seen in Ashkoff body? In Ashkoff body, 5 type of cells are there. No? I told you the name of the 5 cells, right? Which of the following is not present in Ashkoff body? Is it a giant cell? Is it a Ashkoff cell? Is it a fibroblast? Or is it a polymorphonuclear cell, that is neutrophil? What is absent? What is absent? So most of you are right, D, but some of you are wrong also. I told you the 5 type of cells. Neutrophil is not a part of Ashkoff body. In the center, there is a fibrinoid necrosis. Surrounding this, there are Ashkoff cells, which are multinucleated giant cells. And there are anti-Ashkoff cells. Surrounding this, there are plasma cells. There are lymphocytes. And there are fibroblasts. But there is no neutrophil. Fibroblast is not the answer. Fibroblast present here. Neutrophil is absent. So correct answer here is D. Right? Everyone agree? Most common valve involved in rheumatic fever. Mitral, aortic, pulmonary or tricuspid? I'm asking you. Yes. Let me see who is first and correct. Yes. Yes, Saad. Very good. Very good. Yes, you all are right. The most common valve is mitral. The mnemonic is matap. I've told you. Most common is mitral in rheumatic fever. Right? So the next valve which is not involved in rheumatic, or least common or not involved. Just opposite question. Just opposite question. Last question was most common. Here I am asking least common. Least common means not at all involved. Yes. So of course matap. Again matap. So it's pulmonary. Pulmonary is option C. Why you are saying D? Arey matap mein P is coming now. Matap ka P is pulmonary. So answer is C now. Why you people are saying D? Those who are saying D. You got confused. Correct answer is C. So most common is mitral and least common is pulmonary. The mnemonic is matap. If I am asking second most common, answer will become aortic. एक बार second most common पे भी PYQ है. तो most common पे भी है, second most common पे भी है, least common पे भी है. सब पे PYQ है. You have to learn matap. Right? Can we go ahead? Right. So this is the next question in front of you. Can you tell me McCallum patch is a diagnostic of which disease? Very easy question. Is it occurs in infective endocarditis, or rheumatic endocarditis, or myocardial infarction, or TOF? Where does it occur? Yes, it occurs in rheumatic endocarditis. We all know that. Correct answer is B. Okay. The next question in front of you. Can you tell me characteristic feature of rheumatic carditis? In rheumatic carditis, endocarditis, what happens? Is it pericarditis, endocarditis, myocarditis, or pancarditis? Yes, you all are right. Very good, Abhi. Very good, everyone. Correct answer here is pancarditis. Everything is involved, no? Pancarditis, yes. Can you tell me the most characteristic finding? I'm asking the pathognomatic feature of rheumatic fever. rheumatic heart disease, rheumatic carditis. I'm asking the pathognomatic feature. I know everything happens here, but tell me the pathognomatic. I know fibrinous pericarditis also occur, vegetation also occur, Ashkoff body also occur, increase, everything occurs. But what is the pathognomatic? Pathognomatic is Ashkoff body. Yes. So correct answer here is C. Ashkoff body is the most specific or pathognomatic feature. So we have done all the MCQs based on that, and our heart chapter is also done. This chapter is also done. Let me move ahead and let me move on lung. Few COPDs I would like to teach you here. Few COPDs. So what is a COPD? What is a COPD? It's chronic obstructive pulmonary disease. We are moving to the respiratory system. We are moving to, you want a break for 5 minutes? Does everyone want a break for 5 minutes? Or shall we continue for 1 more hour? I guess I would be able to continue for 1 more hour. Okay. Just a second. What you people are saying, let me see. Yes. Okay. So we would like to take a break for 5 minutes, right? After 5 minutes, I will be back here. Okay. Currently it's 9:30, 9:31. Maybe at 9:36 around, I will come back, right? Okay. So at the same link here only, we will continue first with respiratory pathology. And after that, I'm having few small topics important for you. So we have covered heart, we have covered blood vessel, we have covered CNS, important systems, we have covered complete hematology, we have covered, right? We will cover respiratory, we will cover renal, some important topics from liver and GI also. So that much is remaining. Let's see how much we can cover, right? Okay. Okay. So I am giving you a break here.
Am I audible? Am I visible? Are you people there? Can you see me? Can you hear me? Are you back from the break? It was a little bit longer now. Can we continue? Are you people there? Come on, write something. Okay, let me see. I guess it's live. I can't see it now. Let me, okay. Give me a minute. Yeah, I guess it's working. So can we go ahead? Okay. Okay, so let me continue with respiratory system. We have covered many systems yet. Let me continue with systemic pathology with the respiratory system. In respiratory system, most commonly questions come from COPD, that is chronic obstructive pulmonary disease. Let me tell you the respiratory tract once, and I will explain you the 4 types of COPD in one shot. Right. So the respiratory tract start from the nose. Let me draw. My drawing is not very good, but let me try to draw a drawing for you. So can you see starting from the nose? Nose ends in pharynx. This is pharynx. Pharynx ends in larynx. Larynx ends in trachea. This is trachea. Trachea ends in bronchi. The 2 bronchi, the right and left bronchi. Bronchi results in bronchioles. Bronchioles. It's primary, secondary, tertiary, terminal, respiratory bronchiole. Respiratory bronchiole results in alveolar duct, and alveolar duct results in alveolar sac. So this is the complete tree. It starts from nose. Let me write. It starts from nose. Nose results in pharynx. Pharynx results in larynx. Larynx leads to trachea. It leads to trachea. Trachea leads to bifurcation into the 2 main bronchi, the right and the left bronchi. From the bronchi, bronchioles appear. The primary, the secondary, the tertiary, the terminal. Terminal. After terminal, we have 3 things. Respiratory bronchiole, alveolar duct, and the balloons are the alveolar sac. So here the respiratory tract is ending. Give me a thumbs up. Now, we are talking about the lower respiratory tract, not upper respiratory tract. So what is lower and upper? At the trachea, there is a bifurcation. So all the things above trachea is upper respiratory tract, and all the things below trachea is lower respiratory tract. So I'm talking about COPDs. In COPD, I will teach you 4 diseases now, one by one. I will start with chronic bronchitis, then I will move to emphysema, then I will move to asthma, and then I will move to bronchiectasis. These 4 diseases together known as chronic obstructive pulmonary disease. There is one thing common in all 4. There is obstruction. In the lower respiratory tract, there is obstruction. But I don't know the level of the obstruction. You know, okay. Let me explain you. In chronic bronchitis, the obstruction is in the trachea or the bronchi. The reason for the obstruction is different, but it's in trachea and bronchi, right? So at this level, the obstruction is occurring. In emphysema, the obstruction is occurring at this level, at alveolar sac level, right? At acinus level, right? In asthma, again, the obstruction is at the trachea, right? And in bronchiectasis, the obstruction is at the level of the bronchioles. So the level of the obstruction is different in all 4, and the reason for the obstruction is different in all 4. But common thing is that they have obstruction. They have obstruction. That's why they all are known as chronic obstructive pulmonary disease. Give me a thumbs up. You got it? That is the definition of COPD, the 4 types of COPD I'm going to teach you. By the way, one more thing before starting the next topic. The last 3 things here. What are the last 3 things here? The last 3 things. After terminal bronchiole, there are 3 things I told you. The 3 things after terminal bronchiole. The respiratory bronchiole, alveolar duct, and alveolar duct. Alveolar sac. These 3 things together known as acini. These 3 things together known as acini. And acini is the structural and functional unit of the lung, like glomerulus in the kidney, acinus in the lung. So, okay, yes. So let me start ahead with COPDs. So COPDs, there is obstruction starting from the trachea till the smallest airway. It can be at any level. So you can see the complete tree is drawn in front of you. What I have drawn, the same diagram is drawn. So there are 4 COPDs I am going to teach you, starting with chronic bronchitis, going to emphysema, going to asthma, and going to bronchiectasis. Bronchiectasis. Bronchiolitis is not very important, so I am going to teach you these 4. Am I audible now? Audible, visible now? Audible, is it, the audio is good? Give me a thumbs up. Okay. So I request you to mark the important points in the 4 types of the COPD. Start from chronic bronchitis. So what is the problem in the chronic bronchitis? You know the trachea. The problem here is in the trachea. You know the 4 layers of the trachea? These are the 4 layers of the trachea. Okay, let me draw trachea. This is the lumen of the trachea. So in the lumen, this is the first layer, that is mucosa. This is mucosa, pseudostratified ciliated columnar epithelia. It's a mucosa. The second layer is the submucosa. Okay.
This is the second layer. It's the submucosa. Submucosa. Submucosa contains glands. I'm drawing these. These are the glands. After that, the third layer is the muscularis propria. This is muscularis propria, and the outermost layer is the serosa. Outermost is serosa. You all know these four layers, right? Now, what is the problem? God has given the lungs, the trachea for respiration, but some people don't understand that and they smoke, right? They smoke. So the respiratory tract is not for smoking. If you are smoking, it is giving trouble, it is giving stress to the respiratory tract. So imagine the person is smoking and this is the smoke. The person is a smoker, chronic smoker. Because of the smoke, there is stress over the trachea, the wall of the trachea. So in the morning, I told you the types of the adaptations due to stress: hypertrophy, hyperplasia, dystrophy, metaplasia, dysplasia. Have you remembered? Right. So because of the stress in the submucosa layer, the glands undergo two things: hypertrophy and hyperplasia. So they increase in number, they increase in size. Badi badi bhi ho gayi aur number bhi बढ़ गया. This is the problem because of smoke. So because of smoke, there is hypertrophy and hyperplasia of the glands in the submucosa. This is the problem. You will say, then what is the problem, ma'am, if they are increasing in number and size? The glands form a secretion. Inside our nose, we have a mucus secretion, right? A sticky mucus secretion. The same sticky mucus secretion is present in the entire trachea, in the entire respiratory tract, having the same secretion, right? So glands form this secretion, these glands. If there is abundant of glands, they will form more and more and more and more and more secretion. So the complete lumen is blocked. The complete lumen is blocked by mucus secretion, and that is causing the obstruction. Patient can't inhale. The trachea is filled with the mucus, thick mucus, and he always does like this and he tries to cough to take the mucus out. And when he cough now, there are two type of cough: dry cough and cough with sputum. So here patient have abundant sputum in the cough, because all the secretions, they will come in the sputum, the sticky sputum. So this is the complete thing which you have to understand in chronic bronchitis. Give me a thumbs up. Give me a thumbs up. So this is the thing. So chronic bronchitis. What is chronic bronchitis? What is the definition of the chronic bronchitis? This patient have cough. Is it dry cough? No, no, no. It's a cough with expectoration. It's the cough with the sputum. This patient have cough and most of the days of the year, right? Now, yeah, I'm coming on the read index. Can you see the two diagrams, the two tracheas here? In the two tracheas, the four layers in the wall are shown. This is normal. Here you can see this is normal, and this is chronic bronchitis. We will compare mucosa of both of them, then submucosa of both of them, then muscularis propria, then serosa. We will compare the four layers of both of them. Let's start with mucosa. So normally I can see this is the mucosa here, this is the mucosa here, and this is the mucosa here. This is the mucosa here. Is there any change in mucosa? A little bit. Let me tell you what is the change. In the mucosa, little bit goblet cells are present. Normally only two I can see here, but in chronic bronchitis I can see four. That is, in the mucosa, goblet cells are increased. So it is a type of adaptation only. In the mucosa, the goblet cells are increased. You have to learn goblet cell hyperplasia in the mucosa. The main thing is in the submucosa. See the submucosa here normally, and see the submucosa here. What you can see? Count the glands here. 1, 2, 3, 4, 5, 6. Count the glands here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Number is not important. I can see the increase in size, the increase in number. And because of which the total thickness of the submucosa is increasing. You got my point? So here we take an index that is known as read index. Read, R-E-I-D, read index. It is having a numerator and a denominator. Denominator is total thickness of the submucosa. Total submucosa ki thickness. And numerator is that portion of the submucosa that contains gland. Uski thickness. You got my point? So normally the numerator is this. This portion have glands, na? This portion, see, this portion. And denominator is this. This portion is total. I'm talking about only submucosa, not the complete four walls. So the portion of the submucosa having glands is the numerator. Let's say it's small a, it's small b. So a upon b is the read index. Now, what happens in chronic bronchitis? The total thickness is same, but the portion which contains the gland is increased because of hypertrophy and hyperplasia of the glands. So A increased, B same. So numerator increased, denominator same. So overall read index is increased. You got my point? So say read index increase. समझ में आया? अच्छी बात है. नहीं समझ में आया? No problem, just learn it. Read index is increase in chronic bronchitis. ज़्यादा दिमाग मत लगाओ. Read index is increase. That is the thing. Read index is the numerator and denominator. It is the ratio between the thickness of the submucosa having glands upon the total thickness of the submucosa. Goblet cell hyperplasia is there. So you can understand that is the thing. Here patient have chronic cough. As I have told you, here the complete trachea is filled with the sputum because there is more sputum, more sticky secretion. So patient can't breathe. Since the patient can't breathe, the oxygenated blood is not going to the organs. So organs have deoxygenated blood. So patient look blue because of the cyanosis. Patient have cyanosis. These are known as blue bloater. It's an MCQ. Blue bloater occurs in chronic bronchitis, right? So that is the thing. So can you help me in solving few questions based on that? The first COPD chronic bronchitis we have completed, right? Can you tell me the answer? Everyone participate. What is the correct answer here? What is read index? Read index is useful in which disease? Is it glomerulonephritis, chronic bronchitis, cirrhosis, and MI? It's a very easy question, I guess. It's a baby question. It's chronic bronchitis. Everyone knows that. Read index is what? Can you tell me? Is it increased or decreased in chronic bronchitis or asthma? First, decide the disease. Of course, it is useful in chronic bronchitis, not in asthma. Then decide whether it is increased or decreased. Whether it is increased or decreased, you all are right. You are fantastic students. Yeah, come on. So yes, it is increased in chronic bronchitis. Yes, the correct answer. And this question is repeated multiple times. Maybe a image-based question can also be created beautifully. If someone given me a chance now to set your question paper, I will set a real good question paper to actually judge the knowledge of the student, right? So the question will be easy, it will be simple, it will be judging the knowledge of the students, not the memory of the student. We should judge the knowledge, not the memory ki rectification kitna gaya, wo judge nahi karna chahiye. We should judge ki uska understanding kitna hai, the conceptual thing is what. So that is the concept behind the next. Now, you know, all the exams are replaced by only one single exit exam, that is next. In the next, most of the questions are going to be conceptual, right? Not the learning and facts. So, okay, coming on the next question. Coming on the next topic, it's emphysema, the second type of COPD. Emphysema. What is the problem here? I have told you the last thing is I would like to draw one acinus. The last three things are the acinus. Can you tell me what is the acinus? Can you tell me the three things in the acinus? What are the three things in the acinus? Say yes. What are the three things in the acinus? One is respiratory bronchiole, one is alveolar duct and alveolar sac. So this is a respiratory bronchiole. From the respiratory bronchiole, multiple alveolar ducts are coming out. And from multiple alveolar ducts, multiple alveolar sacs are coming out. Can you see? So this is respiratory bronchiole, this is alveolar duct, and this is alveolar sac. You got my point? So this is diagram of acinus. Does anyone have any confusion? I don't think so, right? Now I'm teaching you emphysema here. You cannot understand emphysema without understanding acinus. It is a disease of acinus. So basically in emphysema, the various portion of the acinus are fusing with each other. I'm repeating again, various portion of the acinus. There is not only one acinus. The lung have millions of acinus. So multiple acinus are fusing with each other and big spaces are formed. Right. So you must ask me, ma'am, which portion of the acinus is fusing with each other? Is it respiratory bronchiole fusing with each other? Is it alveolar duct, alveolar sac? Which portion? So it is different type of emphysema. There are 4 different type of emphysema. In each of them, the different portions are fusing with each other. You got my point? Okay, I will draw all for you. If respiratory bronchiole fuse with each other, only respiratory bronchiole, multiple respiratory bronchiole fuse with each other and they dilate. So this is known as centrilobular emphysema. Give me a thumbs up. Because the respiratory bronchiole is central, na? And the central structure is dilated. That's why known as centrilobular. The central structure is dilated. That's why known as centrilobular, right? If the alveolar sac is fusing with each other, these alveolar sac, and they are forming one big space, big spaces, right? So this is known as paradistal, the paradistal type of emphysema. Distal matlab sabse last structure, paradistal type of emphysema. This is centrilobular, this is paradistal. Give me a thumbs up. You got it. And the third option, all 3 structures are dilated. They are fusing. All the respiratory bronchioles are also dilated, alveolar duct also dilated, alveolar sac. So it is known as pan-acinar. Pan matlab complete. Pan-acinar type of emphysema, the third type, the pan-acinar. And the fourth one is the irregular. Irregular is haphazard. Anything can happen. So the 4 main type of the emphysema. Can you tell me what are the 4 main type of the emphysema? Yes, no one will teach you such minute details. Students used to learn centri, no need to learn here. Come on, everything is visible in front of eyes. You can understand them, right? So the 4 type of emphysema, the first type is centri-acinar, right? The second type is paradistal. The third type is pan-acinar, and last one is irregular. Can you tell me which area is dilated? In centri-acinar, respiratory bronchiole fuse with each other. In paradistal, alveolar sac fuses with each other. In pan-acinar, everything fuses with each other, the three structures, respiratory bronchiole, alveolus, as well as alveolar duct, as well as alveolar sac. Say yes, yes. And in irregular, it's of course irregular. Irregular means irregular. So, okay, now tell me which is the most common among them. Among the four type of emphysema, which is the most common? I will show you the diagrams also. Which is the most common? So technically, irregular is the most common. But it is silent. It is asymptomatic. By silent, I means it's asymptomatic. So most common is irregular, but it's asymptomatic. Among symptomatic, most common is centriacinar. I'm sorry. Among symptomatic, most common is centriacinar. Say yes. You got it? You got it? So these are two important MCQs. The next important MCQs, tell me the trigger for each of them. For centriacinar, the trigger is smoking. It occurs in smokers. It occurs in smokers, right? For pan-acinar, the trigger is alpha-1 antitrypsin deficiency. In these patients, it occurs frequently. In paradistal, the trigger is spontaneous pneumothorax. Spontaneous pneumothorax, it usually occurs in athletes while doing some athletic activity, while some play sports, they just fell down and they have an injury over the chest. So because of the injury, there is spontaneous pneumothorax is occurring, and because of which they can have paradistal type of emphysema. And irregular, the trigger is the scarring. If someone is having chronic scarring like TB or something, they can have this. So learn one trigger. You will get a clue in the question with this trigger. Learn the definition, learn the four types, learn which is most common asymptomatically and which is most common symptomatically. If nothing is mentioned, only most common is asked, go with irregular. If symptomatic most common is asked, go with centriacinar. These are two PYQs, huh? And you should learn the trigger of each of them. I will show you MCQs also, don't worry. Have you got it? So let me finish emphysema now. So what is emphysema? It is a disease of acinus. It is a disease of the acinus, last three structure. It's not a disease of trachea and bronchi like chronic bronchitis. Now, what is the problem? You didn't ask me, ma'am, why the multiple things are fusing with each other. Fusion ka reason kya hai? Now, whether respiratory bronchioles are fusing with each other, or alveolar duct are fusing with each other, or alveolar sac are fusing, but what is the reason of fusion? Why they are fusing with each other at all? You have not asked me this question. Let me tell you. Let me tell you. Imagine this is alveolar sac, this is alveolar sac, and these two are fusing with each other and they are forming one sac, right? This is the thing which is happening in emphysema now. Okay, why they are fusing? In the wall, two types of enzymes are present. In the wall of the respiratory tract, two types of enzyme are present. Protease and antiprotease. Antiprotease, okay? Protease also known as elastase. Elastase, it is also known as trypsin. Trypsin. Antiprotease also known as anti-elastase or antitrypsin. Alpha-1 antitrypsin, one and the same thing. Either you say this, or you say this. They have opposite function. They have opposite function. As the name indicate, protease degrade the protein and antiprotease prevent the degradation of the protein. Normally in my lung, your lung, we are not smoker. I guess you are also not a smoker. So the protease, antiprotease equal and opposite to each other. You know, they balance each other. They balance. So whatever protease, the antiprotease, so there is a balance between the two. So the wall doesn't fuse with each other. But the person who smoke, right? The person who smoke, in that protease increases too much and antiprotease decreases too much. The one who is degrading is increased, the one who is preventing is decreased. So that's why this is the fusion. And this is known as protease antiprotease theory. Give me a thumbs up. Can you see? Beautiful diagram. Smoking. Smoking. Can you see the smoke? Due to the smoke, protease is increasing and antiprotease is decreasing. So they all are fusing with each other and forming big spaces. Give me a thumbs up on this point. Come on. Yes. So this is the reason. Can you see the four types of emphysema? Yes. Here you can see the central structure is dilated. Respiratory bronchiole is dilated. This one is centriacinar. Here you can see the last structure, alveolar sac is dilated. Here it is paraseptal. Here you can see complete thing is dilated. Everything is dilated. This one is pan-acinar and this one is irregular. I guess everyone got it. Yes, I guess everyone got it. Yes. So we have done, yeah, one more important thing. We have done the two diseases till now. Chronic bronchitis and emphysema, right? In chronic bronchitis, the most common complaint patient have cough, right? Cough is more prominent here, cough. In emphysema, the most common complaint is dyspnea. Patient have more common complaint of dyspnea. Both happens in both, but here cough is more prominent, here dyspnea is more prominent. The another important thing is that in chronic bronchitis, it is blue bloater. The patient looks blue because of the cyanosis. In the emphysema, patient is known as pink puffer. There is no cyanosis. Actually, it is a misnomer. मुझे भी अभी समझ में आया, मतलब पेशेंट को पिंक पफर क्यों, मुझे लगता था पेशेंट ज्यादा पिंक हो जाएगा, ज्यादा इरिदमा हो जाएगा. इट्स नॉट लाइक दैट. पेशेंट इज नॉर्मल. एक्चुअली देयर इज नो साइनोसिस. हियर साइनोसिस प्रेजेंट, दैट्स व्हाई ब्लू बफर. Here cyanosis is absent, so patient is normal, not any different color. That's why known as pink puffer. So blue blotter and pink puffer, you have to learn the two names. Say yes, right? So we are done with the two types till now. This thing is different now. The level is different. Chronic bronchitis is a disease of trachea, and emphysema is a disease of acinus. The level is absolutely different. Both are COPDs. The reason is different, and the level is different. Right. So we will do some polls on the emphysema and move on the asthma. The third is the asthma. Give me a thumbs up. We will do some polls. Can you tell me the answer here? Can you tell me the answer here? Give me a minute. What is the correct answer? Emphysema pathologically, its involvement of which level of lung? Is it involvement of bronchi? Involvement of, it's beyond bronchi, beyond terminal bronchiole, beyond respiratory bronchiole, or alveolar sac? Don't rush, don't rush. What is emphysema? So only Rani is correct till now. Okay, Harsha is also correct. Rest all are wrong. Rest all are wrong. Rest all. Okay, Shashi is also correct. Rest all are wrong. Only few students are correct. Read the question correctly, na. I'm asking emphysema is a disease beyond what? Do you understand English? Beyond मतलब किसके आगे की disease को emphysema कहते हैं? You know the complete respiratory tract now. Can you help me in writing that? Okay, start from the nose, nasopharynx, its larynx, its trachea, its bronchi, its primary, secondary, tertiary, and terminal bronchioles. Then respiratory bronchiole, then alveolar duct, and last is alveolar sac. So where is emphysema? Who will tell me? You will say, ma'am, these three things is emphysema. This is acinus. And involvement of acinus is known as emphysema. Okay, I got it. But they are asking beyond what? So the answer of beyond is terminal bronchiole. Beyond terminal bronchiole, we are having these three structures. Beyond. Terminal के आगे के तीन structure. You got my point? So answer will be beyond, that is B. You got my point? Give me a thumbs up, everyone. So there is a trick in the question. The question is easy, but it's tricky. So correct answer is B, not C, not D. Right? Okay. Can we move ahead? Most of you have said C initially, no? Okay. So moving to the next question. Commonest type of emphysema. Don't jump. Tell me the correct answer. Commonest. Which is the most common? Yes, yes, correct. Yeah, correct, Mishab. Correct. So correct answer here is irregular. The most common type of emphysema is irregular. If nothing mentioned, go with irregular. But I'm changing the question. Most common type of symptomatic emphysema. What is your answer now? What is your answer now? I'm changing the question. What is your answer now? So symptomatic one will be centriacinal. The symptomatic one will be centriacinal. Yes. Okay. Can you tell me the answer? Distension of the distant alveoli. I'm asking distant alveoli. Distant alveoli matlab alveolar sac. Which type of emphysema? There is distension of the alveolar sac. Alveolar sac. Yes, it's paraseptal or paradistal, in which alveolar sacs fuses with each other. Right? So that is a thing. Okay. Coming on the next disease, asthma. We all know what is asthma. I'm not defining it. Asthma is a disease of trachea. You know, here see the trachea, it's normal. And here see the trachea. It's the trachea or bronchi undergoes spasm. They are undergoing, I'm sorry, just a second. They are undergoing spasm in response to a antigen. You know, I'm not asthmatic. I don't have this disease. Just suppose I'm a normal individual. So there is pollen grains present in the air or some allergen. Now, allergen is different for different person. For some, it's dust. For some, it's pollen grain. So if dust, pollen grain present in the air, I inhale them. But my trachea and bronchi do not go in spasm in response to that. But there are some persons which are very oversensitive, hypersensitive to certain particular antigen. So just suppose they are very sensitive for the dust or the pollen grain. So when they inhale that particular antigen, na, so as soon as antigen go in the trachea and the trachea and the bronchi undergo spasm. Why the trachea and bronchi is undergoing spasm? Because the trachea and bronchi do not want that particular antigen to go inside. That's why they are undergoing spasm कि तुम अंदर नहीं जा सकते. ठीक है, antigen will not go inside, but air will also not go, and patient will have attack of asthma. Patient can't breathe. Patient is in attack of asthma. Asthma is not a disease which is present continuously. No, it comes, it goes. It comes, it goes. It's an attack. So the attack in pathology is known as paroxysmal. So can I say asthma is a paroxysmal disease? Yes, of course. So asthma is a paroxysmal disease in which between two attacks, patient is absolutely normal. And attacks comes only in response to the allergen. And it's an example of type 1 hypersensitivity, right? You already know the complete hypersensitivity, right? So it's not a disease of acinus. It's again a disease of trachea and bronchi. See, it's normal trachea and bronchi and it's asthmatic trachea and bronchi. Compare the lumen in response to the antigen. Compare the lumen, right? Now, there are three symptoms in a patient of asthma at the time of the attack, not constantly. At the time of the attack, patient have dyspnea. The patient can't breathe. It's like this, like patient can't breathe, patient have attack, that is dyspnea, and it's paroxysmal. I've told you it's an attack, it's not continuous. Patient have cough, patient try to cough and open the airway as a response, so cough is there. And wheezing, wheezing is peculiar sound you can hear while the breathing. So when the airway is narrowed and through a narrowed airway the air is going inside, it creates a sound, so that is known as wheezing. So so this is known as asthma. And usually the attacks subside by itself spontaneously or with the treatment. In the treatment, we give the bronchodilators, in pharmacology, and that can be the treatment. So it comes in the form of the inhalers and pumps. So the patient should always keep the inhalers and pumps with him or her. So the attacks are unpredictable. Anytime they can get the attack, so they should always keep the treatment, the pumps and inhalers with them. It's type 1 hypersensitivity. I already taught you. Yeah, the most important how you will do the diagnosis. So as I've told you, asthma patient cough. When they cough, they have a sputum. Like in chronic bronchitis also, they have more sputum. There is more secretion of the glands. So they have sputum. So ask the person to collect the sputum in a container. Ask the person to collect the sputum in a sterile container and make a slide of this sputum. Mix the sputum with saline. Make the saline suspension of the sputum. Take one drop here, make a smear and watch it under microscope. In the sputum, you will find triple C. C, 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 the three hallmarks of asthma. So that is sputum microscopy, the sputum of an asthma patient. It's triple C. It's triple C. All three are your PYQs. In the sputum of an asthma patient, you will see C, C, and C. What is triple C? What is triple C? You will find Kurtzman spiral. You will find charcoal-laden crystals and you will find triola bodies. You will say, ma'am, in सबका मतलब क्या है? Right? When I was at your place, ना ये सब समझे बोलते इन सबका मतलब क्या? What does it mean? Right? You should understand everything. Okay, let me explain you. So, okay, just a second. Let me draw the respiratory tract, a rough respiratory tract. So this is the nose, nasopharynx, larynx, trachea, and bronchi. I'm interested in this much only. So whenever the patient is coughing, the cough is very vigorous. It's very vigorous. So this is the lining. This is the lining of the trachea and the bronchi. So whenever the patient is coughing vigorously, two things happens. The strip of the respiratory bronchusa, it's just degraded. It's just degenerated and complete strip comes out in the sputum. So that strip is known as Kurtzman spiral. Kurtzman spiral. So it's like a spiral. It's like a spiral. It's like a spiral strip. So complete strip of the respiratory tract epithelium is coming in the sputum. Give me a thumbs up. You got it? What is Kurtzman spiral? Say yes. Say yes. Okay. So number two, individual cells can also get degraded. The respiratory columnar cells, they also get degenerated because of the vigorous cough, and the individual cell can also come in the sputum. That is known as Crayola body. Crayola body. Say yes. So Crayola body also comes. So Kurtzman spiral is the complete strip. Crayola body is single cell. They are getting degraded, degenerated from the respiratory tract epithelium. It is coming in the sputum out and it is contained, it is collected in the container. The third thing is the diamond-shaped crystals, charcoal-laden crystals. Now in the sputum, in asthma patient, abundant of eosinophils are present because of type 1 hypersensitivity. Do you know that? So eosinophils is the hallmark here. Abundant of eosinophils are present. So when abundant of eosinophils are present, inside the sputum, diamond-shaped crystals are formed. Typically, diamond-shaped crystals are formed and they come in the sputum. These are known as charcoal-laden crystals. Charcoal-laden crystals are there. These are diamond-shaped crystals which are present in the sputum. So in the sputum, three things are there. See the diagram. See the diagram. Can you see the diagram? In the diagram, I can see two only here, not all three. First thing, I can see the diamond-shaped crystals here. These diamond-shaped crystals are charcoal-laden crystals. I can see eosinophils. So eosinophils is forming these crystals, number one. And number two, I can see this complete strip. Appreciate the strip. Strip ki strip bahar aa gayi hai. So this strip is known as Kurtzman spiral. Crayola bodies are not shown here. Can we go ahead? Can we go ahead? Yes, yes. So we will do some polls on the asthma, very easy, and move on the last COPD, that is bronchiectasis. So the respiratory system is also over. The important topics are over at least. So can you tell me the answer here? Cruella bodies are seen in. Of course, the answer is asthma. Why I'm asking this question? It's a baby question. I must skip it. Cruella bodies are seen in asthma. But yeah, this question is your PYQ. It's the easiest question. If I set the paper, I will never put this question in your paper. Right? Okay. Charcot-Leyden crystals are found in. Yes, again the answer is asthma. Again, triple C. So question is coming on all C that I want to explain you. And Kochman spiral is seen in. Again, the answer is asthma. So all three C's are important for your MCQs, for image-based questions also and for MCQs also. Moving to the next topic, the last COPD, bronchiectasis. What is bronchiectasis? So in the bronchiectasis, bronchioles are involved. We have how many types of bronchioles? Primary, secondary, tertiary, terminal. And after that, the acinus is there. So these are the 4 levels of the bronchioles. These are involved. They get dilated. That is known as bronchiectasis. So bronchiectasis is the abnormal and irreversible dilatation of the bronchioles. It is a disease of bronchioles, and here also patient have cough. But here the main problem is the infection. Patient have infection, the bacterial infection, because of which the patient have cough and patient have this dilatation. Infection is leading to weakness of the wall, and because it's not smoking related. My point is that it's not due to smoking. It's due to infection. Due to the infection, the wall of the bronchiole become weak. So it become dilated. Can you see here this portion? This portion. So the bronchioles are dilated. Please appreciate the dilatation. Now, based on the shape, it is of 4 types. If the bronchioles are dilated like this, in a circular manner, it's known as secular type. If they are dilated circumferential everywhere, it is known as fusiform type. If they are dilated parallel, it is known as cylindrical, and if multiple small dilatations are there, it's known as varicose. So depending on the shape, they are of 4 type, not very important, but yeah, these are of 4 type. Now in the lung, it's clearly visible. It's more common in the lower half of the lung, less common in the upper half. It's clearly visible in the diagram, right? Learn it. It's common in lower half. It's an important question, important MCQ, right? Now all the bronchioles are dilated. Now this is the gross of a lung. Can you see the gross? Can you see the bronchioles? These all are bronchioles. They are dilated, dilated, dilated. It's looking like a honeycomb. Honeycomb kya hai? Madhumakhi ka chhatta. Have you seen a honeycomb? Right. So this is looking like a honeycomb. This is typically known as honeycomb appearance. It's very important MCQ. So honeycomb appearance is typically seen in bronchiectasis of the lung. Never forget. So ये सारे MCQs हो गए आपके bronchiectasis पे. Now related to the bronchiectasis, there is a very important syndrome known as Carter-Jenner syndrome. Carter-Jenner syndrome is a triad in which one of the thing is bronchiectasis. But along with bronchiectasis, 2 more things occur. So bronchiectasis तो है ही in the bronchioles. Patient को sinusitis भी है. Sinusitis and situs invertus. What do you mean by situs invertus? See, the triad of the Carter-Jenner syndrome. Patient has sinusitis. Can you see the sinus is involved? In the upper respiratory tract, the sinus is involved. Patient have bronchiectasis. The bronchioles are dilated in the lower respiratory tract. The third thing is situs invertus. In human body, some things are left, some are right. Where is the heart? Left or right? Where is your heart? Is it left? Okay, this is the left of the patient. This is the right. Patient is standing in front of me. Okay, I guess, yes, it is left, right. I'm right. So heart is little bit towards the right. The apex of the heart is towards the right, although it is central, but a little bit right. Where is the liver? I guess liver is towards the right. Right, where is the appendix? So we have typical left-right thing in the body. Now, there are some person in which everything is opposite. The heart is on the right, the liver is on the left. Yes, it happens. The disease is known as situs invertus. Everything is opposite, inverted. The laterality is inverted. The left is right, the right is left, right? And it is asymptomatic condition. Okay. So this is known as situs invertus, and this is situs invertus. So dextrocardia is one of the feature of situs invertus. Dextro matlab right heart. Dextrocardia means right heart. The heart is on the right side. So dextrocardia, not only dextrocardia, the liver is on the left. Everything is opposite. So dextrocardia is one of the finding of the situs invertus. So can you see in this X-ray? Beautiful X-ray. So in this X-ray, where is the heart? Just a second, I can't see yours, this thing, chat. Okay, it's open. So where is the heart? This is the heart. Can you see the heart? This is the, yes, this. So I guess this is towards the which side? The heart is tilted towards which side? This is the right now. You can see this is the right, this is the left. X-ray देखना तो आता होगा ना, right, left. So this is dextrocardia. So it is indicating its situs invertus. So this triad is known as Carter-Jenner syndrome. Yes, So cartagener syndrome, never forget, cartagener. So we will do some polls based on this and move to the next topic. Can you tell me the answer? Can you tell me the answer? Bronchiectasis means what? Is it inflammation of the bronchi, dilatation of the bronchi, or cavitation of the bronchi? I will go with dilatation. I will go with dilatation. Can we go ahead? Can we go ahead? Yeah, here wrong answer is given. I will go with dilatation. Bronchiectasis most commonly occurs in which lobe? In which lobe? Is it upper lobe, middle lobe, or lower lobe? In which lobe it occurs? I've told you it is more common in the lower half, lower lobe. So go with lower lobe, number one, and learn it's more common on the left side. I forgot to tell you it's more common on the left side. So left lower lobe is the most common location. Okay. What is the true? All of the following are true about cartagener syndrome except which is not happens in cartagener syndrome. Can you tell me the answer? Now here you will get confused. Okay, first you tell me the answer. See, many of you are saying B also now. I forgot to tell you that infertility is also a feature of cartagener syndrome. I can explain. Basically, you didn't ask me, ma'am, what is the main problem in cartagener syndrome? Why these three things are occurring together? What is the problem in cartagener? What is the problem in cartagener syndrome? Have you heard about the word cilia? We have cilia in our body. Cilia matlab हिंदी में कहूं तो झाड़ू झाड़ू देखा है घर पे वी हैव अ झाड़ू एट अवर होम ना वी क्लीन अवर होम्स विद झाड़ू राइट सो द सीलिया तो द झाड़ू ऑफ द बॉडी इज द सीलिया राइट सो झाड़ू कैसे निकालते हैं वी टेक द डस्ट आउट ऑफ द हाउस और इनसाइड द हाउस व्हेन यू बीट योर झाड़ू सो यू टेक द डस्ट आउट ऑफ योर हाउस so you beat in that particular direction. You don't beat reverse. You don't take the outside dust inside. No, we never do so. So in the same way, we have cilia over the cell or in certain organs. Cilia beat in particular direction. This is known as beating of the cilia. So there is a particular direction of the beating. So in the entire respiratory tract, cilia beats towards outside. So take the pathogen from inside to outside, dust from inside to outside. So cilia is a very important organ. For the functionality, for the motility, for the beating of the cilia, it have a protein inside that. The name of the protein, I'm forgetting. What is the name of that protein which is mutated here in cartagener syndrome? The name of that particular protein, I'm just forgetting the name. It's flagellin protein. Exactly. Is it? No. The name of the protein is from, yeah, dynin. Very good, very good. It's dynin protein. The flagella, the cilia have a protein, it's dynin protein. That protein is mutated. The gene for that protein is mutated. The dynin gene. It is mutated. So cilia is immobile. Cilia is not beating. That is the main problem in cartagener syndrome. Now, since the cilia is not doing this motility, so that's why patient have sinusitis, the respiratory tract infection. That's why the patient has bronchiectasis. And situs inversus is not related to the cilia, but it is a part of the syndrome. You can understand that. Now, since cilia do not move, the male as well as female, both are infertile. They cannot conceive. They cannot have baby. They cannot conceive. They are infertile. Can you explain the reason? How cilia is related to the fertility? Is for fertility cilia is required? Yes, of course. It is required in males also, females also. Males have sperms. The sperm have a tail. The tail of a sperm is the cilia actually. For the motility of the sperm, the dynin protein is required. If the dynin is mutated, the tail of the sperm will not work. The sperm is immobile and that's why the male is infertile. Chalo, male mein to samajh mein aa gaya. The male is infertile because the tail of the sperm is not functional. Why the females are infertile here? Why cilia is required for female also for fertility? Females don't have sperm. Females have ova and ova don't have tail. Then what? Okay. For that I have to draw this thing. Reproductive system of a female genital tract. How I should draw? Yes, this is the uterus, this is the cervix, this is the vagina. These are the two ovaries. These are the fallopian tubes. Okay, these are the fimbriae of the fallopian tubes. Okay, where is the ova? Ova is secreted from one of the ovary either right or left. And where is the sperm? The sperm is coming from the sexual intercourse from the vagina. It will move because it has tail, so it move upwards. It comes here. Right, the sperm is coming. How does the ova is coming inside the reproductive tract? So ova is coming inside the reproductive tract from this fimbriae. The fallopian tube have cilia. The fallopian tube have cilia and it beats the ova towards the sperm. So here fertilization take place. So for male also the tail requires the cilia, requires dynin protein, and for female also the fallopian tube have cilia. So imagine either the female don't have cilia or the male don't have cilia. They both are infertile. So in cartagener syndrome, both are infertile, although infertility is not included in triad. Triad में मैं तीन ही चीजें लूंगी. I will include sinusitis, I will include bronchiectasis, and I will include dextrocardia or situs inversus, whatever you say. Infertility is not included in triad, but it happens. It happens. I guess you got it. Give me a thumbs up if you got it. Can I move to the next question? Same question again. Now you will answer it correctly. I guess you must. Okay. Now everyone answer it. Can you answer it now? True about Carter-Jenner syndrome except. So can you tell me which condition do not occur in Carter-Jenner syndrome? So dextrocardia happens, bronchiectasis happens, infertility also happens, but no way, mental retardation is not a feature of Carter-Jenner syndrome. So now everyone will be right. Yes, infertility is not included in triad, but it happens. So you know, you should have a detailed knowledge of everything. Detailed knowledge. If you have detailed knowledge, किसी से डरने की जरूरत नहीं है. किसी से कुछ भी आ जाए, you can rock. You can rock. Again, for that you should build your concepts in all subjects. Okay, moving to the next question. Carter-Jenner syndrome increases the risk of what? So is it bronchitis, bronchiolitis, bronchiectasis, or tracheitis? What does it include? So don't get confused. It's bronchiectasis. In the triad, bronchiectasis is coming now. Go with C. Go with C. Right? Okay. The next topic is the pneumonias. The next in the respiratory tract, a small little bit. I will not take the detail. A little bit about the pneumonias on which MCQs can be asked. Can you define pneumonia for me? What is the level of the pneumonia? Pneumonia is inflammation. It's inflammation. It's not obstruction. COPDs are over. The 4 COPDs I have explained you. It's not obstruction. It's inflammation. But inflammation of what? Pneumonia is inflammation of trachea, ki bronchi, ki bronchiole, ki terminal bronchiole, ki acinus. So yes, acinus. So inflammation of the acinus is pneumonia. So pneumonia, again a disease of acinus. You should know the level of all respiratory tract disease. There is a complete big tree now. You should know the level. So pneumonia is inflammation of the acinus. ठीक है? Yes. Of parenchyma, don't say parenchyma, Sashi. Yeah, of course it's parenchyma, but I'm not asking the parenchyma. I'm asking the exact level. This all constitute the parenchyma, na? So don't be non-specific. Be specific in your answer. In the parenchyma, what is the level? The level is the acinus. You got my point? Yes. So let me classify pneumonia. We classify pneumonia by 3 things. The first, depending on the anatomical region of the lung. So, you know what is the lobe and what is the lobule? In the lung, we have lobes. In the lung, we have lobules. Right? And in the lung, we have interstitium. How should I explain you all these things? When the lobe is involved, it's lobar pneumonia. When the lobule is involved, it's lobular pneumonia. And when the space between the 2 cells, interstitium is involved, it's interstitial pneumonia. So based on the anatomical location, this is the classification. Now, what is causing infection? If there is an inflammation, there should be an infection. The bacteria is causing, the virus is causing, or fungus. Others में fungus आएगा. Fungus is causing. So there are 3 types of pneumonias: bacterial, viral, fungal. Okay, the third type of classification based on the clinical settings. Whether the pneumonia is occurring in the community, that is community acquired pneumonia, CAP. Whether the pneumonia is occurring in hospital. In hospital, there are high chances of having pneumonia. It's an infectious place now. It's known as nosocomial pneumonia. Or on ventilator, there are high chances of pneumonia. It's known as VAP, ventilator associated pneumonia. So these are the classifications. Anyways, let me compile the 2 classifications. Based on the anatomy, how many types of pneumonias are there, and based on organism, how many types of pneumonia are there. Here it's of 3 types: lobar, lobular, and interstitial. Right? Lobular is also known as bronchopneumonia. Broncho, right? You may be knowing that. Organisms, it is 3 types: bacteria, virus, and fungus. Can you compile the 2? Can you compile the 2? I will do for that. Bacterial causes lobar as well as lobular. Bacterial causes 2 types of pneumonia, lobar as well as lobular. But viruses and fungus, the viruses and fungus, both of them, they causes interstitial pneumonia. Interstitial pneumonia is known as atypical pneumonia. I guess you may be knowing that. Say yes. Can we go ahead? Can we go ahead? So bacterial causes lobar as well as lobular, but viral and fungal causes interstitial pneumonia or atypical pneumonia. So what is the difference between lobar and lobular pneumonia, which is caused by the bacteria? In lobar pneumonia, lobes are involved, of course. And in lobular pneumonia, lobules are. What is lobe and lobule? Itna pata hoga na. You may be knowing that. What is a lobe and lobule? Okay. The right lung have 3 lobes: upper, middle, lower. These are the lobe. Lobule nahi hai, ye lobe hai. And left lung have only 2 lobes, upper and lower. ठीक है? So this is lobe. Now where is the lobule? Lobule कहाँ है? Lobule कहाँ है? So I told you now, from the terminal bronchiole, respiratory bronchioles arises. From the respiratory bronchiole, alveolar duct arises, and from alveolar duct, alveolar sac is arising, right? So from respiratory bronchiole, multiple alveolar respiratory bronchioles are, from one respiratory bronchiole, multiple alveolar ducts are arising. From one alveolar duct, multiple alveolar. So you know, from one there are multiple. From one there are multiple. So if I take one terminal bronchiole, so all the regions which are formed from that, that is one lobule. Just suppose here is the one terminal bronchiole. अब इसमें से multiple respiratory drug bronchiole यहाँ पे गए, उनमें से multiple alveolar duct यहाँ पे गए in each of them, और उनमें से multiple alveolar sac यहाँ पे गए. So this all portion is constituting one lobule. So lobule is not continuous, it is patchy. Lobe is continuous. This is continuous lobe. This is a continuous lobe. This is a continuous lobe. But lobule is patchy. Lobule is patchy. Give me a thumbs up if you got it. I tried hard. I tried hard. So what is a lobe? What is a lobule? You got it? Yes. So you can see here, these are the three lobes which are continuous. And lobule is patchy. This is a lobule. Can you see? It's patchy. So when lobar pneumonia occurs, consolidation occurs continuously in one of pura ka pura lobe gaya. The complete lobe is gone. It is consolidated. It is infected. It is having exudate in that. You got my point. So it is. You can say the continuous consolidation is there. But in lobular pneumonia, the consolidation is patchy, right? In viral pneumonias also, like we have COVID now, we have done numerous X-rays in our hospital during COVID. So I also used to see the X-rays while reporting this thing for the COVID, right? So in the X-rays, it was a patchy consolidation. The viral consolidation is also patchy. No? So it was typical lobular, the patchy one. Can you see the consolidation? You can see it's continuous. It's lobar pneumonia. And this one is patchy. Patchy. I'm using the word patchy because one lobule is involved, not one lobe. Here one lobe is involved. Here one lobule is involved. So lobular is bronchopneumonia. This one is patchy. So based on the gross, you can identify. Can you see? These are the real diagrams. Can you see this one? The complete lobe is involved. It's continuous. It diffuse. Use the word diffuse. The consolidation is diffuse. So say this one is lobar. This one is lobar. And here I can see patchy, like typical COVID, right? It's patchy. It's lobular. It's lobular or broncho, right? So based on the image-based questions are very common on the lobar and lobular. Okay, let me come on the microscopy directly. Let me come on the microscopy. Lobar and lobular. Lobar is a big one. It is of 4 types. There are 4 phases in lobar. You may be knowing, you may have heard the 4 phases: stage of congestion, red hepatization, gray hepatization, and resolution, right? So these are the 4 stages. Now don't go in the detailed microscopy, I can skip. Now only thing I would like to explain here is the hepatization. तो बोलो मैम लंग में हेपेटाइटिस, यू नो व्हेन आई वाज इन सेकंड प्रॉफ ना आई गॉट कंफ्यूज, हेपेटाइजेशन मतलब तो लीवर होता है ना, हेपेटाइटिस अकर्स इन लीवर. We are studying pneumonia in the lung. Why liver is coming inside the lung? That was my question to my professor. That why you are saying it is hepatization? Hepatization means liver, na? And you are saying inside the lung there is liver. Matlab, what does it mean? So yes, the answer is that. Have you seen the lung in a cadaver? It's spongy. And have you seen the liver in a cadaver? It's stony hard. So the lung is spongy normally, and the liver is stony hard. You may know that. Here in pneumonia, the lung is like liver. Lung is not liver. The lung is like liver. That is, sponginess of the lung is gone and it become hard like a liver. That's why the term hepatization is used. And red and gray is the color given to them. So red hepatization, gray hepatization. Everything have a reason. If you know the reason, the things are like, you know, they are very easy. So red and gray hepatization, you must understand, right? These are the 4 phases. I must skip them right now. Okay. Okay, so that is about the pneumonia, the important points about the pneumonia, right? What else you want from my side now? Because the time is limited. If you wish, I can share a PPT with you. I can share a PPT with you, which contains the important mnemonics of entire pathology. Just a second. Yeah, I'm sorry. Important mnemonics. What do you mean by important mnemonics? In pathology, we are having various bodies. You know, ascoid body, ye body, Ashkoff body, multiple bodies are there, you know, multiple bodies. So I'm having a table of all bodies compiled at one place. There are various named cells in pathology. So I have compiled all the cells at one place. There are various types of stains in entire pathology. I have compiled all the stains at one place. So if you want that PDF, I can share. There is nothing to understand in that PDF that I read and you learn. You just have to go through that PDF. That many MCQs, there are high probability you will get from those lists. right? So I'm having many lists with me, only list, and few mnemonics are there in the end. So I can share that PDF rather on this group only. On this group means in the YouTube only, I will share the PDF and pin that after the session. So after what I have taught you, you can read that PDF, and that will be sufficient for the revision. And if I get, I would like to end now basically. So if I get further lectures, so I would like to cover some more important topics, or I would like to cover PYQs. My genuine advice for all, you all are FMG students, FMG aspirants. So if you all are FMG aspirants, my genuine advice to all of you, solve your PYQs of last 3 years. At means 6 papers, at least 6 papers. You should solve it completely. So when you solve it, how do you solve a paper? You take the paper, you read the question, you see the correct answer. If you are correct, you just move ahead. If you are wrong, you just read the explanation. No, don't solve like that. So whenever you are solving your paper, you get 25 questions from the pathology, right? Let's talk about pathology. So these are not 25 questions, these are 25 topics. You just read those 25 topics thoroughly. The exact question will not be repeated. Just suppose the question is from hypersensitivity, which of the following is an example of type 1, type 2, whatever. So the exact question will not come. But yeah, hypersensitivity is an important topic. Maybe this time question on type 1, this year question on type 4, type 3. So your topic should be perfect. So from 6 papers, at least from 6 papers, take 25 topics from each paper in pathology. Many of them will be common because hypersensitivity comes every year, graft come every year. You know, there are many topics which are repeatedly asked in your exam. So 25 into 6, I guess there will be more than 150 topics you will be having, or 300, how much? So you will be having those much of topics with you. You got my point? So you are having 150 topics with you, not questions, topics. In the same way you do forever. So, you know, you expertise on those topics. Now, there is high probability that at least 30 to 40% of them will be repeated. The repeat rate is only this one, not 100%. 100% is not repeated. But yeah, 30 to 40% to sahi ho jayenge na, at least. Lekin if you remember only question, na, nothing is going to repeat. Mind my words, only 5 or 10% is going to be repeated. So don't learn question. You understand the topic. You understand the topic, right? I will share the notes here only on the group, on this YouTube channel, on this video only, and I will pin that. Anything else you want to ask regarding your sessions or everything? Anything else? Do you have any other query? So pathology is a very easy subject and high scoring subject, I must say. You have to score 50%. You should have a strategy for that. You should have at least 50% you have to score. So at least target for 70 or 80%. If you target SONA, we never reach our target. It's human tendency. If you target 80, you will reach 50. If you target 50, you will reach 30 or 40. Don't just target 50. So at least try to target 80 to 100. You will reach definitely 50, right? For that, you have to cover all the subjects. Genuine another advice, don't leave any subject. At least cover all 19. What you people do now, ma'am, ophthalm is a small subject, derma is a small subject, or in medicine, I'm skipping this system. Pura topic kabhi nahi chhodna, pura subject kabhi nahi chhodna. Never leave any subject untouched. At least touch. If you don't have time, na, at least do what I have told you, na, pick out the topics. Only do on those topics which are asked in the PYQs. Don't do the complete subject. Even not in pathology, I'm asking so. Do the topics which are asked repeatedly in PYQs. I try to cover maximum of them in this session, but of course, due to the limitation of time, I cannot cover 150 topics in one day, no? But I tried best. I have tried to cover maximum of them. Now, if you go through, na, maximum of them are already covered. But even if some are remaining, you have to do by yourself. Even if you have any doubt, you can ask me your queries anytime. Thank you so much for being with me and giving your precious time to me. I would like to wish you all the best for your exam, and I want all of you to get selected, to get your license pass. And this is not the end. You know, after FMG, it's not the end. Just yeah, we have got the license. Of course, it's just a licensing exam. After that, your main journey will start. So some of you will go in the PLAB, some of you will go in USMLE, some of you will appear in INICT, NEET PG. You know. So you will divide everywhere, and you will rock in this world, you will shine in this world. We all are doctors, we serve for humanity, and I must say it is the most noble, humble, the best profession I find in this world, to serve the humanity. You know, to help people at their most vulnerable time is a privilege, and this privilege is given to us by the God. Yes or no? We are helping the people at their vulnerable time, when they are most vulnerable, when they are most in, you know, they are sick, they are not good, they are not feeling well. At that time, we are helping them. It's the most privilege. It is our privilege. And you must study for that. You should have a motto for your study. You should have a motive. why you are studying. So always keep your motive in your mind, be positive, be optimistic, never think कि नहीं हुआ तो क्या. Don't even have this thought in your mind, not even a single time. अरे होगा 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 करके रहेंगे, ये thought होना चाहिए कि we will do, we will rock. ठीक है. So this is the only thing I must say and I must end the session. Thank you. Bye bye. Study hard. All the best. I'm ending the session. Bye bye.